So hi guys, I hope I'm audible and visible to you properly. Just give me a thumbs up if I'm audible and visible. Hello everyone. Good evening to the screen. And today we are here to talk to you about and we are going to revise the general surgery. So just let me know if I'm general surgery. So the stream we has started around 8 o'clock and we will continue till around 1 a.m. and I'll try to discuss most important 35 topics with you guys, and these are not just I've put on the questions, and these are not just the questions. We are going to discuss that particular topic in detail. So yeah, that's what you're going to do. So let's start. Okay, one thing which I want from you guys is that I want your complete participation. I want your participation. I want you to kind of put your answers in the comment box and in the live chat and everything. I do want that from you guys. Okay, I'm not audible. I hope I'm audible, right? I hope I'm audible. Hello. Yeah. Okay. Everything is kind of set now. Let's kind of okay. Let's kind of start, and let's kind of do that. Okay. So the first question is there in front of you guys. Can you please help me with this? So there's a 49-year-old lady which is presenting to you with the mass in the left breast. Okay. Now the mass was basically 4.5 centimeters. Was larger than 4.5 centimeters, and there is an ipsilateral mobile axillary lymph node which was present on examination. What is the staging of the mass in this particular patient? Okay, now this is a pretty simple question, pretty straightforward question, but this is based on the TNM classification of the breast. I understand that it's a pretty straightforward question, but let's try to kind of revise the TNM staging of the breast. So there are at least two stagings which you should know by and large, like by heart, in the surgery. So what are these two particular staging systems? Breast and head and neck. These two staging systems you should know kind of in and out. Okay. Okay. So can you please help me with this, guys? What is the answer? Yeah, please put your answers on the comment box. What is it? Is it like A, that is C, T3N1M0, or T4N1M0, or T4 whatever? So yeah, can you please help me? What is the answer? Answer is okay. So the answer to this particular question, you're saying that it is T3N1M0. Okay, so yes, it is T3N1M0. Absolutely right, guys. Okay, so what is it? It is kind of T3N1M0. Okay, so what you need to understand about this, let's kind of talk about the TNM staging. So in the TNM staging of the breast, what you need to understand over here, that okay, frankly that answer is okay. So let's kind of talk about it. So we have the T stage. So what is this T stage of the breast, guys? The T stage of the breast is, in the T1, what is there? There is a mass which is less than 2 centimeters in size. T2 is a mass which is basically 2 to 5 centimeter in size, and then T3 is a mass which is more than 5 centimeter in size. Okay, so yes, so what you need to understand here, you have a T1, T2 and T3. Everybody's okay with this? What about the T4? What about the T4? T4 is divided into T4A, T4B, T4C and T4D. Okay, so what you need to understand over here is that okay, so many students are getting confused whether T4A is involvement of the chest wall or the skin or something like that. So can you please help me with this? What is T4A? T4A is involvement of chest wall or involvement of the skin. So please try to understand, whenever we screw up in our life, the first person whom you should kind of blame is yourself. So in this manner, you can remember that T4A is what? It is involvement. It is involvement of the chest wall. Okay, what is it? It is involvement of the chest wall. Okay, and what is T4B? T4B is involvement of the skin. Okay, but if I ask you which is not included, or rather if I ask you what is a part of a chest wall, okay, so which structures, if at all they are involved, we will say that the chest wall is being involved. This is a very important stuff. Okay, so if at all, let's say there is involvement of the ribs, or there's an involvement of an intercostal muscle, or if at all there is an involvement of the serratus anterior muscle. Okay, so all these three are basically considered as involvement of the chest wall. Okay, so ribs, intercostal muscle, and the serratus anterior muscle. What is not considered to be a part of the chest wall? So please try to understand, it is pectoralis major, and pectoralis minor. This is not considered to be a part of the chest wall. It is not considered to be a part of the chest wall. So if at all they say that, you know what, there's a tumor which is involving the pectoralis major or the pectoralis minor, that is not true. Okay, so that is not the kind of involvement of the chest wall. Okay, I hope you have understood this point. What about the skin? In the skin, what has to be mentioned in your question? So it is ulceration, or let's say a nodule, satellite nodule, okay, or Pau de orange appearance. That is your the skin which is appearing like your kind of yeah, so it is like a peel appearance. Okay, so orange peel appearance, that is what is called as a Pau de orange. What is not considered to be a part of it? So let's say if at all they said puckering, okay, puckering and dimpling, it is not considered to be a part of the skin involvement. Okay, now what is T4C? T4C is involvement of both, that is skin as well as the chest wall. That is what is T4C. T4C is skin plus the chest wall. And what about T4D? T4D is inflammatory breast cancer. Okay, what is it? It is inflammatory breast cancer. Okay, so this is what is T4D. Okay, so this is what is the T stage which you have in the patients with the kind of a breast cancer. I'm pretty sure that most of you guys know that, but for those of you who are kind of struggling with remembering this, please revise with me. So what are the T stages? T1 is less than 2 centimeters, T2 is 2 to 5 centimeters, T3 is more than 5 centimeters. What is T4? T4 is divided into A, B, C, and D. Okay, so what is A? A is basically your involvement of the chest wall. Okay, so what is included in the chest wall? So ribs, intercostal muscles, and the serratus anterior muscle, that is what is involvement of the chest wall. Pectoralis major and minor, that is not involvement of the chest wall. What about the skin? In the skin, there is ulceration, there is nodule, there is what you call as Pau de orange appearance. All these are considered to be a part of the involvement of the skin. Okay, then what is not included? Puckering and the dimpling. Why? Because they are involvement of the Cooper's ligament. Because of the involvement of the Cooper's ligament, what happens? The skin basically becomes puckered and dimpled and all those particular stuff, right? Now, what about T4C? T4C is involvement of the chest wall plus the skin, and T4D is inflammatory breast cancer. Okay, it is inflammatory breast cancer. Okay, now if I go back to this particular question, it's slight error is there, because here it has written larger than 4.5 centimeters. That is factually wrong, because over here there is nothing like a like T2, so it should be, let's say, 5.5 centimeters. Probably it is a whatever the typing error over here or something like that. Okay, so I hope you have understood this point. Here it should be 5.5 centimeters, because 4.5 centimeters will become T2. That is not there. Okay, now I will talk to you about the lymph nodes first. Okay, so what we are going to cover? We are going to talk about the lymph nodes. Okay, so lymph nodal involvement, that is what we are going to talk about now. Now in the lymph nodes involvement, what do we have? We have lymph node N1, then we have N2A, B, and C. Lymph node N2A and N2B, and what do we have? We have N3A, B, and C. Okay, so what is N1? N1 is ipsilateral mobile axillary lymph node. So what is this? This is ipsilateral mobile axillary group of lymph nodes. Axillary group of lymph node. Okay, what is N2A? In the N2A, what you have, again, it is ipsilateral. It is again axillary, but it is matted. It is matted or fixed. Okay, so what is this? It is matted or fixed. I hope you have been able to understand this, but this is what is your ipsilateral axillary matted or the fixed group of lymph nodes. Then what do we have? N2B. What is there in the N2B? Here there is internal mammary group of lymph node without axillary. Okay, without the axillary lymph nodal enlargement. Okay, so axillary lymph nodes are not involved, but what you have is that okay, so what you need to understand, it is basically a mobile like a matted axillary group of lymph nodes without the axillary group of lymph nodes involvement. Then what do we have? We have N3A. In the N3A, what is there? It is infraclavicular. Okay, infraclavicular. What is N3B? This is axillary plus the mammary group of lymph nodes. And what about N3C? This is supraclavicular. Supraclavicular. Okay, so I hope you have understood. This is what is the end stage of the patients with a breast cancer. So let me just revise it with you guys again. So please repeat after me. What is N1? N1 means ipsilateral, on the same side, but then what you call as a mobile axillary group of lymph nodes. What is N2? N2 is divided into N2A and N2B. What is N2A? It is ipsilateral axillary, but it is fixed or matted. Okay, matted means that, so why does these particular things happen? If at all there is an extra kind of like the cortex of the lymph node has been breached. So if at all the cortex has been breached, it is going to get kind of like it's going to become fixed. Okay, so that is what you need to understand about that. Okay, so matted or the fixed basically says that you know what, the tumor has spread beyond the cortex of the lymph nodes. Then what is N2B? Axillary nodes are not present, only the internal mammary group of lymph nodes are present. Then what do we have? N3. N3 is divided into A, B, and C. What is A? A is infraclavicular, B is axillary plus the internal mammary, N3, C is basically supraclavicular. Okay, I hope you are able to understand this particular point. So this is what you need to understand about the lymph nodal metastasis in the patients with the breast cancer. Okay, I hope you have understood this point, right? Got it? Right? So this is all about what you call as the TNM staging of the breast cancer. Now the last thing which I want to mention over here is, what is this Y? The small y stands for what? So let's say if at all, and what is this C? Okay, so we have C and we have small y. So C basically stands for clinical. So clinical means that you try to palpate and there was no lymph node present. Okay, that's what is a clinical examination. But maybe when you did a sentinel lymph node biopsy and when you kind of did actual lymph node dissection, the lymph nodes came out to be positive. So that is what is going to be P, that is pathological staging of the breast cancer. But here what we are trying to talk to you about is a clinical staging. What is this Y? Y is after giving the neoadjuvant therapy. Okay, so this has been asked to you in the FMGE and the NEET PG both. What you need to understand, why is basically after giving the neoadjuvant therapy. So when do you kind of give that? So let's say if at all you are dealing with a patient with a locally advanced breast cancer. Okay, so if at all you're dealing with a patient with a locally advanced breast cancer, what you give? You give a neoadjuvant therapy. What is this neoadjuvant therapy? Okay, so let's also build some concept over here. What is the neoadjuvant therapy? Neoadjuvant therapy is a therapy which you give before the definitive surgery. So how does it help? It basically helps in a way that it reduces the size of that particular cancer. Okay, so earlier, which was let's say locally advanced, after giving a chemotherapy, if it all become localized, now you can kind of operate on these particular patients. So it basically downstages the tumor. You understand my point? So after completing the neoadjuvant course of the chemotherapy, you again do the TNM staging, and that is what is referred to as your YTNM, small y TNM staging. Okay, I hope you have understood this particular point. These two things have been asked, so please do remember that. Okay, I hope you have understood this point. Okay, now let us talk about the next question. Okay, so that is about the TNM staging of the breast cancer. Pretty simple, I understand that, but I hope you have kind of recollected and kind of learned again with me. So in the next session, which I'm going to have on 8, I'll cover with you the head and neck TNM staging, because these two are the most important TNM stagings in the surgery according to me. Okay, now quickly guys, please tell me the answer to this particular question. Management of a renal cell carcinoma less than 4 centimeters in size is what? Is it like a radical nephrectomy, partial nephrectomy, chemotherapy, or the surgery followed by the chemotherapy? So what is the answer over here? It is partial nephrectomy. Yes, absolutely right, guys. Okay, so first let us try to understand what is the difference between, let's say, the partial nephrectomy and the what you call as a radical nephrectomy. So let's say if at all there is a patient who is having a renal tumor. Okay, so I'm drawing 2 kidneys over here, and I am basically having so let's say somebody is having a tumor. Okay, tumor in this particular patient. Okay, so there is a tumor in this particular patient, right? So if at all, let's say I want to operate on this particular first patient, what I can do, I can just remove this particular part along with the tumor. Along with this, I can just remove it, and this is what is referred to as your partial nephrectomy. Partial nephrectomy. Okay, so would you prefer to go ahead with the partial nephrectomy or a total radical nephrectomy? In the radical nephrectomy, what you're removing? We're removing the entire kidney along with the upper part of the ureter, along with the upper part of the ureter. So this entire thing is kind of removed in your radical nephrectomy. In the radical nephrectomy. Okay, so why would you prefer to get a partial nephrectomy? Because obviously kidney has a very, very important role to play in our body, and it is always good to kind of preserve the renal parenchyma. That's what is kind of ideal thing, right? But you cannot do that in every patient. So this particular question was trying to ask you, the management of a renal mass less than 4 centimeters is what? It is partial nephrectomy. So at your level, yes, you can kind of understand that. That is, this less than 4 centimeters is also referred to as your small renal mass. Okay, small renal mass. Okay, so it's also called as a small renal mass, and for that what you can perform is a partial nephrectomy. But in the real life, in the idealistic scenario, this is not how we kind of actually operate. So you will only tell me the answer. Okay, so you will only tell me what is the kind of a thing. Okay, so let's say again I draw 2 kidneys over here. Okay, now I'm trying to tell you that both these particular patients are having a kind of a tumor of the size 5 centimeters, or let's say 6 centimeters, something like that. So this is a tumor which is present in the first kidney, and this is a tumor which is basically present in the second kidney. Okay, so are you understanding my point? So yeah, these are the 2 tumors which are basically present. Both are 6 centimeters in size. Now can you please tell me, guys, in the first kidney, can you perform a partial nephrectomy? I hope you are saying yes, right? So it is not just the size of the tumor, it is also about the complexity of the tumor, whether your tumor is basically predominantly peripherally situated or the centrally situated or something like that. There are too many things which kind of go into it. But yeah, I hope you have understood that size is not a kind of a thing. So according to the latest guidelines, they have said that up to 7 centimeters you can perform a partial nephrectomy. Okay, according to the latest guidelines, they have said that. But for you, just remember, small renal mass less than 4 centimeters, you have to perform a partial nephrectomy. But deep down, you know that it is not the size of the tumor, it is the complexity of the tumor. So let's say if at all there is a very small tumor, but it is basically involving the renal artery or something like that, again you will not be able to perform a partial nephrectomy. Am I making some sense to you guys? I hope I am, right? So this is what you need to understand about this, right? Okay, right. Now this is just about the mass, but what we'll do is we'll quickly kind of summarize the important things about the renal cell carcinoma. Okay, so let's kind of summarize the important things about the renal cell cancer. But for this, as usual, what I will need your support. I want you to kind of put whatever I'm trying to ask you, I want you to put the answers of that in the comment box. Okay, so I hope you will kind of cooperate with me, right? So the first thing which I'm trying to ask you is that what is the most common type of your renal cell cancer? So can you please tell me what is the most common type of the renal cell cancer? So the most common type of the renal cell cancer is clear cell carcinoma. Okay, so clear cell type of renal cell carcinoma. If I ask you, this is associated with which genetic mutation? So please try to understand this clear cell type of the renal cell carcinoma. This is the one which is associated with the VHL gene mutation. And quickly, can you tell me what is the chromosome number of this VHL gene? This is chromosome 3p. Okay, so 3. Okay, chromosome 3 is the kind of location of your VHL, von Hippel-Lindau gene mutation. Okay, so this is the most common type. Now there another subtype which you have is a papillary carcinoma. Okay, what you have is a papillary carcinoma of papillary type of a renal cell carcinoma. So what are the characteristic things about the papillary type of the renal cell carcinoma which you need to remember? So if at all they ask you that, important, again very, very important thing, if they ask you that what is the most common type of renal cell cancer which can develop in the acquired renal cystic disease in patients with long term hemodialysis. Okay, are you understand my point? So what is the cancer which is occurring in the patients with a long-term hemodialysis, acquired cystic renal disease in the patients with a long-term hemodialysis? The answer over here is what? Papillary type of a renal cell cancer. Okay, papillary type of a renal cell cancer. And as many of you guys have already told me that this is the one which is having a presence of samoma bodies. Okay, samoma bodies are the ones which are basically present in the papillary type of a renal cell cancer. Okay, I hope you have understood this particular point. Now this clear cell and the papillary cell cancer, these are the ones which are arising from the proximal convoluted tubule, PCT. Okay, I hope you have understood this particular point, right? Then what we have a chromophobe type, and then we have a collecting duct cancer, which are the ones which are arising from the distal convoluted tubule. So what do we have? We have a chromophobe, and we have collecting duct cancer. So these are the ones which are basically arising from DCT, or the distal part, like DCT and the collecting duct, as the name only suggests. Now, important thing is about this, what you call as a medullary carcinoma. Okay, so again, a very, very important MCQ over here. Can you please tell me what I'm going to ask you? Yep. So if I ask you that there is a patient who is suffering from a sickle cell trait, okay, so what is a renal cell cancer which is going to happen in the patients who are suffering from sickle cell trait? It is not the sickle cell disease, it is a sickle cell trait. So what is the kind of a cancer which is kind of present in the patients with the sickle cell trait? Please try to understand. It is a medullary carcinoma, medullary type of a renal cell carcinoma. Okay, I hope you have understood this particular point. Very, 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 very important. Okay, now let me just walk you through the clinical presentation. Okay, so let me just talk you about the clinical features of the clinical presentation of these particular patients. Okay, so first let's talk about the risk factors. Okay, so what were the risk factors which we talked about? So risk factors were, first is, okay, VHL gene mutation. We talked about this VHL gene mutation. Then there are other risk factors which are basically called as a HOT. What is this HOT? It is hypertension, obesity, and tobacco. Okay, so all these are the risk factors for this. Then there are occupational risk factors, occupational risk factors like asbestos and cadmium exposure. Okay, then what else do we have? We have what you call as painkillers, chronic painkillers. If at all the patient is taking chronic painkillers, analgesic abuse, these are broadly the risk factors of the patients with renal cell cancer. Okay, now very, very important, what is the presentation? Okay, what is the presentation of the patients with the renal cell cancer? The most common presenting feature is hematuria. What is it? It is hematuria. Please try to understand this point. Very, very important. So if at all there is a patient who is coming to you with frank hematuria, that is, the patient is coming and trying to tell you that, you know what, there is a blood in my urine, it means that the patient is able to see that particular blood. That is what is called as a gross hematuria. Okay, so in that particular scenario, you have to kind of take it seriously, because it might be a, what you call as a risk of a, like, it might be a kind of a feature that, you know what, the patient is having an underlying malignancy. You understand my point? So that is very, 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 very important for you to understand. Okay, so if at all there is a patient who is having hematuria, then you have to kind of consider that the patient might be having a renal cell cancer. Now there is something which is called as a characteristic triad. So what is the characteristic triad of the patients with renal cell carcinoma? Can you please help me with this? What is this particular characteristic triad? It is consisting of hematuria, then it is consisting of pain, and it is consisting of lump. Okay, but what you need to understand about this particular characteristic triad, it is present only in 15% of the patients. Okay, it is present only in the 15% of the patients, and this is also referred to as your too late triad. Okay, too late triad. You understand my point? So this is also the one which is referred to as your too late triad. Okay, so that is what you need to understand about this, right? Okay, understood. Now when you examine this particular patient, okay, on examination, what are you going to find in the examination of this particular patient? On examination, what you're going to find is a non-reducible varicocele. Okay, so what you're basically going to find is a non-reducible varicocele. Okay, that is what you're going to find over here. Okay, now non-reducible varicocele. Why non-reducible varicocele? Because what you need to understand is that renal cell cancers, they grow as tumor thrombus. So what you need to understand is, I have drawn it over here. Okay, so let's say this is a renal cell cancer. This is a renal cell cancer. It is going to grow towards, like, into this particular renal vein as a tumor thrombus. Okay, it is growing as a tumor thrombus. What is it going to do? It is going to obliterate this particular opening of the testicular vein. And if at all it obliterates this particular opening of the testicular vein, if at all it obliterates this particular opening of a testicular vein, what you need to understand is that it is going to cause dilatation of this particular testicular vein, and that is what is called as a varicocele. I hope you are able to understand this particular point. So this is why there is a non-reducible varicocele. Normally the varicoceles are reducible. In the patients with the renal cell cancer, what do we find is we find a non-reducible varicocele. Okay, I hope you have understood this particular point, right? Now, what else do you need to understand over here? That okay, that's fine. Okay, I hope you have understood. Lastly, if at all, let's say the patient is having cough, or otherwise also if you get an X-ray done and if you find an image like this. So what is this image? What is this image trying to tell you over here? So this is what is a patient who is having a cannonball metastasis. Okay, so in the patients with the metastasis, what you need to find is that we find a cannonball metastasis. Okay, on the X-ray, what you're going to find, if you find a cannonball metastasis, this is what you can find in the later stages of this. Okay, so cannonball metastasis can be found in the later stages of the renal cell cancer. Okay, so whatever we have read, we'll just kind of try to just summarize it. So what we talked about the renal cell cancer. What did I tell you? That von Hippel-Lindau kind of gene mutation is one of the important risk factors. Then hypertension, obesity, tobacco exposure, then cadmium, asbestos exposure, all these are the risk factors. Along with that, painkillers, yeah, all these are the risk factors. The presentation, the most common presenting feature is going to be hematuria. Okay, there is a triad also, that is a flank mass, and then pain, and then hematuria, but this is present only in 15% of the patients, and that is what is called as a too late triad. It is not present in everybody, and even if it is present, it is already too late. By this time already the metastasis might have taken place. So when you examine this particular patient, what do you find? You find that there is a non-reducible varicocele. What do you find? Non-reducible varicocele. Okay, so somebody has written on the left side, so it is not just on the left side, guys, it is can be present on both the side. Okay, you understand my point? Yep, they can be present on the left as well as on the right side. That's fine. So it is more, let's not go in there. Overall, per se, the varicoceles are more common in the left as compared to that of right. That's fine. But in the renal cell cancer, non-reducible varicocele can be present in both sides, not just on the left side. Okay, I hope you have understood this particular point, guys. Yeah. Okay. Okay. Okay, I hope you have understood this point. Okay, now lastly, if you get an X-ray done, what you're going to find on the X-ray? On X-ray, you're going to find a cannonball metastasis. Okay, so you are going to find a cannonball metastasis, and do not forget this is an X-ray of a cannonball metastasis. Okay, I hope you have understood these particular points, guys. Okay, now let's talk about so this is all about it. Now before moving forward, I want to ask you something. So there's no point of just covering topics, just kind of memorizing or just kind of bombarding you with all these particular things. Whatever you read, you should kind of read with a bit of a understanding. So can anybody, again, very simple question, but can you tell me what is a paraneoplastic syndrome per se? I'm not trying to ask you what is in the renal cell cancer, is it present or not present or something like that. Blindly I'm asking you, what is a paraneoplastic syndrome? I understand it's a pretty simple question, right? But whenever we ask this particular thing in the class, many times students are not able to tell. So I'll just explain you what is a paraneoplastic syndrome. Paraneoplastic syndrome means, let's say if at all there is a tumor. Now the tumor will produce a systemic manifestations after it has metastasized to a distant place, right? So once it has metastasized to a distant place, then it can kind of produce your what do you call as the systemic manifestations. But if at all the tumor is producing a systemic manifestation without having the metastasis, that is what is called as a paraneoplastic syndrome. Okay, so that is what is called as a paraneoplastic syndrome. So in the comments I can see that erythropoietin and hypercalcemia and all those things. Okay, these are the ones which are associated with renal cell cancer. We'll talk about it. But what is a paraneoplastic syndrome? So this is what is a paraneoplastic syndrome. Okay, I hope you have understood this point. Okay, now coming to this. So coming to the renal cell cancer, what is the paraneoplastic syndrome? So first question which they ask is, which is the most common? So please try to understand. Raised ESR. Raised ESR is the most common paraneoplastic syndrome which you find in these particular patients. Okay, then hypertension, anemia, polycythemia, hypercalcemia. So another question which I want to ask you is that, is this hypercalcemia because of increased parathyroid hormone? No, this is because of the increase in the parathyroid hormone related peptide. Okay, are you understand my point? So this is because of the parathyroid related peptide. Okay, so it is basically because of parathyroid related peptide. Are you understanding my point? So very, 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 very important. It's because of the parathyroid related peptide, and because it is produced by certain substance, the management of this is bisphosphonates. So that is, it can be managed medically. Okay, you can manage these particular patients medically. Okay, now the last thing which I want to talk to you about is a Stoffer's syndrome. So how many of you have know about this particular Stoffer's syndrome? So Stoffer's syndrome basically means that there is a patient who is having a renal cell cancer. Okay, so let's say there is a patient who is having a renal cell cancer. Now what is this renal cell cancer going to produce? It is going to produce interleukin 6, and this interleukin 6 is going to go to the liver, and it is going to cause the deranged liver enzymes. Okay, it is going to cause deranged liver enzymes. Okay, are you understanding this particular point? This is what is called as a deranged liver enzymes. So this is what is a Stoffer's syndrome. What is a Stoffer's syndrome? When there is a tumor which is producing interleukin 6, it's going to the kind of liver and it is causing the derangement of the liver enzymes. This is what is called as a non-metastatic liver dysfunction. Okay, non-metastatic liver dysfunction. And what about the management of this? So please try to understand. You have to go ahead and do a nephrectomy. Okay, so once you do a nephrectomy, once you kind of take out this particular kidney, what is going to happen? The interleukin 6 is going to come down, and the liver enzymes, whatever has got deranged, they are going to kind of come down to the normal level. Okay, I hope you are able to understand this particular point. So these are the paraneoplastic syndromes which are associated with the patients with the renal cell cancer. And we have talked about the management. So if at all it is less than 4 centimeters, then we perform a partial nephrectomy. Otherwise, you can perform a radical nephrectomy. Okay, now a pretty simple question over here. Primary survey of the ATLS does not include what? CT scan, FAST, chest X-ray, and the pelvic X-ray. So what is the answer over here? So please try to understand. It's pretty simple. It is the chest CT scan. Okay, so CT scan is not part of your primary survey. It is a part of your secondary survey. Okay, so what I'll do is I'll just kind of quickly talk to you about a couple of important points about this ATLS guidelines. Okay, so whenever you have a patient who is coming to you with a trauma, okay, after the trauma, the patient has been brought to the trauma center. So what you have to do, you have to follow something which is called as a ATLS guidelines. Okay, what are you going to follow? You're going to follow the ATLS guidelines. Now in these particular ATLS guidelines, the sequence is small c, A, B, C, and D. Okay, so my important question to all of you guys is, and I want you to answer this, what does the small c stands for? In the ATLS guidelines, this small c stands for what? Can you please help me with this? What is this small c stands for? I'm waiting for your answers in the comment box, guys. Can you please help me with this? What is this small c? Can you please help me? Cervical collar. Okay, VPR is saying cervical collar. No, that's not the answer. Anybody else? Yes, very good, very good. Okay, so this is what is, it is not the cervical stability, guys. Please try to understand. It is a direct line from your love and belly. This small c is basically standing for your control of external hemorrhage. Okay, what is this? Control of an external hemorrhage. You understand my point? So this is what is control of an external hemorrhage. This A basically is consisting of airway with cervical spine stabilization. Then we have other things like the breathing, circulation under disability, which you all know, that's fine. But what you need to understand, this C basically stands for control of an external hemorrhage. So you will not forget it, right? Please, I hope you promise me you will not forget it. So the small c basically stands for control of an external. What do you mean by that? Okay, so let's take a practical example. Let's say there's a patient who is walking to you in the trauma center. You are the kind of in charge of the trauma center, and the patient is having the cut in this particular radial artery or the brachial artery or whatever. So if at all there's a bleeding which is coming from this particular radial or the ulnar artery, what you're going to do? First, you're going to kind of control this particular hemorrhage, right? You will not kind of sit back and assess the airway and the breathing and then you'll come to this. No, not really, right? Okay, so first you're going to control this external hemorrhage. That is what you need to understand about the small c. Okay, now this is directly from your love and belly, guys. Do not forget about this. It's an important stuff. Okay, I hope you have understood this point. Now another things which you need to understand about the ATLS guidelines are, there is something which is called as a primary survey. In this, you basically evaluate the patients quickly, and that's fine. So primary and secondary survey. So in the secondary survey, what you're going to do, you are going to perform a head to toe examination. What you're going to do, you're going to perform a head to toe examination. Okay, and in this, what do you have? You have CT scan as a part of it. Okay, so CT scan is a part of your secondary survey. Very, 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 very important. Even in the recent INI CT exam, this particular question was asked to you. So I'll just kind of talk to you about one more small thing. Okay, so I will like to talk to you about a very, very small thing. So which small thing which I wish to talk to you about? Okay, so what you need to understand over here is, so let's say if at all there is a patient who is having a there's a patient who is coming to you in the trauma center. Okay, so there's a patient who is coming to you in the trauma center. Now what you can do is, either you can subject that particular patient directly to a CT scan. Okay, so what you can do, you can subject that particular patient directly to the CT scan, or you can evaluate the patient, and then once you are convinced that, you know what, this is a suspicious of the injury, then you can subject the patient to a CT scan. Okay, so please try to understand, whenever there is a patient who is coming to you with a trauma center, so what you can do is very, very important. This is a concept which you need to understand. Either you can offer this particular patient a whole body CT scan, or what you can do is you can evaluate the patient, and if at all there is some suspicious injury, then what you can do, you can perform a selective CT scan. Are you understand my point? So either you can perform a whole body CT scan, or you can perform a selective CT scan. Okay, so did you understood the concept of this? Okay, so let's no point kind of moving ahead if you have not understood. See, let's say if at all I am a patient who is coming to the trauma center, and let's say I am suffering from a polytrauma or some significant trauma or something like that. Two things you can do. You can directly subject me to a whole body CT scan. So if you subject me to a whole body CT scan, whatever the injuries are there, let's say a couple of bones are broken, or whatever the hemoperiton is there, not there, or something like that, all these particular things you will get to know immediately, right? On the other hand, what you can do, you can stabilize me and you can evaluate the patient. And when you kind of abdomen palpation, when you find that there is a peritonitis, and if at all I am hemodynamically stable, then you can shift me to a CT scan. Are you understand my point? So the second kind of approach is called as the selective CT scan. The first approach is called as a whole body CT scan. Now what you need to understand is that what was the rationale of bringing this particular whole body CT scan? We thought that, you know what, it will help us detect the injuries a bit early, and this is how it is going to help you reduce the mortality of these particular patients. But that is actually not true. So what you need to understand, very, very important, two things. In this, you have to understand two things. The whole body CT scan, it yes, definitely detects the injuries early, no doubt about it. Okay, but it does not reduce the mortality. I understand my point. It detects the injuries early, but it does not, what you call as, reduce the mortality. Okay, so it detects the injuries early, but it does not reduce the mortality. Okay, this is one point which you need to understand. Another thing what you need to remember is very, very important, direct line from below and Billy, one whole body CT scan is equivalent to how many, like what is the radiation exposure in the one whole body CT scan? Can you please help me with this? What is the kind of radiation exposure to the this particular one whole body CT scan? It is equivalent to 76 chest X-rays. Okay, so please do not forget this, guys. This is directly from your 11 billion, this can be asked to you. Okay, so one whole body CT scan is equivalent to the 76 chest X-rays. So that is what is the radiation exposure in this particular stuff. Okay, I hope you have understood this particular point, guys, right? Okay, right. Now let's talk about the next question. Okay, so identify the sign which you're kind of seeing on your screens. It's a pretty simple question. Can you please help me? What is the answer? Battle sign, raccoon sign, Romberg sign, or the Mc-Evans sign? Okay, what is the answer over here? So this is, yes, definitely it is a battle sign. Okay, so now what we are going to do, we are going to talk about what you call as the base of the skull fracture. Okay, so what we are going to talk about, we are going to talk about the base of the skull fracture. Okay, so we are going to talk about base of the skull fracture. So how many, like what is the base of the skull? So what do we have? We have the anterior cranial fossa, middle cranial fossa, and the posterior cranial fossa. So these are the three kind of cranial fossas which we have. Now these particular things may get injured. Okay, so they may get injured over here. Okay, they may get injured, and once they get injured, they basically present as a different kind of findings. Okay, so in the anterior cranial fossa fracture, so if at all there is an anterior cranial fossa fracture, what are the findings which you're going to get in the anterior cranial fossa fracture? Okay, so what are the findings which you're going to get in the anterior cranial fossa fracture, guys? Can you please help me with this? So in the anterior cranial fossa fracture, what you're going to get is CSF rhinorrhea. Okay, CSF rhinorrhea, that is what you're going to get. Okay, so what is the CSF rhinorrhea? That is basically the CSF which is dripping from the nose. This is what is called as the CSF rhinorrhea. Now the important thing is, how do you kind of distinguish between the CSF rhinorrhea and the running nose and all those particular stuff? Okay, so what you're basically seeing over here, this is what is your reservoir sign. What is this? This is what is your reservoir sign. So in this, what you basically, it's not that irrelevant, but it's still fine. It is called as a reservoir sign, or it is also called as a teapot sign. Teapot sign. So what is this reservoir sign or a teapot sign? So when the patient basically lies down, what happens? All the CSF is basically getting accumulated in the air sinuses, and when the patient gets up, the CSF basically comes down from the nose. So this is what is called as a reservoir sign or the teapot sign. That's fine. This is slightly more important. This is what is called as a target sign. Target or a halo sign. Halo sign or a target sign. So this is going to happen if at all there is blood which is mixed in the CSF. Okay, so there's a CSF mixed with the blood, then you're going to have this target sign or a halo sign. So what happens is, whatever the secretions are coming out from the nose, you kind of put it on the filter paper or the blotting paper. So what happens, if at all there is a blood is going to take the central part, and the CSF is going to take the peripheral part of it. So this is what is called as a target sign or the halo sign, which you basically find in the patients with the CSF rhinorrhea when there is a blood which is mixed with it. Now my question to you is, what is the best test to distinguish between the CSF rhinorrhea and the running nose? Now this is very, very important, guys. Okay, so sniff is fine, that's okay, but that's not that kind of specific test. Okay, but what is the best test to distinguish between the CSF rhinorrhea and your running nose? So can you please help me with this? What is the best test? Can you really tell me? So it is beta 2 transferrin. Yes, very nice. Okay, so beta 2 transferrin is the best test. Okay, what is this? This is the best test to distinguish between CSF rhinorrhea and running nose. Okay, the running nose. So this is the best test to distinguish between the CSF rhinorrhea and the running nose. Okay, I hope you have understood this particular point, guys. Okay, now what is this? Pretty simple, pretty straightforward. So this is what is your black eye or the raccoon eye. Okay, what is this? This is what is your black eye or raccoon eye. Raccoon eye. Okay, so please try to understand over here, nothing major, nothing significant, pretty simple, nothing major about this. Okay, so this is raccoon eye or the black eye. Okay, now the important thing is about this. Now this is something which I might feel that you might have some extra point over here. So what you need to understand is that, okay, let's say I'm sitting over here. Okay, now very, very important, let's kind of focus again on me. So what you need to understand, let's say I'm sitting over here and you come and you kind of give me a good punch over on my face or something like that. What is going to happen? There is a chance that there is a subconjunctival hemorrhage which is going to happen, right? Now the subconjunctival hemorrhage in the patients with a trauma can happen because of two reasons. One is because of the anterior cranial fossa fracture. Yes, that is one of the reasons. The another reason is because of the direct blow on the eye. So it can cause it directly, there can be a subconjunctival hemorrhage. So these are the two reasons why the patients might have a subconjunctival hemorrhage. Now how will you distinguish whether this is because of the direct blow or this is because of the base of the skull fracture? So how will you be able to distinguish between these guys? So can you please help me with this? So when you have any particular patient with whatever the subconjunctival hemorrhage, try to look for the posterior and the upper border. If at all you are able to delineate the posterior or the upper border. Okay, I'll just go back to the screen. So are you able to appreciate? So here what you're able to see, that are you able to appreciate that there is you are able to look at the posterior and the upper border of this particular hemorrhage, right? So this is what is because of your direct blow to the eyes. But over here I hope you're able to appreciate that you're not able to kind of look at the posterior border. It is kind of covering the entire kind of sclera. So this is the one which is because of the anterior cranial fossa fracture. But this one, this is probably because of the direct injury on the eyeball. Okay, I hope you have understood this particular point. So this is very, 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 very important. You should be aware of this. Okay, so this particular subconjunctival hemorrhage, just to summarize, this is because of the base of the skull fracture. Which skull? So it is anterior cranial fossa fracture, skull fracture. Now this is because of your direct injury. Okay, this is because of your direct injury. You understand my point? So this is very, 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 very important thing which you need to understand. Okay, got it? Okay. Now, what about the middle cranial fossa fracture? So in the middle cranial fossa fracture, you are going to have this battle sign. Okay, so this battle sign is something which you basically find in the middle cranial fossa fracture. So what is this? This is ecchymosis on the mastoid process. Okay, ecchymosis on the mastoid process. What another thing which you can find? You can have a hemotympanum. So when you do an otoscopic examination, behind the tympanic membrane, you can find the accumulation of the blood. That is what is called as a hemotympanum. So all these are the features of your middle cranial fossa fracture. Okay, so now quickly let's move on to the next question. Now this is again an important question for you guys to answer. So can you please help me with this? Okay, so there's a patient who presented with the abdominal pain. So there was a patient presented with the abdominal pain. There was a blood in the stool and the palpable mass on the abdominal examination. So abdominal pain, blood in the stool, palpable mass in the abdominal examination. The barium image has been obtained. What is the most probable diagnosis of this particular patient? Okay, so can you please help me? What is the most probable diagnosis of this particular patient? The options are Meckel's diverticulum, intussusception, volvulus, and the diverticulitis. Okay, so yeah, what is the answer over here, guys? So yeah, I've gotten answers as it is intussusception. Yes, guys, absolutely right. Okay, so what is the answer over here? It is an intussusception. Can anybody tell me what is a sign which is being shown over here? What is this investigation and what is the sign which you're basically seeing? Can anybody tell me what is this? What is this? What is this sign which you're basically seeing over here? Can anybody tell me this? Yes, barium. Yes, absolutely right. I got the answers. So this is what is a barium enema. What is this? This is what is a barium enema. And what you're basically finding over here is a coiled spring appearance. Okay, what you're basically finding is a coiled spring appearance. Okay, I hope you have understood this particular point, right? So this is very, very important. Okay, so now let's talk about the intussusception a bit. Okay, so what is intussusception? Intussusception is a condition where there is an telescoping of one part of the bowel into the other. Okay, so one part of the bowel is basically going into the other, and that is what is causing your intestinal obstruction. Are you understanding my point? So as you can see over here, there's a telescoping of one part of the bowel into the other, and that is what is causing the intestinal obstruction. So how will the patients present to you? So what will be the clinical presentation of the patients with intussusception? So what will be the clinical presentation, guys? So clinical features will be that the patients are going to come to you with a bilious vomiting. Obviously the patients are going to have a colicky abdominal pain. So full-blown features of your what you call as intestinal obstruction. Okay, so colicky abdominal pain, bilious vomiting, all these particular things are going to be there. There might be emptiness in the right iliac fossa, which is called as a sign of dance, or there can be a palpable mass in the abdomen. All these particular things are there. Now the important things which can be asked from this particular topic are about the findings. Okay, so can anybody tell me what is this? Okay, so first of all, tell me whether it is a kidney. I'm just trying to draw things for you. So this is a kidney, right? Okay, I hope you're able to understand. Here there is a renal artery or something. Yeah, so is it like a kidney or it's something else? So please try to understand. This is what is a donut sign. Okay, it's not a donut sign. Oh sorry, you confused me as well. It's not a donut sign. What is this? This is a pseudo kidney sign. Okay, this is a pseudo kidney sign. So please try to understand this point. Okay, so you have an ultrasound. Okay, on the ultrasound what you have is you have a pseudo kidney sign. Pseudo kidney sign. Okay, so let me just explain to you what on earth is this particular pseudo kidney sign. Okay, so let's assume that there is a intussusception. Okay, so let's say there is an intussusception. Let's assume that this is an intestine and this particular part of the intestine is going into the each other. Okay, now it has went, that's fine. Now if I have the ultrasound probe, okay, so let's assume that this is my ultrasound probe. Okay, oh just come. Okay, so let's assume that this is my ultrasound probe. Now what I can do, I can either put my probe like this on along the what you call it, the length of the intestine, or I can put it perpendicular to the length of the intestine. If I put it along the length of the intestine, what are you going to find? I'm going to find a pseudo kidney sign. Now you understand my point? If I put my probe like this, what I'm going to find is a pseudo kidney sign. But if I put my probe perpendicular to this particular intestine, I'm going to find a target sign, or a double target sign, or a donut sign, whatever you want to call it, you can call it. You understand my point? So let's come back over here. So what is this? This is what is an pseudo kidney sign on an ultrasound. Very, very important. You would have heard of this, but what is the pseudo kidney sign? I hope you're able to appreciate this is how the pseudo kidney sign looks like. And what is this? This is what is a target sign or a double target sign when you keep the probe perpendicular to the length of the intestine. Okay, I hope you have understood this particular point. Now, if I perform a barium enema, what I'm going to find? There are two signs which you can find on the barium enema. One is the claws sign. Okay, so somebody is kind of bringing out the claws out. Okay, so this is what is a claw sign, which you can basically find in the barium enema. Okay, understood? And we already saw one which was a coiled spring appearance. Okay, so this is what is a coiled spring appearance, which you basically find in the patients with the barium enema, in the patients with intussusception. Okay, I hope you have understood. And finally, if at all you perform a plain X-ray, on the plain X-ray, what you can find is a air crescent sign. Okay, so what is this? This is an air crescent sign in the patients with a plain X-ray. Okay, I hope you have understood this particular point. So this is what is an air crescent sign in the patients with a kind of a plain chest X-ray. Okay, so yeah, you have kind of diagnosed it to a certain extent. Now it's time to manage this. Okay, so how are you going to manage the patients of an intussusception? How do you manage these particular patients, guys? Can you please help me with this? So for the management, what you need to understand is that you can try for a conservative management. Okay, what do you understand with the conservative management? So you can try to reduce the intussusception by air enema, by giving an air enema, or a gastrographin enema. Okay, so what you can do is that you can kind of push air, or you can put a contrast, that is a gastrographin contrast, and what it will do, if at all there is an intussusception, it will reduce that particular intussusception back into its normal position. This can happen. That is one of the things. What is the another thing what you can do? You can basically okay, so this is the only thing in the conservative management what you can do. But if there is peritonitis is present, okay, if at all there is a features of peritonitis, or the or if at all what is the conservative management, it fails. Okay, whatever you try this particular conservative management but it fails, then in that particular scenario you have to perform a surgical kind of correction of that. Okay, no brainer about this. I kind of unnecessarily stretched it a bit, but I hope you have understood conservative management. What is there? There's an air enema or a gastrographin enema. That is what you can put. But if at all that fails, or if at all, let's say there are already the features of peritonitis or the perforation is there, in that particular scenario, what you have to perform is you have to kind of perform a surgery. Okay, so you have to kind of do a surgical correction of it. Okay, so they will never give you directly peritonitis. Okay, so can you please tell me what are the features of the peritonitis? Like, what are you going to look in the question which is going to prompt you that you know what the features of peritonitis are present? What is going to be there in the kind of clinical scenario? Can you please help me with this? Yeah. Can you please help me with this? What is going to be there in the clinical scenario which is going to say that you know what the patients are having the features of peritonitis? Guarding and rigidity. If at all the question mentions that there not fever, guarding and rigidity. Pain is also not there. Okay, pain can be there in any particular patient, right? So guarding and rigidity. If they mention guarding and rigidity, it means that the patient is having peritonitis. Okay, I hope you have understood this particular point, guys. Okay. Okay, great. Now let's look at this particular question over here. So there's a patient who develops an air embolism during a surgery. So they're giving you that, you know what, there's a patient who is coming to with an air embolism during the surgery. The patient has to be put in which position? So what is the position in which you are going to put this particular patient? Now this is again a direct line from your 11 milli. It has been asked to you a couple of times, I think, in the NEET PG exam, but yeah. So let's try to understand. What is the answer over here? Left lateral decubitus position with the head up position. Left lateral decubitus position with the head down position, let's say right lateral decubitus position with the head up, and right lateral decubitus with the head down. Okay, so can you please help me with this? What is the answer over here? Okay, so what is the answer? Okay, great guys, great. Yep, okay, very nice. The answer over here is left lateral decubitus position with the head down. Bravo, guys. Whoever answered this correctly, very nice, very, very nice. So can you please tell me what is the, what do you call as, what is the, what is this particular position named as? What is the name of this particular position? This is what is called as a Durant's position. Okay, what is it called as? It is called as a Durant's position. Okay, so this is what is a Durant's position. Please remember this particular name as well, Durant's position. Okay, position. Okay, now before I move ahead and I kind of explain you about this particular position and everything, so Saviti is basically asking, sir, X-ray finding in the interception. Okay, it is air crescent sign. Okay, so I'll just move back. So what you need to understand over here, what happened, let's say the part of the intestine came from here and here there was an interception. I'll just draw for the sake of it. What you need to understand is, let's say the part of the intestine which kind of entered over here is like this. Okay, so this is a part of the intestine which has entered over here like this. Okay, so what you need to understand, the rest of the bowel is going to have a, what you call as a air crescent sign over here. I mean, are you able to appreciate this? So this is what is an air crescent sign, and this is a part of the bowel which has got intussuscepted. Okay, so this is a part of the bowel which has got intussuscepted. Are you understand my point? So this is what is an air crescent sign which you get over here. Okay, I hope you have understood this particular point, guys. Okay, now moving ahead. So what is this Durant position? Please try to understand. This is what is the Durant's position. So left lateral. Okay, so first of all, what is the left lateral? Left side is up or left side is down? So please try to understand. Just look at this particular image. Left side is down. Left lateral means left side down. Right lateral means right side down. Okay, so left lateral position with the head down position. Now if you don't know about this and if you try to apply your logic, you might end up marking it as a head up position. Okay, but that's not true. Okay, so let's assume that I don't have at this point of time. Okay, so let's say if at all I have a bottle of water. Okay, and in that what you have is an air. So when I keep the bottle straight, what is going to happen? The air is going to kind of go up, right? So in the similar manner, if at all I put my head up, what is going to happen? That air embolus will go into the brain, but I want it to be trapped inside the atrium so that I can put in a central line and I can take that particular air balloon, air kind of bubble out. So that is why I put the patients in the left lateral decubitus with the head down position, which is also called as a Durant's position. Okay, so this is also called as a Durant's position. Please try to remember this. And this is what you basically, so what they might give you, that there is a patient who was being operated for a splenectomy, and then suddenly what happened, the end tidal CO2 basically fell down. Okay, so what they're basically trying to tell you, that the patient has suffered from an air embolism. What is the position in which you're going to move this particular patient? So left lateral decubitus position with the head down. Okay, I hope you have understood this particular point, guys. Okay, understood, right? Okay, right. I will address that particular question, okay, at the time of the break. So Vijaya, let's not kind of break the rhythm of this. Okay, let's kind of continue. I'll give the break at around, let's say 10, 15, 10:30. I'll give a break. At that point of time, I'll address this particular question of yours. Okay, I hope you will have that much of patience. Please kind of stay along. Okay, I'll kind of address that. Okay, now there's a 10-year-old female presented with the recurrent attacks of an cholangitis. Okay, recurrent attacks of an cholangitis, and the CT scan was done, and this is the kind of image which you basically got in the CT scan. So what is this? What is the diagnosis of this particular patient? Can you please help me with this? Okay, so what is the diagnosis of this particular patient? The answer over here is very nice, very nice. The answer over here is D, guys. Okay, it is D. It is not kind of C, it is D. That is a Carolese disease. Okay, type 5 is Carolese disease. And can anybody tell me what is a sign which you're basically seeing over here? Can you please tell me what is the sign which you're basically seeing over here? Vijay, please don't be sorry about that. Okay, please don't be sorry about that. I'm just not addressing this at this point of time because it will break the rhythm of the kind of teaching. That's the only thing. Okay, so stay calm. I'll definitely kind of address it towards the, let's say at the time of the break. I'll definitely address that particular stuff. Okay, no need of sorry, guys. We all are here to kind of help each other and kind of learn and all those particular stuff. Okay, so no need of being sorry. Okay, so yeah, what is this particular name of the sign which you're basically seeing on this? Well, first of all, what is this particular kind of a investigation? Is it like a contrast or a non-contrast CT scan? Okay, so I'm just not waiting for your answers. I'm just trying to telling you this is what is a contrast CT. So whenever you get a CT scan, how will you tell that whether there's a contrast or not? In this, there are too many things. Okay, so over here, what you're able to appreciate, what is this? This is what is a kidney. Okay, what is this kidney? I hope you're able to appreciate over here. This is the cortex of the kidney, which is basically taking up the contrast. Now, what is over here? I hope you're able to appreciate this is the aorta. Okay, so this is an aorta, and this is also having a contrast. So definitely this is a contrast enhanced CT scan. And what are you finding on this particular contrast enhanced CT scan? You are finding a central dot sign. Are you able to appreciate this? This is a whatever the cyst, and in the center of that you have a kind of a dot. Are you understanding? This is a central dot sign. So wherever the arrows have been kind of pointed, all these are the central dot signs, guys. Okay, so this is a kind of a this is what is a central dot sign. So what you need to understand is, in the Caroli's disease, what you basically find is a central dot sign. Okay, central dot sign is something which you basically find in the patients with the Caroli's disease. On what? On contrast enhanced CT scan. Okay, I hope everybody have understood this particular point, guys. Okay, got it? Okay, now first of all, let's try to understand what is a okay. So what is this all about? This is all about the choledochal cyst. Okay, so what is this? This is what is a choledochal cyst. So what is this choledochal cyst, guys? Choledochal cyst is basically a congenital anomaly. Okay, what is it? It is a congenital anomaly. And what is the congenital anomaly in this particular choledochal cyst? It is, what is it? It is ABPJ. What is this ABPJ? Abnormal pancreatico APBJ. Okay, what is it? So what is the congenital anomaly which is present in this? It is abnormal pancreatico-biliary junction. Okay, so what is this? This is abnormal pancreatico-biliary junction. Okay, so if at all there is an abnormal pancreatico-biliary junction, what is going to happen? That the pancreatic enzymes are going to enter into the bile duct. Okay, and if at all the pancreatic enzymes enter into the bile duct, what is going to happen? The bile duct will become weak, and if at all the bile duct becomes weak, what is going to happen? It is going to end up dilating. Are you understand my point? So the bile ducts will be dilated, and that is what is a choledochal cyst. Okay, so what is a choledochal cyst? Choledochal cyst is a condition where there is an abnormal pancreatico-biliary junction. Because of this, what is happening? The pancreatic juices are entering into the bile duct, and it is basically ending up dilating these particular bile ducts. I hope you are able to appreciate this particular stuff. That's what is a choledochal cyst. Okay, now the most common presentation, okay, in the children, what is it? Okay, so in the children, it is jaundice. Okay, what is it? It is jaundice. And in the adults, it is lump or a mass. Okay, so in the children, it is jaundice. I hope you're able to understand this particular point, guys. Okay, got it? Okay, now what do we have? We have a Todani or an Alonso's classification. So what is the name of the classification system? So please try to understand. The classification which we have over here is called as a Todani Alonso classification. What do you have? We have a Todani Alonso's classification which we have over here. What is this Todani Alonso's classification? Okay, let's kind of focus on me first. Okay, so first is fusiform. What do you understand by fusiform? Fusiform means there is a uniform dilatation. Okay, so please repeat after me. What is the first? First is fusiform. What is the fusiform? That there is a uniform dilatation of the bile ducts. Okay, that is what is the fusiform. Then what do we have? Two is a diverticular. What do you understand by diverticular? That is the entire lumen is not dilating. A part of the lumen is basically dilating. So there is a diverticulum or a outpouching coming out from that particular lumen. That is what is called the diverticular. Type 3 is very what do you call as interesting. So what is this type 3? So I hope you have understood that, you know what, the bile duct continues as a common bile duct. It goes and it joins to your common pancreatic duct, and it has a common pathway and it is going to enter into the intestine. So when it is having that intraluminal or like the stage where it is basically going through that particular intestine, at that point of that terminal point, if at all there is a dilatation of a bile duct, that is what is referred to as your choledococele. What is it called as? It is called as a choledococele. I hope you are able to understand this point. That is what is called as a choledococele. Then we have type 4. What is there in the type 4? In the type 4, what you have is type 4 is divided into type 4A and the type 4B. What is type 4A? Type 4A is intrahepatic plus the extrahepatic dilatation. What is type 4B? It is just the intrahepatic dilatation. Type 4B is just the intrahepatic dilatation. And what is 5? 5 is Caroli's disease, that there are multiple intrahepatic dilatations where you get a central dot sign. Okay, so please try to understand these are what you call as the types of the choledochal cyst. Okay, so I'll just kind of go back to this particular Todani Alonso's classification. So what is the type 1? Type 1 is basically your what do you call the like fusiform dilatation. Then we have a diverticular dilatation. This is what is a choledococele. The terminal portion is basically getting dilated, intra plus extra, and only kind of intra. This is only type of extra. That is what is a type 4B. And then in the type 5, what you have, this is multiple intrahepatic, which is basically called as a Caroli's disease, where there is a central dot sign. Okay, I hope you have understood this particular point. Now finally about the management. Okay, so for okay, so first can you please tell me about the type 3 choledochal cyst? What is the management for the type 3 choledochal cyst? Please try to understand. It is ERCP with sphincterotomy. Okay, what is it? It is ERCP with the sphincterotomy. That is what is a management of a type 3, ERCP with the sphincterotomy. And what is the management for the type 5? In the type 5, the management is liver transplantation. Okay, what is the management over here? It is liver transplantation. Liver transplantation. Okay, and the type 1, type 2, and type 4, what you do, you kind of excise it, and then you perform a choledochojejunostomy. Okay, so you excise whatever the cyst is there, and then you perform a choledochojejunostomy. Okay, also for type 4A, not really. So please try to understand there's a difference. Okay, so if at all there is an extra plus intra, but if at all it is not involving it, if at all there are multiple intrahepatic dilatation, then you can perform a part of a liver resection, that you can do. But yeah, if at all there are multiple intrahepatic dilatation, then yes, you have to kind of perform a liver transplantation. So idealistically, what you need to understand, if at all there is a solitary intrahepatic dilatation, then you can kind of go ahead with an excision of that particular part of the liver. Okay, I hope you have understood this particular point. Kasai procedure. So somebody is asking me about the Kasai procedure. No, it is not a part of this. So can anybody tell me where will you perform this particular Kasai procedure? What is the condition where you're going to perform this particular Kasai procedure? Can you please help me with this? Yeah. So where are you going to perform this particular Kasai procedure? Anybody, guys? Okay. So the Kasai procedure is no. It is not in the choledochal cyst, guys. Kasai procedure is basically performed in the extrahepatic biliary atresia. Okay, in the extrahepatic biliary atresia, in the biliary atresia. Okay, it is a completely different entity. Over here, the management is your Kasai procedure. Are you understanding my point? So please do remember, guys. Okay, so it is a completely different entity altogether. So there you basically perform a Kasai procedure. Okay, I hope you have understood this point. Now let's move on to the next question. Mirizi syndrome. So what on earth is this particular Mirizi syndrome? Okay, so it is like the gallbladder stone compressing the common hepatic duct, gallbladder carcinoma invading the IVC, gallbladder stone causing cholangitis or pancreatic carcinoma. Okay, and guys, whatever the questions I'm kind of putting up over here, they have been asked at one form or the other in one or the other exam or something like that. So all these are the important PYQs. Okay, so you do need to understand the concept. So as I always say, the questions are irrelevant, the topics become very relevant. That is why I'm trying to discuss the topic in good details with you guys. Okay, so yeah, what is the answer over here? Yes, absolutely, it is basically A. What is the answer? It is A. So what is a Mirizi syndrome? So if I just ask you guys, okay, so if I just ask you that, you know what, you have this particular gallbladder. From the gallbladder, what do you have? A cystic duct. Okay, and then what do you have? You have this particular liver, and from the liver, what is kind of coming out is a hepatic duct. So you have right hepatic duct, you have a left hepatic duct, then you have a common hepatic duct, which is basically joining your cystic duct, and then it is continuing as a common bile duct. Okay, so this is what you basically have. Now, if I ask you that if at all there is a patient who is coming to you with an obstructive jaundice, okay, so if at all there is a patient who is coming to you with an obstructive jaundice, where would be the stone, or where would be the obstruction, where would be the site of the obstruction? So I hope that you say that the site of the obstruction would be somewhere in this common bile duct. Okay, so I hope that you say that the site of the obstruction will be somewhere in the common bile duct. Okay, but what is the Mirizi syndrome? Mirizi syndrome is a condition where the stone is still inside the cystic duct, but it is basically causing the obstruction of the whatever the flow of the bile, and that is why the patients are landing up into obstructive jaundice. Okay, so let me just explain this to you with the help of an image. I hope you're able to appreciate it. So please try to understand this. Okay, so here what is there? There is a stone which is basically present in the neck of the gallbladder or the cystic duct, right? But it is compressing this common hepatic duct, and because of this, the patients are having an obstructive jaundice. Okay, so please try to understand it is a specific kind of a condition where the stone is not entered into the common bile duct, but the patients are having a obstructive jaundice. Now, this particular stone can get stuck in the neck of the gallbladder, or in Hartmann's pouch. There's something which is called the Hartmann's pouch, or in the cystic duct. But the whole thing is that because of the inflammation, it is basically causing a compression over the common bile duct or a common hepatic duct, and ultimately leading to an obstructive jaundice. Okay, I hope you have understood this particular point, guys. Okay, now if you have understood this point, can anybody tell me what is the classification for the Mersey syndrome? So first of all, what is the classification of the Mersey syndrome? Classification for the Mersey syndrome, can you please help me? So how many classes are there? We have 4 classes. Okay, so we have 4 types of the Mersey syndrome. So what are the types? We have type 1, we have type 2, type 3, and type 4. Now it's absolutely simple, like it's frankly there's absolutely nothing in this. So let me just make you understand like what exactly are these particular classifications. Please try to understand. If at all there's a Mersey syndrome, what did I tell you? That there's a stone which is basically stuck inside the cystic duct or whatever, the neck of the gallbladder or something like that. Okay, now over a period of time, what can happen? It can form a fistulous communication with the common bile duct or a common hepatic duct, mainly the common hepatic duct. Okay, it can form a fistulous communication with the common hepatic duct. So depending on whether the fistula is present or not, and how much is the circumference of the fistula, based on that you have type 1, type 2, type 3, type 4. What is the type 1? There is a Mersey syndrome, there is no fistulous communication. What is type 2? There is a fistulous communication which is involving less than 1/3 of the circumference of the common hepatic duct. Okay, now what is the type 2? There's a fistulous communication 1/3 to 2/3 of the circumference. What is type 4? It is more than 2/3. Are you understand my point? So what is this particular Mersey syndrome? In the type 1, what is there? There is only the Mersey syndrome. There is no fistulous communication. Okay, there is no fistulous communication. In the type 2, what is there? There is a fistula which is involving less than 1/3 of the circumference. What is type 3? Type 3 means what is there? There is a fistula which is involving 1/3 to the 2/3 of the circumference. What about type 4? Over here there is a fistula which is involving more than 2/3 of the circumference. Are you understanding my point? So please try to understand this particular point. What is the classification? Type 1, type 2, type 3, type 4. In the type 1, no fistulous communication. In the type 2, there is a fistulous communication less than 1/3 of the circumference. Type 3, fistulous communication 1/3 to 2/3. In the type 4, more than 2/3 of the fistulous communication. I hope you have understood this particular point. Very, 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 very important. Okay, got it, guys? Yep. So always, yeah, I mean, some things are good to know, right? I mean, some important things, or let's say some advanced things or something like that. Okay, that's fine, don't worry about it. Now what about the management of this, guys? What about the management of this? So the management of this is cholecystectomy. Cholecystectomy. Sometimes what happens is that the wall of this particular gallbladder is very, very intensely adhered to the common bile duct or the common hepatic duct, and it is kind of a bit difficult to kind of separate the entire gallbladder. In that particular scenario, you may perform a partial cholecystectomy. Okay, you may perform a partial cholecystectomy, but broadly what you need to understand, the management is what you call as a cholecystectomy. Okay, cholecystectomy or a partial cholecystectomy, that is what you have to perform in these particular patients. Okay, I hope you have understood this particular point, guys. Yep, got it. Now let's talk about the next question. Okay, so what is the next question which we have, guys? Red proto-oncogene is associated with the development of what? Okay, so there's a red proto-oncogene, that is what is associated with the development of what? Can you please help me with this? Okay, so this is the one which is associated with the development of, what do you call as? It is the one which is associated with the development of medullary carcinoma of the thyroid. Okay, so please try to understand, this red proto-oncogene is the one which is associated with the medullary carcinoma of thyroid. Okay, so let's talk about this particular medullary carcinoma of thyroid. Okay, shall we? Okay, it's a very, very important topic again. So let's talk about this medullary carcinoma of thyroid. Okay, so from where is this particular medullary carcinoma of thyroid arising? Medullary carcinoma of thyroid, it arises from which portion? Can you please help me with this? So what we have inside the thyroid gland. Okay, so let's assume that this is a thyroid gland. So what are the things which are basically present inside the thyroid gland? So we have a thyroid follicles. So we have a lot of thyroid follicles, and then what do we have? We have parafollicular C cells. Okay, in between these particular follicles, what do we have? We have parafollicular C cells. Okay, so what we have is we have a parafollicular C cells. Okay, so we have a thyroid follicles, and we have parafollicular C cells. These are the things which we have, right? So this medullary carcinoma of thyroid is the one which is arising from what? It is arising from parafollicular C cells. Okay, it is the one which is arising from the parafollicular C cells. Okay, now if at all it is arising from the parafollicular C cells, okay, what do these particular parafollicular C cells, what do they produce? So they basically produce what? They basically produce your calcitonin. Okay, what do they produce? They basically produce your calcitonin. Okay, I hope you're able to understand. What are these C cells producing? C cells are producing calcitonin. Okay, and if at all they're producing calcitonin, it is going to cause reduction in the calcium levels of the blood. Okay, so again, very basic stuff. I'm pretty sure most of you guys might be knowing this, but let's try to understand. So what you need to understand is that calcium. So how is the calcium levels maintained inside the blood? It is because of the parathyroid hormone and the calcitonin. So what is the function of a parathyroid hormone? Parathyroid hormone is trying to increase the calcium levels in the blood. What about the calcitonin? It is trying to reduce the calcium levels in the blood. Okay, so if at all there is an excess of a parathyroid hormone, it is going to increase the kind of calcium levels, and if at all it is like, if at all there is an excess of a parathyroid hormone, what is it going to do? It is going to reduce the calcium. If at all there is a excess of a calcitonin, it is going to cause hypocalcemia. Okay, I hope you are able to understand. They both kind of act opposite to each other. Okay, I hope you have understood this particular point, guys. Okay, now what about the familial association, guys? In the patients with the medullary carcinoma of thyroid, this is associated with which familial syndrome? So it is associated with MEN syndrome. Okay, it is associated with the MEN syndrome. Which MEN syndrome? MEN 1 or MEN 2? Okay, so this is the one which is associated with MEN 2A and B. Okay, MEN 2A and MEN 2B, which is basically having the RET gene mutation. Okay, it is having the RET gene mutation. So if at all there is a familial association, these are the things which are basically going to be what you call as more aggressive and all those particular stuff. Okay, so the MEN syndrome, they are going to occur at a younger age and they are going to be more aggressive. The medullary carcinoma of thyroid, they are going to be occurring at a younger age and they're going to be more aggressive. Okay, if at all they are associated with the MEN syndrome. Now let's talk about the clinical features. Okay, so what is the most common presentation? Okay, so please important understand what is the most common presentation of the patients with the medullary carcinoma of thyroid. What is the answer over here? It is diarrhea. Okay, please try to understand. Diarrhea is the most common presentation of the patients with medullary carcinoma of thyroid. Along with that, the patients may have hypocalcemia, no doubt. Hypocalcemia can be present, but the most common presentation is your diarrhea because of the serotonin and all those particular stuff. That is what is the most common presentation. Okay, now if you perform a labs, okay, if you perform like the blood examination of this particular patients, what are you going to find? You're going to find that there is an increase in the calcitonin. Okay, there is increase in the calcitonin. Now you understand my point? There's an increase in the calcitonin levels. Okay, and this is what is your tumor marker. Okay, what is this? This is what is your tumor marker. Okay, so this calcitonin is basically your tumor marker. What is the tumor marker? Calcitonin is your tumor marker. Please try to remember this particular point. Okay, now what else can happen? Obviously you can have reduction in the calcium levels, that's fine. Okay, but very important question is, what is the tumor marker? Calcitonin is the tumor marker for your medullary carcinoma of thyroid. Okay, understood? Now in the medullary carcinoma of thyroid, is there a chance of metastasis? Mets, are they possible in the medullary carcinoma of thyroid? Answer is yes. It can occur either by the hematogenous route, or it can occur by the lymphatic route. Okay, both are possible. In the hematogenous route, it can either spread to the bones or it can spread to what you call as your viscera. Okay, so if at all there is a hematogenous metastasis to the bones, what kind of metastasis are going to be there? Osteoblastic or osteolytic? So please try to understand. Yeah, can you please help me with this? What type of metastasis will be there in the bones? It is going to be osteoblastic metastasis. Okay, osteoblastic metastasis are going to be there. And what about the viscera? What is the most common visceral metastasis? What is the most common site in the viscera? It is liver. Okay, so liver is the most common site for the visceral metastasis. Okay, so yeah, all these particular things can be there. In the lymphatic, what is the first lymph node involved? Okay, can you please help me with this? Very, very important. Okay, what is the first lymph node involved if at all there is a lymphatic metastasis? Okay, so it is called as Delphian group of lymph nodes. Okay, it is a Delphian group of lymph nodes, which is basically a central group. Okay, so what do we have? We have a central group of lymph nodes. That is what is a Delphian group of lymph nodes. So that is something which is involved in the lymphatics. Okay, I hope you are able to understand this point. Okay, so this is what is a sentinel node for your kind of thyroid. Okay, I hope you have understood this particular point. Now, finally, what you need to understand is that if you perform an FNAC, very, very, very important point. It has been asked so many times. I think even in this I9, they had been asked. Okay, so on the FNAC, what are you going to find? On the FNAC, what you're going to find is a amyloid stroma. Amyloid stroma. Okay, what are you going to find on the FNAC? You're going to find an amyloid stroma. Very, 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 very important. Okay, so amyloid stroma is something which you basically find on the FNAC in these particular patients, right? Now, lastly, what about the radioactive iodine? Is there any role of a radioactive iodine? Radioactive iodine. Okay, is there any role of it? Any role? What do you think, guys? Okay, is there any role of the radioactive iodine in the patients with the medullary carcinoma thyroid? The answer is big no. Okay, what is the answer? It is no. There is no role of the radioactive iodine in the patients with the medullary carcinoma thyroid. Okay, so yeah, all these particular points are very, very important. So I'll just quickly summarize what are the important things which we talked about this. So first of all, we saw that the medullary carcinoma thyroid is arising from the parafollicular C cells, and that is why it is going to produce calcitonin, and it might come to you with a hypocalcemia. That is the first thing, right? Now, it is associated with the MEN syndrome. Which MEN? MEN 2A and MEN 2B. Okay, and that is what is a red kind of genetic mutation is kind of there, present over there. It can have diarrhea, that's fine, but the tumor marker is your calcitonin, which can lead to decrease in the calcium levels. Metastasis can occur either to the hematogenous or the lymphatic sites. Hematogenous metastasis can occur to the bones. Osteoblastic metastasis and the visceral metastasis can go to the liver, and the lymphatic metastasis, the first lymph node which is involved is a Delphian group of lymph nodes, which is the central group of lymph nodes. Finally, what we have is an FNAC. On the FNAC, what you find is amyloid stroma. That is what you basically find over here, and the radioactive iodine has no role to play in the patients with the medullary carcinoma thyroid. Now, lastly, what about the management? What is the management of the patients with the medullary carcinoma thyroid? It is total thyroidectomy. Total thyroidectomy with central node dissection. Okay, so you have to kind of dissect the central group of nodes. Okay, so that is what is a management of the patients with the medullary carcinoma of thyroid. Okay, now just give me 1 minute. I'll just be back. Just give me 1 minute. Okay. Okay, so this is about what you call as a medullary carcinoma of thyroid. Okay, I hope you have understood this particular point. Okay, now let's move on to the next question. The next question is, TURP was done in an old patient for the BPH. So you did a TURP, transurethral dissection of the prostate, TURP, in an old patient of the kind of BPH, after which he developed an altered sensorium. What is the cause of this? Okay, so what is the cause of this, guys? Okay, what is the cause of this? Can you please help me with this? So you did a whatever TURP, and after that the patient basically developed an altered sensorium. So what is the cause of this particular condition? Okay, so you're saying that it is hyponatremia. Very nice, guys. Okay, what is the answer? Where it is in hyponatremia? Okay, so what is this? This is what is the management of a patient with the BPH, benign prostatic hyperplasia. Okay, benign prostatic hyperplasia. So if I ask you, what is the indication? Okay, what is an indication? Indication of surgery in the patients with the BPH. Okay, so what you need to understand is, so first listen to me. Okay, so what you need to understand is that in the patients with the BPH, whenever the patient comes to you with the benign prostatic hyperplasia, what you need to do is first you start the patients on the medical management. So you start the patients on whatever the tamsulosin or the finasteride and all those particular stuff, but a point comes when the patient has to be shifted from the medical management towards the surgical management. So what I'm trying to ask you is that what is that particular point? What is an indication which is going to tell you that, you know what, now you can no more manage these particular patients on the medical management. You have to kind of operate on these particular patients. So what is that particular point, guys? Can you please help me with this? So when do you kind of say that, you know what, now you have to kind of operate? So please try to understand over here. There are various, so I'll talk to you about this because this is important also for you, important, okay, very, very important. So let's say if at all there is a patient who is having a bilateral hydronephrosis. What do you understand by the bilateral hydronephrosis? It means that there is a back pressure changes which is occurring on both the kidneys. So if at all there is a back pressure changes occurring on both the kidneys, ultimately the creatinine levels might kind of go up and ultimately the patients may land up into renal failure. So in these particular patients, what you have to do, you have to perform a surgery. That is one. What is the next one? So let's say if at all there is a patient who is having a recurrent episodes of UTI. Okay, so ultimately again and again the patients are having a urinary tract infection. Yes, again you have to kind of operate on these particular patients. Then what else? So let's say if at all there is a refractory urinary retention. What do you understand by a refractory urinary retention? It means that the patients were on the medical management, but still on the medical management, patients developed a urinary retention. This is what is called as a refractory urinary retention. Okay, so bilateral hydronephrosis, recurrent UTI, refractory urinary retention. What else? If at all there is a hematuria, okay, or if at all there is a formation of a urinary bladder stones. Okay, urinary bladder stones. You understand my point? So all these are the indications of performing a surgery. Now my whole point is, what is a surgery? What surgery do you perform in the patients with a BPH? So as you just told me, what you perform is TURP. What is this TURP? What is the full form of this? It is called as a transurethral resection of the prostate. Okay, what is it? Transurethral resection of the prostate. So that is what is a surgery which you're going to perform in these particular patients. Now, how do you perform this? Okay, so please try to understand how do you kind of do that. So this is, let's say, a kind of surgeon who is basically sitting and they are basically performing a TURP. Now what you need to understand over here, this is what is a screen. So here you basically kind of look like you basically look in the screen and then you operate. Okay, and you're basically sitting in that particular lithotomy position. The patient is in the lithotomy position, you're basically sitting down and you're basically operating. So you basically sit down and then you operate. Now what you need to understand, when you are operating on the patients with, let's say, a TURP or something like that. Okay, so first of all, what you're doing, so it is basically like taking out the scoops of the ice cream. Okay, so I hope you're able to appreciate this is what is a prostate gland. So when you start doing this particular TURP, what you do, you take the scoops out of it. Okay, so you take these particular scoops out and ultimately you kind of resect this particular prostate out. Okay, now how it is possible? With the help of this particular loop. Are you able to appreciate? So this is a loop. Okay, so this particular loop is made up of tungsten. Not that important. Okay, important, I think they had asked you once. So this particular loop is made of tungsten. Okay, and what you need to understand is that this loop, are you able to appreciate this? Okay, so what you do is this loop basically you kind of fix it onto a tissue, and then where you kind of fire a cautery or something like that, basically cuts the tissue. So it is basically like kind of scooping the tissue out. Okay, I hope you are able to appreciate. This is how you perform a TURP. Okay, now two things what you need to understand about this is that during surgery, okay, during the surgery, what you have to do is you have to put the patients, like continuous irrigation has to be maintained. Continuous irrigation is maintained. Okay, are you understand my point? So when you are basically performing this particular stuff, what you need to understand, continuous irrigation has to be maintained. Okay, now this particular continuous irrigation is maintained by what? Like what is the thing which you're using for this particular continuous irrigation? So that particular question is wrong. Okay, that's absolutely wrong. So why I'm trying to sell this? Okay, so let me just come back and let me just kind of clear a couple of myths with you. So what you need to understand, once they had asked you a question that which of the following is not used for the irrigation in the patients with TURP, and the options were mannitol, glycine, normal saline, and let's say distilled water. Okay, so these were the options which were given to you. The answer to that particular question was normal saline, but that particular question is actually wrong. Okay, so what you need to understand is that there are two types of TURP. Okay, so what are the types of the TURP? You have a monopolar TURP. So TURP can be of two types. It can be either a monopolar TURP, monopolar polar TURP, or you can have a bipolar TURP. Bipolar TURP. So what you need to understand is that if at all you're performing a bipolar TURP, the only irrigation fluid which you can use is normal saline. Only normal saline can be used. You understand my point? Only normal saline is used in the bipolar TURP. No other irrigation fluid will be helpful. But in the monopolar TURP, what you need to understand, you have glycine. That is what is the preferred irrigation fluid. But then you can have what you call as, okay, so this is what is a glycine. Okay, so please pardon my spelling. So what is this? This is glycine. Glycine. This is the preferred. Then what do we have? A distilled water. Okay, mannitol. You understand my point? So all these are the fluids which you can use, but the one which is kind of preferred over here is a glycine. Okay, I hope you have understood this particular point. So in the monopolar TURP, what you use is glycine. In the bipolar TURP, only thing what you can use is a normal saline. Okay, everything is clear till over here. So the question which they had asked you was ideally not a very accurate question. Okay, I hope you have understood this point. Okay, now okay, that's done. Now another important thing which you need to understand is what is the distal extent of the resection. Can anybody tell me what is the distal extent of the resection in TURP? Now this has also been asked to you a couple of times. Okay, so what is the distal extent of the verumontanum? Very nice. Okay, but why? What is the reason why verumontanum is the distal extent of the resection? Verumontanum. Okay, so that's great that you know this, but what I'll do is I'll just explain it to you about these particular things. Okay, VPR, I'll just explain it to you. So what you need to understand is, okay, let me just draw the kind of a image of whatever the basics of the anatomy of the bladder and all those particular stuff. What is this? Urinary bladder. Then we have a prostatic urethra. What is this? This dotted is a membranous urethra. Then we have a bulbar urethra, and then we have a penile urethra. So all these particular things are there. Now over here, what you need to understand is that here there is a urogenital diaphragm. Okay, there's a urogenital diaphragm, and what you have over here is a prostate gland. Now I'm drawing it as a cross section, that's fine, but what you need to understand, it is like a donut shaped gland which is basically sitting on the kind of a urogenital diaphragm, and it is encircling the urethra. And then what we have inside the urethra, there is a opening of a verumontanum. So here what is happening, the ejaculatory ducts are opening into this verumontanum. Okay, so this is what is the verumontanum, where the ejaculatory ducts are opening. Now what you want, that after the surgery has been done, do you want the patients to be able to control the urine? I guess so, right? I guess so, that you want the patients to control the urine. Now in order to control the urine, males have two sphincters. What are these sphincters? External urethral sphincter and an internal urethral sphincter. If I ask you where is this internal urethral sphincter present, so please try to understand, the internal urethral sphincter is present at the bladder neck. Okay, so the internal urethral sphincter is basically present at the bladder neck, and the external urethral sphincter is basically present in this urogenital diaphragm around the membranous urethra. Okay, now what you do, so I hope you have understood what is this. This is what is an internal urethral sphincter. What is this? This is what is a verumontanum. Verumontanum. What is this? This is an external sphincter. Are you understanding my point? So this is what is an external sphincter. Understood? Got it? Right? Now, what you need to understand is that when you perform a TURP and when you are basically kind of moving a scope inside the kind of a lumen, nothing, you're not able to appreciate that, you know what, this is a point where the external urethral sphincter is there, this is a point where the internal urethral sphincter is there. So whenever you perform a surgery, this internal urethral sphincter is always destroyed. Internal sphincter is always destroyed. Okay, now the external sphincter you have to kind of preserve. So let me just go back over here. So what you basically see inside is just like this. Okay, you just see like this. So here all this is like the covered with the mucosa, the red mucosa. You will not be able to appreciate, you know what, this is a point where the external urethral sphincter is basically starting or something like that. We are not able to appreciate it, but we are able to appreciate this verumontanum. This verumontanum is appearing as a hillock. So the logic says that if at all we restrict our kind of dissection proximal to the verumontanum, we will invariably end up preserving the external urethral sphincter. Are you understanding my point? This is very important, and that is why the distal extent of the resection is what? It is verumontanum, because we want to preserve the external urethral sphincter. Okay, I hope you are able to understand this particular point, guys. Okay, I hope you are able to understand this. Got it? Understood? Right? Okay, that's great. Now, okay, now lastly, let's talk about the complications. Okay, let's talk about the complications. So if I ask you what is the most common complication, what is the most common complication of TURP? What is the answer? It is retrograde ejaculation. Retrograde ejaculation. Okay, so why is this the most common complication? What is the most common kind of, why is this the most common complication? Okay, so can you please tell me, erection is a sympathetic or a parasympathetic kind of control? So erection is under the parasympathetic response, ejaculation is under the sympathetic response. Okay, so when the person ejaculates, what happens, that there is an increase in the sympathetic tone, and when there is an increase in the sympathetic tone, what is going to happen, these internal sphincters, they are receiving the supply from the alpha 1a receptors. So when there is an increase in the sympathetic tone, what is going to happen, this alpha 1a receptors are going to close, and if at all this alpha 1a receptor closes, what is going, this alpha 1a receptors are going to get stimulated, and the internal sphincter is going to close. So when like in the normal people, whenever there is an ejaculation, what happens, the sperm is not going to enter into the bladder. It might try, but the bladder neck is closed, so the sperms are basically coming out. But in the patients in whom you have performed this TURP, what you have done, you have destroyed this, what you call as an internal sphincter. So because you have destroyed this particular internal sphincter, whenever the ejaculation is going to happen, the semen is going to go into the bladder, and the patients are going to have a retrograde ejaculation. So that is why this is the most common complication of the patients with TURP. Like after TURP, that is what is the most common complication. Okay, I hope you have understood this point. Now the second thing what you need to understand is that, okay, urinary incontinence can happen. Urinary incontinence can happen. Incontinence can happen, but the important thing is about the TUR syndrome. So what is this TUR syndrome? TUR syndrome basically stands for your dilutional hyponatremia, and this was actually the question was all about. Okay, so TUR syndrome is nothing, it is the dilutional hyponatremia. Okay, so what is this? This is what is a dilutional hyponatremia. So what happens is, when the fluids are giving, like the continuous irrigation is going on, that particular fluid can get absorbed, and if at all you're doing a bipolar TURP, then it's fine, because the fluid which is going to get absorbed is in its normal saline, it has a lot of sodium. But if at all you're performing a monopolar kind of TURP and the fluids are getting absorbed, what is going to happen, the sodium levels are going to be relatively deficient. So the volume is going to increase, but the sodium levels are not going to be increasing, they're going to be the same. So the patients will land up into dilutional hyponatremia, and because the patients are having a dilutional hyponatremia, the patients are going to have all the signs and symptoms of hyponatremia, that is a confused state, convulsion, decreased whatever the mental status and all those particular stuff, and the treatment. Okay, so I hope you understand. So the clinical scenario will be like that, you know, that you performed a TURP on a patient, next day morning you went, you examined that particular patient, and the patient was kind of altered conscious, or the patient was having convulsion, or the patient was confused or something like that. What will you order? You will order electrolytes, because you want to look at the sodium levels. Okay, so once you have kind of done that, that's fine. What is the management? Okay, so if at all there is a patient who is having a TUR syndrome, the management is that first you kind of do the fluid restriction, and if at all that kind of doesn't help, then you have to perform, you have to kind of give the sodium supplementation. Are you understand my point? So this is how you manage the patients of your what you call as a TUR syndrome. Okay, so that's all about this particular TURP and all those particular stuff. Now let's talk about this dysphagia lusoria. Okay, so this dysphagia lusoria is because of what? Is it because of esophageal diverticulum, aneurysm of the aorta, esophageal web, or the compression by an aberrant blood vessel? Okay, yeah, what is the answer over here? Oh yeah, Saviti, right? Okay, so answer over here is D. Okay, answer over here is D. Now just give me a minute, guys. Okay, so BPR, thank you so much. Yep, that's fine. Now Saviti is asking about the Gleason score. So I cannot just kind of randomly talk to you about the Gleason score. What I'll do, I'll make sure that this is a part 1, right? In the part 2, what I'll do, I'll make sure to put a question on the Gleason score, and then I'll elaborate over it in a detail. Okay, so don't worry about it. Okay, will that be okay with you, Saviti? Okay, so please look at the I'll put it as the first question. Okay, I'll put it as the first question in the part 2. Okay, so that even if you don't want to watch the entire stuff, you can just watch that particular first question. It will take around 5 to 10 minutes, that's fine, but I want to show you a couple of images and I want to kind of build the base and then talk about it. So that will be kind of much better. Okay, Understood? So we'll talk about that. Okay. Now here, what is the answer over here? Compression by the aberrant blood vessel. Okay, guys, but what on earth is this particular aberrant blood vessel? Okay, so which aberrant blood vessel this particular question is trying to talk to you about? So it is basically trying to talk about an aberrant right subclavian artery. Okay, so it is basically talking about the aberrant right subclavian artery. Very nice. Okay, so what you need to understand is that the subclavian artery, the right subclavian artery, should ideally arise from the thyrocervical trunk, right? It should kind of ideally rise from there. But what you need to understand is that if at all this right subclavian artery is arising from this part of the descending aorta, so because it is arising from the left side, ultimately it has to go to the right side, right? So it is going to go from the left to the right side, and it is going to compress the esophagus posteriorly. The two things are important over here. What is this dysphagia? Why this is there? Okay, so first, what is it? There's a dysphagia. Why there is a dysphagia? Because the esophagus is being compressed by an aberrant right subclavian artery. Okay, so because the esophagus is being compressed by the aberrant right subclavian artery. And the last thing what you need to understand is that the compression is where? Is it like the anterior compression or the posterior compression? So please try to understand the esophagus is being compressed posteriorly. Okay, so very important point again. So what you need to understand over here, that the esophagus is getting compressed posteriorly. Okay, it is getting compressed posteriorly. Okay, I hope you have understood this particular point. It is getting compressed posteriorly. Very important point. Okay, got it? So that is all about the right subclavian artery. Nothing major about this. Okay, what is the investigation of choice? Obviously, the basic stuff. Investigation of choice is going to be obviously arteriography. Now this can be either a CT arteriography or whatever, the angiography or whatever you want to do, but yeah, this is what you basically have to diagnose it, and then for the treatment you have to kind of go ahead with a vascular kind of repair of it. But what they ideally ask you is that where it is kind of compressing the esophagus, anteriorly, posteriorly. What is it? Apparent right subclavian artery. Okay, so I think enough is enough. Right, now let's talk about this. This is something which has been asked to you previously in your NEET PG exam. So serpiginous ulcers in the lower esophagus are seen in. Okay, so what is this? What is this, guys? What is this? Is it seen in the CMV esophagitis, candida esophagitis, corrosive esophagitis, or a pill-induced esophagitis? What is the answer over here? So the answer over here is CMV esophagitis. Okay, so let's talk about the esophagitis, guys. Okay, so this is important. Okay, so first we'll talk about the pill-induced esophagitis. What is this pill-induced esophagitis? Sometimes when you kind of take the pills, and if at all it gets stuck inside the esophagus or something like that, it may cause an ulcerations in that. Okay, or let's say sometimes even when it is kind of you're swallowing it, and if it comes in contact with the mucosa of the kind of esophagus, it has a tendency to cause an esophagitis. Okay, so can you tell me which are the medications which are associated with this what do you call as a pill-induced esophagitis? There are so many, there are many of them, but one of the few of them are very distinctly associated with this. So can you please help me with this? Okay, so yes, bisphosphonates, very nice VPR. Okay, very nice. Okay, so let's kind of talk about what the Levin Bailey is trying to tell you about all these particular stuff, right? Okay, so what is the most common cause of an esophagitis? No doubt it is the GERD, gastroesophageal reflux disease, GERD or GORD, whatever you want to call it, that's what is it. Okay, now the medications which are associated with the pill-induced esophagitis is tetracycline, important, do not forget about this, potassium chloride tablets, non-steroidal anti-inflammatory drugs, and the bisphosphonates. So Levin Bailey has mentioned these four, so please do not forget about this. What are these? Tetracycline, potassium chloride tablets, then we have a non-steroidal anti-inflammatory drugs, NSAIDs, that's fine, and finally you have a bisphosphonates. Okay, so these are what is called as a pill-induced esophagitis are associated with these drugs. Now, if at all there is a pill-induced esophagitis, what you have a kissing ulcer. You have a kissing ulcers in the esophagus. So you have a kissing ulcer in the esophagus. That's fine. So both the walls are kind of involved. That's why it's called a kissing ulcer. Nothing major about this. Okay. Now there are three infections which you need to remember. One is the candida. Then you have a herpes simplex virus and the cytomegalovirus. Okay. So let's talk about these particular stuff. Okay. So in the candida, what you basically find is it's like a fungal infection. That's fine, and it is characterized by adherent, what you call as pseudomembrane. Okay, adherent white pseudomembrane. So this is what is a this is what is kind of what you're going to find over here. Okay, so what is this? This is adherent pseudo membrane kind of an appearance. This image is again important, directly from 11 Bailey. They can give you this particular image and they can ask you what is the infection. It's simple, it is a candida esophagitis. Okay, I hope you're able to understand this point. This is what is a candida esophagitis. Okay, now if you perform a barium swallow in these particular patients, you can have a pseudo esophageal varices. Okay, pseudo esophageal varices is something which is present in this particular candida. That's fine. Okay, now coming to the other two infections, so we have a herpes simplex virus infection and the cytomegalovirus infection. So answer to this particular question was a bit simple, because obviously in the candida you don't have an ulcers, and what you need to understand is that in the options they had given you just the CMV esophagitis. Okay, CMV ulcers. Okay, but yeah, both herpes simplex and the CMV both are going to present to you with an ulcers, but the difference is herpes simplex virus are going to have a punched out ulcers. It means that they're going to have a deep ulcers. The cytomegalovirus are going to have a superficial ulcers, shallow ulcers, or the serpiginous ulcers. Okay, so please try to understand this particular point, guys. Okay, so I'm just trying to show you the image. I hope you're able to appreciate. This is what is a punched out ulcer. This is what is a deep ulcer, which you're basically going to find in your what do you call it, cytomegalovirus. Okay, and then we have a herpes simplex virus, which is going to have the other ulcers. Okay, so that's what you need to understand over here. Okay, so here they did not give you, right, here they did not give you the herpes simplex virus, so then it is going to be your CMV esophagitis. Okay, so yeah, let me just kind of rephrase it. So here they had given you the serpiginous ulcers, and here out of the options which you have, all you need to understand is the cytomegalovirus was the only place where you could have found the ulcers, and that is why that is what is the answer. So corrosive esophagitis is not going to present like this. Corrosive esophagitis is going to kind of come to you with a stricture. Okay, it is going to come to you with a stricture. Pill esophagitis is something which is going to have a kissing ulcer. I just explained it to you. Do not forget about this. So what is a kissing ulcer? What you need to understand about the kissing ulcer in this, okay, so what are the medications which are associated with it? Bisphosphonates, potassium chloride tablets, and whatever, tetracycline. These are the important ones which you need to remember. Corrosive esophagitis, long segment stricture, or maybe the perforation, outright perforation. Candida esophagitis, it comes to you with a, what do you call it, pseudo, this pseudo membrane formation. Okay, pseudo membrane, whitish flakes kind of a thing on the esophagus. Herpes simplex virus is going to have a punched out ulcer, and the cytomegalovirus are going to have a more shallow ulcers. Okay, so that is what you need to understand over here. Maybe this particular image is a bit like this, but yeah, just forget about the image, just try to understand. Cytomegalovirus is going to have a more shallow ulcers, and the herpes simplex virus are going to have a punched out ulcers. Okay, I hope you have understood this particular point, guys. Okay, right now, yeah, that's pretty much it. Okay, I just took this particular image. I'll just recheck this particular stuff. I just took it from the internet, but yeah, that's fine. Forget about this particular image for now. Okay, forget about this particular image for now, but just try to remember that the herpes simplex virus is the one which is having a punched out ulcer, and the cytomegalovirus virus are going to have a shallow ulcers. Okay, and in the options they had only like the answer cytomegalovirus, because that was the only befitting or the most appropriate kind of answer to whatever the question was asked. Okay, I hope you have understood this particular point. Okay, got it. Okay, now let's talk about this. Maximum reduction in the gastric acidity is kind of achieved by what? So can you please help me with this? Maximum, what do you call as a, yeah, so maximum reduction in the gastric acidity is achieved by what? Truncal vagotomy with the pyloroplasty, or truncal vagotomy with an antrectomy, partial gastrectomy, or a highly selective vagotomy. What is the answer over here? D. Really, guys? No, all of you are marking D. Really? Yes, it is B, guys. B, truncal vagotomy with the antrectomy. Very, very important. Okay, so let me just talk to you about this. Okay, so okay, now first things first. Okay, so if I ask you guys that, you know what do we have? Do we have a right vagus and the left vagus, or do we have an anterior vagus or a posterior vagus? Okay, so what you need to understand, in the embryological period, when the child was kind of getting born and the development was happening and everything, during the intrauterine life, we had the right and the we have a right and the left vagus. Okay, so what you need to understand is, during the part of the development, the stomach rotates 90 degrees. So the left vagus becomes the anterior vagus and the right vagus becomes the posterior vagus. Are you understanding my point? So right is basically the posterior and the left is the anterior. Don't get confused in this. Okay, so left vagus is the anterior vagus, right vagus is the posterior vagus. Okay, I hope you have understood. Now let us talk about the branches. Okay, so let's talk about the branches. Let's first talk about the branches of your anterior vagus. Okay, so let's first talk about the branches of your anterior vagus. I'll show it to you in the image, but let's kind of understand it at this point of time. So anterior vagus basically comes down and it gives a branch to the gallbladder. Okay, it gives a branch to the gallbladder, which is called as a hepatic branch. Okay, it is a hepatic branch. Okay, now how does it help? It basically helps in the contraction of the gallbladder and all those particular things. It basically helps in that. Then it gives the branches to the stomach, which is parietal branches, which are going to help you in increasing the acid secretion. And then when it comes to the pylorus, it is going to give a crow's foot. It is going to give the multiple branches, which is called as a crow's foot. So I'll not confuse you any further. I'll just directly go on the image and I'll talk to you about this. So what you need to understand, this is what is an anterior vagus. Okay, I hope you have understood. This is what is an anterior vagus now. It is coming down and it is giving a branch. So what is this? This is what is a hepatic branch. Okay, so first branch is a hepatic branch, which is basically being given to your gallbladder. Okay, if it's a branch which you give to the gallbladder, that's fine. Now this particular anterior vagus is basically coming down and it is giving all these parietal branches. Okay, so what are these parietal branches? These are what is called as the nerves of Letaget. So there are like both the anterior and the posterior, both nerves, both vagus basically give these branches, which are called as the nerves of Letaget. Okay, so this is the one which is actually responsible for your HCl secretion. Okay, then what happens? The anterior vagus comes down and it gives the branches to the pylorus like a crow's foot. So this is what is called as a crow's foot. You understand my point? What is a crow's foot? These particular branches which you give to the pylorus, these are called as a crow's foot. Everybody understood this point? So please repeat after me. Let's not kind of put things for the next time. Let's try to revise right here, right now. What are the branches of the anterior vagus? Anterior vagus, first of all, is your left vagus. So what are the branches of the anterior vagus? The first branch is given to the liver, like the gallbladder, hepatic branch. Okay, then what we have is the nerves of the Letaget, which are given to the stomach, and then it basically comes to the pylorus and it gives the crow's foot. Okay, I hope you have understood this particular point, guys. Okay, understood? Right? Now what you need to understand, this is about the anterior vagus. Now let's talk about the posterior vagus. In the posterior vagus, what do you have? In the posterior vagus, you have the first branch is basically the cremalar nerve of Grassus. Okay, so please try to understand. This is the posterior vagus. I hope you're able to appreciate. This is in the dotted form. So this is the posterior vagus now. It comes and first it basically gives this cremalar nerve of Grassus. Cremalar nerve of Grassus. Why it is called the cremalar nerve of Grassus? I'll talk to you about that. Okay, I'll tell you why it is called the cremalar nerve of Grassus. Then it comes down and it gives a branch to this celiac plexus. Okay, so please try to understand the celiac branch. Okay, to the celiac plexus and the retroperitoneum, it basically gives the branch. Obviously, celiac plexus will be near the retroperitoneum. It makes sense that the posterior vagus is going to give a branch to that. Okay, gallbladder is anteriorly near to the anterior wall of the abdomen. So obviously, it makes sense that the anterior vagus is going to give a branch to the kind of gallbladder, hepatic branch. So nothing to memorize, guys. Okay, just pure logic. Okay, so posterior vagus, cremalar nerve of Grassus, that is the first branch. Then branch to the celiac plexus. Then what you have? These nerves of Letaget, which are basically given to this particular stomach, and then ultimately when it kind of reaches to the pylorus, it gives the crow's foot. Okay, so I hope you have understood. These are the branches of your posterior vagus. Okay, I hope you have understood this point. Now let's talk about the vagotomy. What is the purpose of the vagotomy? We want that the acid secretion should go down, and that is why we perform a vagotomy. So what you need to understand is there's something which is called the truncal vagotomy. So when we first started kind of doing this, what we thought that, you know what, let's go and let's cut these anterior and the posterior trunk together. So once if you cut that, what is going to happen? Obviously all the branches will be cut off and their acid secretion will be low. Obviously makes sense, right? So if at all you do a truncal vagotomy, what is going to happen? Maximum acid secretion. Now maximum reduction in the acid secretion. Okay, so the most effective vagotomy is a truncal vagotomy, but there's a small problem. There are other side effects also of that. What is the side effects? I hope you have understood that we are giving a branch to the hepatic. That's not just for the sake of it, right? We're also giving a branch to the celiac plexus. So this hepatic branch and the celiac plexus branch, they are also kind of cut. So gallbladder contraction is reduced. There is an increased risk of biliary stasis and the gallstone formation. In the celiac plexus, the branch does not go. So autonomic dysregulation can happen. And also this particular branch to the pylorus, that is basically cut. So there is a delayed gastric emptying. So these were the comorbidities or the side effects of a truncal vagotomy. Am I making some sense to you guys? So these were the side effects of your doing a truncal vagotomy. So first of all, what is a truncal vagotomy? You directly cut on these trunks. Okay, you directly cut the kind of a main trunk only. So anterior vagus, posterior vagus, you just cut it off. So if I write down that if at all you perform a truncal vagotomy, okay, so if at all you perform a truncal vagotomy, it is the most effective one. So there is a maximum reduction in the acid secretion Okay, so there's a maximum reduction in the acid secretion, but it is also having the maximum side effects or comorbidities, whatever you want to call it. It is the one which is having the maximum side effects or the comorbidity. Am I making some sense to you guys? Yep, I hope I'm making some sense. So what we got to know now, that there are too many side effects which are happening to this. So what we thought that let's kind of be a bit selective. So what do you understand by selective? Selective means that after the main branches have been given, for example, after this branch to the hepatic, like the liver and the gallbladder has been given, and after this particular celiac branch has been given, after that, if you kind of cut this particular vagus nerve, this is what is called as a selective vagotomy. So what is a selective vagotomy? Selective vagotomy is a vagotomy when you cut this particular vagus after you have given the hepatic branch and after you have given whatever the kind of the celiac branch. Understood? Obviously, it makes sense. The side effects will be lower, but still the pylorus branch is still not functioning. So the delayed gastric emptying was still kind of remaining. So we decided that, let's be a bit more creative. So what is this being a bit more creative? We said that, these are the nerves of Letaget. We will kind of ligate these nerves of Letaget individually. You understand my point? So we thought that let's kind of cut these nerves of Letaget only. Okay. So yeah, the idea was very nice. So if you kind of cut this only, what is going to happen? The rest of the side effects are not going to be happening, but we all are humans, right? And if at all we kind of screw up over here, or let's say if at all we miss a couple of nerves of Letaget or something like that, the chances of recurrence will be maximum. Are you understand my point? So in the highly selective vagotomy, what is a highly selective vagotomy? Highly selective vagotomy. Selective vagotomy. What you need to understand is sometimes you might miss to ligate a couple of nerves of Letaget or something like that. So here what you need to understand, the chance of recurrence is maximum, but the side effects are very low. Okay, but this is also the one which is having the least side effects or comorbidities, whatever you want to call it. Okay, I hope you're able to understand. This is the one which is having a least side effects or the comorbidities. Okay, now one thing which I did not tell you is about this criminal nerve regresses. Why on earth this is called as a criminal nerve regresses? So what you need to understand, when you're performing a selective vagotomy, so where are you cutting? So in the selective vagotomy, you're basically cutting this particular nerves after they have given this hepatic branch and the celiac branch, right? So if you kind of cut this, if you kind of cut this, and if you fail to ligate this particular criminal nerve regresses, then it might lead to the recurrence, because that was given prior to giving these particular branches. Okay, so that is what is called as a criminal nerve regresses. Okay, because it is associated with the recurrence if you fail to ligate it individually. Okay, I hope I'm making some sense to you guys. And finally, truncal vagotomy with the pyloroplasty and the antrectomy. Antrectomy is something which is kind of beneficial, because in the antrum, what is there? So maximum acid secretion happens in the distal part of the stomach, that is antrum. Pyloroplasty basically is done if at all you have a pyloric stenosis. So helicae, Mikulicz manure and all those particular stuff, that is what is done if at all you have a pyloric stenosis. But for the acid reduction, what you basically want is a truncal vagotomy with a antrectomy, because antrum is the part where the maximum acid secretion takes place. Okay, I hope I'm making some sense to you guys. Okay, yep, I hope I'm making some sense. Got it? Now let's move on to the next question. Identify the crystal depicted in the urinary microscopy. Okay, I hope everybody have understood what I was trying to tell you about the truncal vagotomy and everything. Any doubts, you can please ask. Okay, right. So what is the what is the answer over here, guys? What is the answer over here? Is it like a struvite stone? What exactly is this? Okay, yes, absolutely right, guys. Okay, what is this? This is what is a struvite stone. Okay, so see, whenever there is a patient who is coming to you with a colicky or the flank pain, or let's say a colicky pain in the urine. Okay, so there is a flank pain or the colicky type of pain. Okay, and there is, let's say, increased frequency. All those particular things are there. Increased frequency, burning mixation, all those particular things are there. You have to kind of do certain tests in order to diagnose. Okay, and you suspect, let's say if you suspect the patients to be suffering from a kidney stone, so there are various investigations which you do, but one of the investigations which you do is a urine examination. So what do you basically do in the urine examination? What you need to understand is you perform a urine culture sensitivity, and what you can perform is a urine routine microscopy. Okay, so if at all you perform this urine culture sensitivity, what are you going to find over here? Why do you perform a urine culture sensitivity? Culture sensitivity is to see for any infection. Okay, any infection. In the urine routine microscopy, what we primarily look for is the RBCs and the WBCs and everything, but we can also find crystals. Okay, so this is what is a crystal which you basically find in the urine routine microscopy. Now the casts and everything, they basically talk about that in your pediatrics and your medicine and all those particular stuff, but here what as a surgeon what we are concerned about is the crystals. Okay, so these are important things. Okay, now there are 4 important crystals which you need to understand. Dumbbell shaped crystal is seen in, can you please put it in the comment box? Where do you find the dumbbell shaped crystals? Where do you find the dumbbell shaped crystals, guys? Can you please help me? Where do you find the dumbbell shaped crystals? Dumbbell shaped crystals are basically seen in calcium oxalate monohydrate. Please try to remember this, guys. Dumbbell shaped crystals are basically seen in the calcium oxalate monohydrate. Then we have a bipyramidal. This is also called as an envelope shaped or a tetrahedral crystal. So this is envelope shaped or tetrahedral. You understand my point? So this is what you need to understand over here. This is what is a dumbbell shaped crystals. Okay, now it is not that visible, not that properly visible, but this is what is a tetrahedral or an envelope shaped crystals. Okay, so this is what is calcium oxalate dihydrate. Now then what is this? This is what is a coffin lid crystals. Okay, so this looks like a coffin lid, so this is what is a coffin lid crystal. And then what do we have? This, what is this? This is an hexagonal crystal which you basically find in the cystine stones. Okay, so these 4 crystals are absolutely must. Even in the recent INI-CT exam, I think they had shown you this coffin lid crystals or something. So they are important. Okay, they are absolutely important. You should know about them. So nobody kind of uses that much in the practical life. Everybody relies on, okay, what is the investigation of choice for diagnosing a renal stone or a ureteric stone or something? What is the investigation of choice? Can you please help me with that? The answer to that particular question is a non-contrast CT scan. Okay, non-contrast CT scan. Okay, that is what is an investigation of choice. But for the theoretical purpose, what you need to understand, you have to know these particular things. So calcium oxalate monohydrate is going to have a dumbbell shaped crystals. Dihydrate is going to have an envelope shaped crystals or a tetrahedral crystal. Screw white stone or the screw white stones or the are going to stag on stones are going to have a what you call as your coffin lid crystals, and the cystine stones are going to have the hexagonal crystals. Okay, so these are the different types of the crystals which you have on the urine routine microscopy. Okay, now, okay, so what is the best investigation to look for T and N stage? Okay, so what is the best investigation to look for T and N stage in the patients with an esophageal cancer? Okay, what is the best investigation to look for T and N stage? What is the answer over here? Best investigation to look for T and N stage is, yes, it is an endoscopic ultrasound. So please try to understand, very important. Okay, so endoscopic ultrasound. What is this endoscopic ultrasound? What you do is you do an upper G endoscopy, and at the tip of this particular upper G endoscope there's an ultrasound probe which is attached. So this is what is in, and this is how you perform an endoscopic ultrasound. Now what you need to understand is that when you do this particular upper G endoscopy, what you're able to appreciate, you are able to appreciate an image like this. Okay, so I hope you are able to understand this. So what you need to understand, these are the different layers of the esophagus which you are able to kind of delineate. How are you able to delineate? Because of this hyperechogenicity and the hypoechogenicity. So in the ultrasound, what do we have? We have a hypoechogenic and the hypoechogenic. Hyperechogenic means it is appearing white. Hypoechogenic means it is appearing black. Okay, so this is something which you should remember. So for example, this, if I ask you muscularis mucosa, it is going to appear hyperechogenic or hypoechogenic. The answer is hypoechogenic. Okay, so what do we have? We have this mucosa, then what do we have? A muscularis mucosa, then we have submucosa, then we have a muscularis propria, and then we have an adventitia. So this basically follows whatever the alternative sequence. So please try to understand over here. Mucosa is white, then muscularis mucosa is going to become black. Submucosa is white, it's appearing white, that is hyperechogenic. So muscularis propria is going to become black, and adventitia is again white. You understand my point? So nothing to kind of memorize over here. All you need to understand, if at all there is a layer which is having a muscle component, so muscularis mucosa and the muscularis propria, that is what is going to appear black. So the muscle is the one which is going to appear black on an ultrasound. Okay, so why this is helpful? Because when you perform an upper G endoscopy, and let's say if at all there is a tumor which has gone up till this point, so now you can say that, you know what, it is a tumor which has kind of involved the muscularis mucosa. You understand my point? So this is how it is going to tell you about the T and N stage of the tumor. Understood? Investigation of choice for the T and N stage of the tumor is endoscopic ultrasound. This is how it works, and you should remember about these particular whether this particular layer is appearing hyperechogenic or hypoechogenic. Nothing to memorize over here. All you need to understand, mucosa is white. Any layer which is going to have a muscular component, that is what is going to appear black. Okay, I hope you have understood this particular point, guys. So now what we have done, we have completed 15 MCQs. We'll take a short break and then we'll come back again. Now, before going, I will just address one particular question. So somebody had asked me that, you know what, is this particular session enough for FMG? How it can be? It cannot be enough for FMG, but yes, these are the important topics. You might expect a couple of questions from these particular topics and all, that's fine. But what you need to understand is the holistic revision of any particular subject is important. Now, there are two things what I can do. I can just quickly rush through the top superficial parts of all this, most of the parts of the surgery, but I personally feel that is not a good idea. So what I'm trying to do over here, if at all I'm taking up a particular topic, I'm trying to explain it to you in a better manner. So what you need to understand is that yes, this is definitely going to help you for your FMG as well as the NEET PG, no doubt about it. But this particular session, it cannot be enough for your FMG and NEET PG, right? How it can be enough? It cannot be enough. Okay, so today I'll be teaching for around 5 hours. Then the second part is going to be around 5 hours. So I will try to cover, let's say, around 60-70 important topics, no doubt, but the entire surgery may be having, let's say, 1500 topics or 1200 topics. So yeah, everything cannot be covered. Okay, I hope you have understood this particular point. Now, towards the end of the session, what I'm going to do, till what time? So class will go until 1 o'clock. Okay, around 1 o'clock the class will go on. That is the first thing. Second thing, towards the end of it, I'll just tell you my kind of a small bit about the strategy which you can follow for this particular upcoming exam and all this particular stuff. So we'll share it towards the end of it. Okay, so yeah, let's kind of stay awake till around 1 and let's kind of talk about this. Okay, so we'll have kind of a break of around, let's say, 25 minutes or something, 25 minutes. Okay, and then we'll kind of meet back again. 25 minutes, 20 minutes per se. Okay, so what we'll do, you guys come by around 10:30. I'll start by around 10:30 or something like that. Okay, we'll start soon. You come back by around 10:30, we'll start it. Okay, bye, see you soon. So hi guys, welcome back. Okay, what you're going to do, we are going to start with our session further. Yeah, I hope I'm audible and visible to you. Just give me a thumbs up if I'm audible and visible to you. We're going to start with our kind of session now. Okay, so we have covered till question number 15. Now we are moving on to the question number 16. So yeah, can you please help me with this? All okay? Okay guys, right? Okay, so let's start with this guys. So let's start with this. What you need to understand over here. Okay, got it. Okay, so what is the answer over here? So there's a lactating kind of a female which is presenting with the breast abscess. Most common organism responsible for her mastitis and the abscess formation is what? The answer over here is yes, absolutely. The answer over here is Staphylococcus aureus. Okay, what is it? It is Staphylococcus aureus. So let's kind of talk about the breast abscess. Okay, so let's talk about the breast abscess. So what you need to understand about the breast abscess. So this breast abscess, if I ask you about this particular breast abscess, what is the cause? Okay, what is the cause of this particular breast abscess? What is the most common cause of the breast abscess? Can you please help me with this? Okay, what is the most common cause of a breast abscess? So the most common cause of the breast abscess is what? It is lactating kind of mothers. Okay, so the mothers who are basically performing a breastfeeding. So what happens is that during the breastfeeding, there is crack in the nipples. Okay, so the most common cause is your breastfeeding. Okay, so during the breast feeding, what is going to happen? If at all there is a crack in the nipple, what can happen? The organisms can basically go up from this particular cracked nipple and they can lead to the abscess formation. You understand what? They can lead to the abscess formation. This is what is responsible for your breast abscess. Okay, as simple as that, nothing major about this. What is your clinical presentation? Okay, so how will the patients present to you? Okay, what is going to be the clinical features of these particular patients? So patients are going to have pain, patients are going to have increased temperature, they're going to have a fluctuant swelling. So all these particular things are going to be there. Okay, fluctuant swelling. Okay, now my question to you is, if at all there is a patient who is having a breast abscess, how will you manage that particular patient? Okay, so I hope that you are answering that itself. Like, how are you going to manage the patients? Can you please put it in the kind of a comment box, guys? Yep. So how are you going to manage the patients of a breast abscess? So I told you the most common kind of causes, the breastfeeding, crack to the nipple, blah blah blah. Yep. So how are you going to manage these particular patients? Okay, dicloxacillin, antibiotics. Okay, that's fine. IND, right? Yeah, definitely. Yeah, hot compression. Okay, what else? So I'm talking about the surgical intervention, right? Oh, you will do an IND, right? Yes, that's what you like. Yes or no? No, guys, no. Please try to understand. IND is not done in these particular patients. I wanted you to answer it so that you will remember it for a prolonged period of time. Okay, so before I move on to the treatment, I just want to cover one more thing. What is the most common organism which is associated with this? It is E. coli, guys. Okay, what is the most common organism? It is an E. coli. So cracked nipple, E. coli infection, this is what is your breast abscess. Okay, now the management of this particular stuff is never IND. Treatment is IND is not done. Are you understand my point? Incision and drainage is not done. Are you understand my point? Incision and drainage is not done in these particular patients. Why? Why will you not prefer to do an IND? So just think about it. Okay, so earlier, like 5 years back, we used to have a conversation that what type of an incision are you going to give? Are you going to give your circular incision or a radial incision? So at that point of time, we used to debate that, you know what, let's give a radial incision. Why radial incision? Because the chances of injury to the ducts are going to be very, very less. You understand my point? But we all are humans, right? So no matter how hard you try, you will end up injuring some or the other ducts. And if at all you perform an IND, what is going to happen? There's going to be the blood, like the milk is going to keep on kind of dribbling from whatever that injured duct, and that is what is not going to be at all nice. Okay, because the patient is breastfeeding, right? The breast like the milk production is kind of continuous, and if at all you end up injuring certain duct, what is going to happen? The milk is going to kind of keep on coming out of it. So during my residency, we had a patient. The patient had a kind of a breast abscess. We performed an IND in that particular patient. What happened was, after the kind of incision drainage was done, the patient used to kind of drip milk a lot. Okay, so that was way back around like quite a lot of back time, but at that point of time, IND was kind of usually kind of done. I hope you have understood this particular point, right? So we ended up doing a IND in that particular patient, and this dressing which we used to get kind of soaked within half an hour, 1 hour, something like that. So what you need to understand is that the treatment for a breast abscess is what that you have to kind of treat it, right? So how are you going to treat it? So please remember, do not forget about this. Your Love and Billy has stressed so much on this. So the treatment is USG guided aspiration. USD guided aspiration. Are you understand my point? Ultrasound guided aspiration of the breast abscess. Okay. Now let's say you obviously along with that, no doubt you are going to give the antibiotics. No doubt about it. Antibiotics are definitely given. But what is the surgical intervention? The surgical intervention is USD guided aspiration. Okay. Now, if at all you did a USD guided aspiration, and if at all there is a recurrence. Okay. If at all there is a recurrence, now what you're going to do? Reaspiration. Please try to understand, even if there is a recurrence, you do a reaspiration. If they give you that there are multiple abscesses, what are you going to do? Multiple aspirations. Okay. At the max, you can leave in a drain over there. That's fine. But it is never an IND. I hope you are able to understand this point. IND is not the treatment for the patients of not 2 times, even 3 times. Okay. You understand my point? So no kind of IND in these particular in these particular patients. Okay. Kindly, why are we not doing IND? Did you just join? Okay, so I'll just explain it to you again. Why you're not doing an IND? See, this is a patient who is breastfeeding. If you end up injuring one or the other duct, what is going to happen? The milk production is kind of continuous. So the milk will continuously leak from that particular duct, and it is going to be very, very not good for the patient, because the clothes, the dressing, everything will get soaked with the what you call as the blood. Infection will go away, no doubt about it. But the milk will continuously keep on dribbling from that injured duct. Okay, I hope you have understood this particular point. Got it? Enoch Gabriel, I hope you have understood this particular point. So yeah, that is what you need to understand. What we have to do is we have to go USD guided aspiration. Okay, right. Now let's move on to the next question. Now this is an interesting one. There's a 60-year-old female patient with a history of a recurrent abdominal pain. Imaging shows multiple small cystic lesions like bunch of grapes in the head of the pancreas with a grossly dilated main pancreatic duct. Okay, so there's a grossly dilated main pancreatic duct. ERCP was performed and you got an image like this. So what is the diagnosis? Okay, ERCP was performed, you got an image like this. What is the diagnosis? Okay, can anybody tell me, guys, what is the diagnosis over here? So what we are dealing with over here is the cystic lesions of the pancreas. Okay, what are we dealing with? We are dealing with the cystic lesions of the pancreas. What is the diagnosis? Mucinous, MCN. Okay, anybody else? Please attempt. What is the diagnosis over here? T, pancreatic pseudocyst. Okay, anybody else? The answer over here is IPMN. Okay, answer is C. Okay, very nice, very nice. Okay, the answer is C, IPMN. Okay, so let's try to talk about the cystic lesions of the pancreas. Okay, so what you need to understand is that let's talk about the cystic lesions of the pancreas. Cystic lesions of the pancreas. Okay, so what are the cystic lesions of the pancreas, guys? What are the cystic lesions of the pancreas? The cystic lesions of the pancreas are that, what are these particular cystic lesions of the pancreas? What you need to understand. So first is the pseudocyst. Let's forget about this, like it's a kind of completely a different entity. But then you have certain cystic kind of lesions. Okay, so you have a like true cysts. True cysts. Now these two stress cysts can be further divided into those which are kind of benign and those which are kind of malignant, or they have a malignant potential. So what are the benign ones? So please try to understand, this is what is a serous cystic neoplasia. What does this SCN stands for? SCN basically stands for your serous cystic neoplasia. This is serous cystic neoplasia. Okay, you understand my point? So this is what is a serous cystic neoplasia. What about the malignant one? The malignant one can be either IPMN, or it can be what it can be. It can be either IPMN, or what it can be. It can be MCN. So what is this IPMN? IPMN basically stands for intraductal papillary mucinous neoplasia. what is this MCN? MCN basically stands for mucinous cystic neoplasia. I understand my point. So please do remember this. First of all, let's just let you familiarize with these particular terms. Okay. So broadly, what we need to understand about these three things. Serous cystic neoplasia, IPMN is intraductal papillary mucinous neoplasia, and the mucinous cystic neoplasia, MCN. Am I making some sense to you guys? Okay. So we have a serous cystic neoplasia, IPMN, and mucinous cystic neoplasia. Yes. Right. Okay. Right. Now let's have a look at this particular what you call as a flow chart. Like this is what is a kind of a tabular column which is going to help you in kind of understanding about all these things. Okay, so let's kind of take it one by one. So first is the serous cystic neoplasia, then we have mucinous cystic neoplasia, and then we have a IPMN. So what about the serous cystic neoplasia? This is the one which is more common in the females as compared to the males, and the ratio of that is 4:1. Okay, so yeah, that's fine. So serous cystic neoplasia is more common in the females as compared to that of the males. What about the mucinous cystic neoplasia? That is again more common in the females as compared to the males, and here the ratio is 10:1. Now you understand my point? Here the ratio is even higher, 10:1. Okay, so serous cystic neoplasia ratio is 4:1. Mucinous cystic neoplasia the ratio is 10:1. What about the IPMN? In the IPMN, what you need to understand, the females and the males are equally, like it is equally present in the females and the males. Okay, so I hope you have understood this particular point. Serous cystic neoplasia, mucinous cystic neoplasia, and the IPMN. Serous cystic neoplasia ratio is 4:1. Mucinous cystic neoplasia ratio is 10:1. IPMN is equal. Okay, now when you talk about the age group, it is broadly the same. All of these particular things are present in around 50, 60, 70 years of age. That's all fine. Now the next thing is about the distribution, whether it is present in the head, body, or the tail. Okay, so when we talk about the serous cystic neoplasia, what you need to understand, it is equally distributed. Okay, so the serous cystic neoplasias are evenly distributed in the head, equal to body, equal to tail. Okay, so this is equally distributed between the head, body, and the tail. Okay, so this is equally distributed between the head, body, and the tail. What about the mucinous cystic neoplasia? They are more common in the body and the tail as compared to that of the head. Okay, so here it is more in the body and the tail, that is the distal part of the pancreas, as compared to that of the head. Okay, I hope you have understood. And then finally what we have is an IPMN. Here it is more common in the head. Okay, it is more common in the head of the pancreas. We are talking about the pancreas, right? All these are the pancreatic cystic neoplasia. Okay, now I understand that many of you might be kind of finding this a bit alien, but just stay with me. After 5 minutes, you will be able to answer most of the questions on these particular cystic neoplasia. So just stay with me. Okay, so till now what we talked about whether it is more common in the females and the males, and we talked about whether it is more common in the head, body, or the tail, and all those particular stuff, right? Now the next thing is about the characteristics. Okay, so for the what you call as this serous cystic neoplasia. So what are the kind of characteristics of a serous cystic neoplasia? Here it is the one which is having multiple small cysts which are separated by the internal separations. That's all fine, but here there is a starburst calcification. So what do you basically find over here? You find a starburst calcification in the patients with the serous cystic neoplasia. Starburst calcification. Then in the mucinous cystic neoplasia, what do you basically find? You find an eggshell calcification. Okay, eggshell calcification and an amyloid stroma. Okay, like ovarian stroma, not the amyloid stroma. Obviously, amyloid stroma was present in the medullary calcified thyroid. Over here, what you find is an ovarian stroma. Okay, please do remember ovarian stroma and the eggshell calcification. These are basically present in the mucinous cystic neoplasia. Are you understand my point? So these are the things which you need to remember about the mucinous and the serous cystic neoplasia. Okay, then finally, forget about all these particular things. Past staining and everything, just forget about this. Yeah, till here you just remember. Okay, so yeah, might be a bit boring, but what I'll do, I'll just kind of talk to you one-on-one. Okay, so we talked about three things. We talked about serous cystic neoplasia, mucinous cystic neoplasia, and the IPMN. So what about this particular serous cystic neoplasia? This is more common in the females as compared to the male. That's fine. What is the ratio? Ratio is 4:1. What about the mucinous cystic neoplasia? That is again more common in the females as compared to the males. The ratio is 10:1. And when we talk about the IPMN, that is equally present in the males and the females. That's fine. Now we talked about the age group, that is kind of same, 50, 60, 70 years, all of these. Talking about the distribution. So the serous cystic neoplasia is equally distributed in the head, body, and the tail. Then we have the mucinous cystic neoplasia. That is what is more common in the body and the tail, not common in the head. And then what we have is the IPMN. IPMN is more common in the head of the pancreas rather than the rest of the things. Okay. Then we talked about the characteristic features. So in the serous cystic neoplasia, what we have is a starburst calcification. In the mucinous cystic neoplasia, what do we have? We have an eggshell calcification and an ovarian stroma. Okay, so till here, I hope you have understood this particular point. You will get this particular annotated PDF and you can kind of go through this particular stuff. It is important. Okay, so it is not a mainstream kind of a topic, but it is an important topic. So I hope you have understood. Okay, now what you need to understand is that this is all about the theory. That's all fine. But let's say in the real life, okay, let's say in the real life, let's say if at all you're a treating doctor, and what you find that there is a patient who is coming to you with a pancreatic cyst. Pancreatic cyst. So don't you want to diagnose what is this particular pancreatic cyst? Okay, so whether it is a serous cystic neoplasia or whether it is a mucinous cystic neoplasia or whether it is a IPMN, don't you need to kind of diagnose it? Yes, you do need to diagnose it, right? So how do you kind of do that? Okay, so if I say that, you know what, if at all you perform an endoscopy and what you do, you basically with the help of an ultrasound, what you're going to do, you may aspirate the fluid. Okay, what you do, you aspirate the fluid from the cyst. Okay, what you do, you perform an upper GI endoscopy and with the help of an ultrasound, you aspirate the fluid from the cyst. And what you do with this particular fluid, you send it for the examination. You send it for an examination. And what are things are you going to kind of look in this particular examination? Okay, what are the things which you're going to look in this particular examination? So what you need to understand over here, that I say that you have to look for three things. What all things you have to kind of look for? You have to look for mucin staining. You have to look for amylase level, and you have to look for whatever CEA levels. Okay, mucin staining, amylase level, and the CEA levels. Now, one thing I did not tell you, I'll just cover it over here. Okay, now, did you understand this particular point? So what I'm trying to tell you is that there is a patient who is basically coming to you in the real life, and the patient is having a cystic kind of lesion of the pancreas, and you are the one who is going to diagnose this particular patient. How are you going to do that? What you can do is you can do an upper GI endoscopy and you can put a needle into that particular cyst and you can aspirate the fluid out of it. And the fluid which you have aspirated, you will send it to the laboratory and you will see three things. What are you going to think? What are you going to see? You're going to see this mucin staining, whether that particular thing is having the mucin stain or not. You will see whether there is an amylase which is kind of present in that particular fluid or not, and you will see whether CEA levels are elevated or not. This is what is going to tell you, like after you get the results of all these three, that is going to tell you that what type of cyst you are dealing with. Okay, I hope you are able to understand this particular point. So over here, what you need to understand is that if at all the mucin staining is absent, okay, if at all the mucin staining is absent, amylase levels are negative and CEA is also negative. You understand my point? So this is what is going to tell you that, you know what, you're dealing with a serous cystic neoplasia. Serous cystic neoplasia. So first of all, serous, obviously the name says it is serous, so obviously mucin staining will not be present. What about this amylase? When will the amylase levels be high or low in these particular patients? Okay, so it is not negative, it is basically low. Okay, so amylase levels are low. When are these particular things going to be low? It is going to be determined by the communication with the main pancreatic duct. Am I making some sense to you guys? If at all there is a cystic lesion which is communicating to the main pancreatic duct, what you need to understand is that it is going to have increase in the amylase levels. But if at all the kind of cyst is not communicating with the main pancreatic duct, the amylase levels are going to be low. So in the serous cystic neoplasia, amylase levels are low. What it means that the communication with the main pancreatic duct is no, or that it's not present. Okay, I hope you have understood this particular point. Now, if we talk about the mucinous cystic neoplasia, if at all we talk about the mucinous cystic neoplasia, what do you think about the mucin levels? It is a mucinous cystic neoplasia. Obviously, it is going to be present, right? Mucin staining is going to be present in this particular stuff. What about the amylase levels? So please understand, amylase levels are low. And what about the CEA level? CEA levels are present. Okay, it is positive. You understand my point? CEA levels are kind of positive in these particular patients. I hope you are able to understand this particular point, right? So here the CEA levels are kind of positive in these particular patients. Okay, right? Now, okay, just give me a minute. Yeah. So yeah, here what you need to understand that the CEA levels are going to be positive, or CA levels are going to be high. CA levels are going to be high. What did I tell you? That the mucinous cystic neoplasia and what you call as IPMN, they both are malignant potential. So CEA levels will be elevated if at all what you're dealing with is a malignancy. Okay, right? Now finally what we have is a IPMN. Okay, so final is what is there? IPMN, intraductal papillary mucinous neoplasia. So in the IPMN, what about the mucin staining? Intraductal papillary mucinous neoplasia. So obviously the mucin levels are going to be positive or present in this particular patient. Okay, now what about the amylase levels? They are also going to be high because IPMN is communicating with the main pancreatic duct. And finally about the CEA, that is also going to be high because this is the one which is having the malignant potential. So am I making some sense to you guys now? So how do you diagnose these particular things? How do you diagnose this? You diagnose this when you perform an upper GI endoscopy. You put in an with the help of an endoscopy, you put in a needle and you aspirate the fluid out of it. You aspirate the fluid, you send it for the kind of a pathology, and then what you basically microscopy, and then you kind of find all these things: mucin staining, amylase, and the CEA. If at all the mucin staining is absent and amylase levels are low and this CA levels are also low, that is what is a serous cystic neoplasia. If the mucin staining is present, amylase levels are low, CA levels are high, that is what is a mucinous cystic neoplasia, and IPMN, all the three are going to be kind of present. So mucin is high, present, amylase is high, and CA is high. Okay, so just go through this particular table, guys. So this is what I was trying to talk to you about. I was trying to explain to you. So I hope you have understood that amylase are going to be high if at all there's a communication with the main pancreatic duct, and the CA levels are going to be high if at all you're dealing with a malignancy. Okay, right? So the drug of choice, yes, I will try to increase it. So this was a slightly complex topic, so I understand that you might be kind of knowing this, but you know, many people might not be knowing this. That's why I was going a bit slow in this particular topic, but I hope you have understood. Okay, so everybody have understood about the cystic neoplasia of the cystic lesions of the kind of a pancreas? Yes, I hope you understood this particular point. Okay, so now let's quickly go on to the next question. Okay, so there's a 72-year-old man which is presenting with the kind of lesion on his back. His appearance has been shown below, blah blah blah. What is the diagnosis? Can you please help me with this? What is the diagnosis over here? A very, very important image, very, very simple image. Okay, options you want, right? So what is the most probable diagnosis? Is it like a melanotic malignant melanoma, or squamous cell carcinoma, or the basal cell carcinoma, or the Kaposi sarcoma? What is the answer over here? What is the diagnosis, guys? What is the diagnosis? Come on, guys. What is the diagnosis? So the diagnosis over here is no, it is C. Okay, what is the diagnosis? It is C, guys. Okay, so this is an image, this is a C. So I'm pretty sure that you guys would have read about this rolled out ulcers and the everted edges. So where do you find the rolled out ulcers? Rolled out edges. Okay, where do you find the rolled out edges? Rolled out edges are basically seen in basal cell carcinoma, right? BCC, right? What about the everted edges? Everted edge with indurated base. Indurated base. This is what you basically find in the squamous cell carcinoma, right? I'm pretty sure that you would have read about these quite a lot of times. But what you need to understand is that in the basal cell carcinoma, it is having various subtypes, right? So what is the most common type of the basal cell carcinoma? It is nodular. Okay, and the characteristic thing which you basically find in the nodular type of the basal cell carcinoma is we have a dilated telangiectatic vessel with an umbilicated nodule. Okay, please try to understand. If they give this particular description, dilated telangiectatic vessel with an umbilicated nodule, even in the absence of the image, the diagnosis is basal cell carcinoma. Please do remember this. Okay, it is a very, very important thing. Okay, so what you need to understand is over here. I hope you're able to appreciate this. So are you able to appreciate these things? Okay, so this is what is your dilated vessels. Okay, so these are the small dilated vessels. These are the telangiectatic vessels, and the umbilication is not that greatly shown over here, but the central umbilication is kind of present in these particular patients. Umbilication, all of you know, understand what is an umbilication. Central depression is kind of present. So nodule with a telangiectatic vessel with a central umbilicated nodule, that is what is a basal cell carcinoma. So we do read about these particular ulcers and the edges and all those particular stuff, but the most common type of a basal cell carcinoma is nodular. Okay, I hope you have understood this particular point, guys. Okay, got it? Okay, now let's move on to the, it's a very important and the characteristic thing, guys. Okay, so do not kind of forget it. It's very important. Okay, so now let's talk about this. Okay, a 25-year-old male patient with an alleged history of a road traffic accident sustained an injury over the chest and the abdomen. At the time of the presentation, the systolic blood pressure of the patient was 70 millimeters of mercury and the pulse rate was 110 millimeters of mercury. What is the next step in the management of this particular patient? Okay, so can you please help me with this? The patient coming to you with the trauma, road traffic accident, whatever, the systolic blood pressure was 70 and the pulse rate was 110 per minute. Okay, what is the diagnosis? Can you what is the next step in the management of this particular patient? Anybody, guys? Anybody? So please tell me, guys, what is this? What is the next step in the management of this particular patient? Fast. Yes, absolutely right. The answer over here is fast. Okay, so quickly let me just revise fast with you. What does fast stands for? What is the full form of fast, guys? So the full form of fast is focused assessment sonogram for trauma. Okay, what is it? It is focused assessment sonogram for trauma. Do not mark it as abdominal. Okay, it is a focused assessment sonogram for trauma. Okay, now what is this particular fast? It is nothing. It is basically an ultrasound which you are basically performing in the emergency room. And the thing is that it basically it's completed in what you call as 3 to 4 minutes. Okay, it is basically completed in the 3 to 4 minutes. Okay, now whatever we do in our life, it should have some aim. So what is an aim of performing a fast, guys? Okay, what is an aim of performing a fast? The aim of performing a fast is to detect intraperitoneal fluid. So what you need to understand over here, that intraperitoneal fluid has to be kind of detected. Okay, I hope you're able to understand this point. Now, you and I, do we have an intraperitoneal fluid? No, right? I mean, we have very similar mode, fight animal or something like that. But let's say if at all you and I end up having a lot of intraperitoneal fluid, it is after a trauma, it is an indirect indication that there is some significant intra-abdominal injury. So after a trauma, if at all you perform a fast and if at all there is a very high intraperitoneal fluid, it is an indirect indicator that what the patient is having is a what you call as a significant intra-abdominal trauma. Are you understand my point? So that is what you need to understand. That is an aim of performing a fast. So how much amount of the fluid can you detect? Okay, how much fluid can you detect? Can you please help me with this? How much fluid are you able to diagnose in the patients with the fast? So around 100 to 150 ml. Okay, so you are able to kind of diagnose 100 to 150 ml. That is what you can kind of diagnose in the patients with the fast. Okay, so how do you perform this particular fast, guys? How do you perform this particular fast? So you have this particular what you call as a Ziffy sternum and all those stuff. This is what is a costal cartilage. This is what is an abdomen. This is what is a pelvis. Okay, so what you basically do, you keep your probe in the epigastric region. In the epigastric region, when you kind of keep the probe in the epigastric region, you're trying to detect the fluid in the pericardial space. So you're basically trying to detect the cardiac tamponade. Okay, so what you're trying to detect over here, you're basically trying to detect the cardiac tamponade. Cardiac tamponade. Then you can have this particular thing in the right hypochondriac. So in the right hypochondriac, what you're trying to detect, you're trying to detect the fluid in the around the liver. Okay, so here what you're trying to detect, you're basically trying to detect the fluid around the liver. Then you keep the probe in the left hypochondriac region. So here what you basically detect, you're trying to detect the fluid around the spleen. And then what you are able to what you're trying to detect, you're trying to detect in the pelvis. So here you're trying to detect the fluid in pelvis. You understand me? Fluid in pelvis. So this is how you basically perform a fast. This is basically done in the emergency room. What you do, you take up a probe and you keep the probe at 4 positions: epigastric, right hypochondriac, left hypochondriac, and the pelvic region, and you're trying to detect the fluid in all these particular places. How much amount of fluid are you able to detect? 100 to 150 ml amount of the fluid. That is what you're able to detect. But with the fast, and do not forget, it is a focused assessment, it is not focused abdominal. But with the fast, are you able to comment on the hemothorax or the pneumothorax? The answer is no. Are you able to accurately tell about the retroperitoneal fluid? The answer is no, big no. Fast is for the intraperitoneal fluid. It is not for the retroperitoneal fluid. Okay, so please do remember that. Okay, so in order to solve that particular complication, what do we have? Not for the retroperitoneum, for the hemothorax and the pneumothorax, we have something which is called as an E-fast. What is this E-fast? E-fast is basically an extended fast. Okay, what is this? Extended fast. So what you basically perform in this particular extended fast is that you keep the probe at 6 positions. Okay, you keep the probe at 6 positions. You mean that you have kept it in the epigastric, right hypochondriac, left hypochondriac pelvis. So here you kind of keep the probe at the 6 positions. So what is the 6th position? Right and the left lung field. Okay, so you also keep it in the right and the left lung field. Okay, now what you find two things or two kind of signs over here. So one is basically called as a seashore sign. What is a seashore sign? This is basically seen in normal individuals. Okay, in the normal individuals. Okay, so for example, in you and me at this point of time, if you keep a ultrasound probe over here, what is going to happen? The lungs are going to expand and they're going to hit the kind of chest wall, and then they're going to go back. Are you understand my point? So this is what is referred to as a seashore sign. This is what you find in the normal individuals. But or you can also find a barcode sign or a stratosphere sign. Stratosphere sign. So where do you find this barcode sign or a stratosphere sign? Barcode sign or stratosphere sign, this is what is found in the pneumothorax. So what you need to understand is that air is an enemy of an ultrasound. So air is going to create a lot of artifacts. Artifacts. Are you understanding my point? Air is going to create a lot of artifacts, and that is what is kind of be detected as a barcode sign or a stratosphere sign. So this is all about what you need to understand about the fast and the e-fast. Okay, now lastly, what you need to understand in the management of a blunt abdominal trauma. Okay, abdominal trauma. If I ask you, if at all the patient is hemodynamically stable and if at all the patient is hemodynamically unstable, okay, what is an first investigation? What is the first investigation? And what is an investigation of choice? Okay, so can you please help me with this? Okay, so if at all the patient is hemodynamically stable, what is the first investigation and what is an investigation of choice? So answer over here is fast, and investigation of choice is a contrast enhanced CT scan. But if at all the patient is hemodynamically unstable, the first investigation is the fast and the investigation of choice is also the fast. Okay, I hope I'm making some sense to you guys. So this is about the blunt abdominal trauma. Okay, so before moving on to the next thing, what you need to understand is, let us quickly discuss about the management protocol of a blunt abdominal trauma. Okay, so yeah, we can move on to the next stuff, that's fine, but before that, let's kind of quickly talk about the management protocol of the blunt abdominal trauma. Okay, so what you need to understand over here, that whenever you have a patient with a blunt abdominal trauma or anything like that, first rule out peritonitis. And how will you rule out peritonitis? By abdominal palpation. So on abdominal palpation, if at all there is any guarding and rigidity, this is what is trying to tell you that, you know what, the patients are having peritonitis. Please do not understand, it is not about the tenderness, it is about the guarding and the rigidity. If at all on abdominal palpation, if at all you have the guarding and the rigidity, that is what is diagnosing that the patient is basically having a peritonitis. So if at all the patient is having peritonitis, what you need to understand over here, what you have to do, you have to perform an exploratory laparotomy. You understand my point? So this is what is going to perform an exploratory laparotomy. If at all the peritonitis is present, straight away exploratory laparotomy, no other investigation needed. Okay, but if at all, let's say the peritonitis is not present, then what you have to understand is that you have to look at the hemodynamic stability. Okay, you have to look for hemodynamic stability of the patient. If at all the hemodynamic stability of the patient is absent, what do you understand by hemodynamic stability absent? It means that the systolic blood pressure is less than 90 millimeters of mercury. Okay, so if at all the hemodynamic stability is absent, what is the first investigation which you're going to perform? You're going to perform fast. And if at all this particular fast comes out to be positive, then you have to straight away take the patients for an exploratory laparotomy. no other investigation is needed. If at all the fast is positive and an hemodynamically unstable person, okay, you have to straight away take the patients for an exploratory laparotomy. Okay, so what you did, you look for the hemodynamic stability. If at all it was absent, you did fast, and if at all the fast was positive, straight away exploratory laparotomy. But if at all the fast is equivocal, okay, then what you have to perform is a DPL. What is this DPL? Diagnostic peritoneal lavage. Okay, you have to perform a diagnostic peritoneal lavage, and if at all this is positive, then you have to take the patients for an exploratory laparotomy. Okay, right? Understood? Now, what about the hemodynamic stability? If at all that is present, okay, if at all it is present, then what you have to do, you have to perform first you perform the fast, and because the patient is hemodynamically stable, you also perform a contrast and CT scan, and based on the findings of this, you can decide. So based on this and the clinical judgment, you decide whether you have to go ahead with this observation or you have to go ahead with the exploratory laparotomy. Are you understand my point? So please do understand these particular stuff. Management protocol of a blunt abdominal trauma. What is the management protocol? First thing, you have to rule out peritonitis. If at all the peritonitis is present, no other investigation needed, straight away go and do a exploratory laparotomy. But if at all, let's say the peritonitis is not present, then what you do, you look at the hemodynamic stability, whether the patient is hemodynamically stable or the patient is hemodynamically unstable. If at all the patient is hemodynamically unstable, then what you perform a fast, and if at all the fast is positive, you straight away go ahead with the exploratory laparotomy. But if at all the fast is equivocal, then what you perform a diagnostic peritoneal lavage, and if at all the diagnostic peritoneal lavage is positive, then you take the patient for an exploratory laparotomy. But if at all we are dealing with a hemodynamically stable person, then what you're going to perform, a fast as well as the CCT, and based on whatever the findings of this along with the clinical judgment of the patient, now you're going to decide whether you have to perform an observation, like you have to continue with the observation, or you have to perform an exploratory laparotomy. Am I making some sense to you guys? I hope I'm making some sense to you in this particular scenario. Okay, now let's talk about this. After total thyroidectomy, okay, so patients were subjected to a total thyroidectomy under general anesthesia. Anesthetist tried to extubate the patient, but the patient was unable to extubate. What is the most probable diagnosis of this particular patient? Okay, so can you please help me with this? What is the most probable diagnosis in this particular patient, guys? Yep. I want all of you guys to answer. Okay, so this is one of the things which you need to remember. Very, very important. Okay, so what is the diagnosis? It's like a unilateral decadent laryngeal nerve palsy, bilateral decadent laryngeal palsy, hemorrhage, or the superior laryngeal nerve damage. Okay, two. Okay, very nice. The answer over here is B, 2, bilateral recurrent laryngeal nerve palsy. Very nice. Okay, very nice. Okay, so let's talk about the thyroidectomy. Okay, so let's talk about the thyroidectomy. So no, we'll not talk about the entire thyroidectomy. We'll just talk about the nerve damage in patients after thyroidectomy. So if I ask you which is most commonly injured, is it like the recurrent laryngeal nerve or the external branch of the superior laryngeal nerve? What is most commonly injured over here? What is most commonly injured? Recurrent laryngeal nerve or the kind of external branch of the superior laryngeal nerve? Can you please put your answers? Okay, which is more commonly injured? Very nice. Okay, so most common nerve injured is external branch of superior laryngeal nerve. This is more commonly injured than the recurrent laryngeal nerve. Okay, so now what you are going to do, we are just going to talk about what are the manifestations. Okay, so if at all the external branch of superior laryngeal nerve is injured, what is going to happen? What is going to happen to the patient? If at all the external branch of the superior laryngeal nerve is injured, what is going to happen to this particular patient? Can you please help me with this? What is going to happen? So patient is going to lose the pitch of the voice. So what you need to understand is that the external branch of the superior laryngeal nerve, it supplies cricothyroid muscle. So cricothyroid muscle जो है, that is the only tensor of the vocal cords. So if at all this is kind of damaged, what is going to happen? The patients are going to lose the high pitch of the voice. So this is going to be very, very detrimental if at all there is a patient who is a singer. Okay, so if at all we are dealing with a singer, like who has a profession of having this particular high pitch and high tone and everything, that is what is going to be very, very detrimental for these particular patients. Now I've seen patients, students marking as a hoarseness of voice if at all there is an external branch of recurrent laryngeal nerve palsy, but that is not true. Okay, so if at all there is an external branch of this superior laryngeal nerve that is injured, the patients are not going to land up to hoarseness of voice. Patients are going to have the loss of the pitch of the voice. Okay, I hope you have understood this point. Now what about the recurrent laryngeal nerve palsy? So recurrent laryngeal nerve, if at all there is a unilateral injury, okay, if at all there is a unilateral injury to the recurrent laryngeal nerve, then what's going to happen? The patients are going to have hoarseness of voice. But if at all there is a bilateral injury, okay, if at all there is a bilateral injury, now the patients are going to have respiratory distress. Are you understand my point? Very, very important. Okay, so three things you have to remember, four things rather. Most common nerve injured is the external branch of the superior laryngeal nerve. If at all the external branch of superior laryngeal nerve is injured, what is going to happen? There's going to be what you call as loss of the pitch of the voice. Okay, so the pitch of the voice is going to be lost. If at all there is a recurrent laryngeal nerve injury, if at all there is a unilateral recurrent laryngeal nerve injury, there's going to be the hoarseness of voice. And if at all there is a bilateral recurrent laryngeal nerve injury, what the patient is going to have is a respiratory distress. Okay, very, 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 very important in these particular patients. Okay, I hope you are able to understand this particular point. What, why? Okay, so Idris, what, why, what are you saying, why? So can you please ask the question in a proper manner so that I'll be able to answer? Please put it in the proper manner. Okay, I hope you have understood. These are the nerve injuries which you get in the patients with the thyroidectomy. So okay, so this is, forget about it, we already talked about that. Okay, now please have a what you going to read this particular question in a proper manner and then answer. Okay, so which of the following is a wrong regarding the superior mesenteric artery syndrome? Okay, so superior mesenteric artery is compressed by the third part of duodenum at the ligament of teres attachment. Superior mesenteric artery has a normal angle of around 38 to 65 degrees in relation to the duodenum. Strong procedure is a corrective kind of surgery in which the ligament of Treats is divided. Superior mesenteric artery syndrome is characterized by an angle less than 28 degrees due to the loss of intervening mesenteric fat of mesenteric pad of fat. Okay, yep, what is the answer over here? So your drug of choice, you're saying that it is 4. No, that's not 4. So this is basically a play of words. Okay, so this is what I talk about as a knee-jerk response. So this is a very, they are basically trying to test your presence of mind and English. That's what they're trying to test over here. The answer over here is 1. Why the answer over here is 1? Why the answer is always 1? Superior mesenteric artery is compressed. No guys, superior mesenteric artery is not compressed. Superior mesenteric artery is compressing. Are you understanding my point? Please do remember this particular point. Okay, superior mesenteric artery per se is not compressed. Superior mesenteric artery is compressing the third part of duodenum, not at the ligament of Treats, between the aorta and the superior mesenteric artery. So are you understanding my point? What is the SMA syndrome? Okay, so answer there was 1. Okay, so what you need to understand about the SMA syndrome, superior mesenteric artery syndrome, is a syndrome where the third part of duodenum, which part of duodenum? Third part. This is also ours. Okay, first part, second part, third part, fourth part. So third part of duodenum is getting compressed between the aorta. So this is what is your aorta and the superior mesenteric artery. It is getting compressed between the aorta and the superior mesenteric artery. Are you understand my point? So the third part of duodenum is getting compressed. Superior mesenteric artery is not getting compressed. So obviously I know that you know that, but it was just the play of the words, and that is what is called as a knee-jerk response. So in the exam you have to have that particular presence of mind. Very, very important. Okay, I hope you have understood this particular point. So yeah, the superior mesenteric artery is basically compressed between third part of duodenum is getting compressed between the superior mesenteric artery and the aorta. Why does this happen? So in the history you will have the patients who are having what you call as so what you need to understand in the history, what you're going to have, you are going to have a patient who has a history of rapid weight loss. There's a history of a rapid weight loss. I understand my point. So normally what happens, that the angle, okay, so let's say if it all this is a aorta, the superior mesenteric artery is kind of originating, and over here there is a pad of fat, okay, there's a pad of fat, and this particular angle is usually maintained at around, let's say 40 to 60 degrees Celsius or something like that. But if at all there is a rapid weight loss, let's say around 10-20 kgs of weight is lost, let's say in one month or something like that, what is going to happen? The angle may become narrowed, okay, the angle may become narrowed, and if at all the angle become narrowed, what is going to happen? The third part of duodenum, which is basically going between this might get compressed. As you can see in this particular figure very well, the third part of duodenum can get compressed between the aorta and the superior mesenteric artery. Because of this, the patients are going to have bilious vomiting and the features of intestinal obstructions. Patients are going to have bilious vomiting, and whatever the intestinal obstruction, whatever. So frankly, this is a very simple topic. There's nothing major to kind of teach over here. So what is an SMA syndrome? Third part of the duodenum is basically going between this, and if at all the angle becomes acute, what is going to happen? It is going to get compressed. Patients are going to have bilious vomiting, intestinal obstruction, all those things. What about the management? What about the management, guys? What about the management? In the management, the treatment is jejunostomy. But there's another thing which is called as a strong procedure. So what is the strong procedure? So what you basically do in this particular strong procedure is just pay a close attention towards this particular image. So you have this particular ligament of Treats. What you can do, you can cut this particular ligament of Treats. Now what is going to happen? This particular part of the DJ flexure is kind of getting free. So what you can do, you can slide this particular thing between the superior mesenteric artery and the aorta. So you understand my point? So for example, this is the superior mesenteric artery, this is an aorta, and let's say if at all this third part of duodenum is getting compressed between this. So if at all you cut this ligament of Treats attachment, what you can do, you can slide this particular duodenum out of this particular kind of angle, right? So if you slide this particular duodenum out after cutting the ligament of Treats, that is what is called as a strong procedure. Nothing major about this, but yeah, that is what you need to understand over here. Okay, so very simple topic, nothing major, but I hope you have understood. This is what is called as a superior mesenteric artery syndrome, a small topic but an important topic. Third part of duodenum, bilious vomiting, intestinal obstruction because of rapid weight loss. So the pad of fat is what is getting kind of lost. Okay, I hope you have understood this particular point. Okay, now can you please put the answers to this particular question, guys? Which of the following would be the most commonly encountered ectopic tissue in the Meckel's diverticulum? Okay, so in the Meckel's diverticulum, what is the most commonly encountered ectopic tissue? Yeah, can you please put the answers in the comment box, guys? Gastric and pancreatic, colonic and pancreatic, gastric and colonic, or the thyroid and lungs? Okay, so what is the answer? It is 1, guys, 1. Please try to understand. It is gastric and pancreatic. Okay, gastric and pancreatic. A is the answer. Okay, got it? Right. So let's talk about the Meckel's diverticulum. Okay, so let's talk about the Meckel's diverticulum. First of all, what is the Meckel's diverticulum? Meckel's diverticulum. So this is a true or a false diverticulum. Can you please help me with this? Is it a true or a false diverticulum? So Meckel's diverticulum is a true diverticulum. Okay, what is it? It is a true diverticulum. What do you understand by the true diverticulum? True diverticulum basically means that the one which is having all the 3 layers of the intestine. So here what you need to understand is a true diverticulum, all the 3 layers of the intestine are present. Why? What is the reason? Why did it form? So it is basically a remnant of your vitellointestinal duct. So what is it? It is a remnant of the vitellointestinal duct. So we have a vitellointestinal duct which was kind of patent in the kind of embryonic period. Now if at all that particular continues to be patent, that is what is called as a Meckel's, that remnant of that is what is called as a Meckel's diverticulum. You understand my point? So what is a Meckel's diverticulum? It is a true diverticulum which is basically a remnant of a vitellointestinal duct. So what is a place, like where does it occur? Does it occur on the mesenteric border or does it occur on the anti-mesenteric border? So Meckel's diverticulum is the one which is basically present on the anti-mesenteric border. Please try to understand this point. This is not occurring on the mesenteric border. This is the one which is occurring on the anti-mesenteric border. Okay, it follows the rule of 2. What is this rule of 2? It basically means that it is 2 feet proximal to the ileocecal junction. It is 2 inches long. It is present in the 2% of the population. So the rule of 2 is what is kind of associated with your Meckel's diverticulum. I hope you have understood this particular point, guys. Okay, now here you can have an ectopic tissue. So what is an ectopic tissue which you usually have in this particular stuff? So you have gastric and you have pancreatic. Please try to understand these are the ectopic tissues which you can have in these particular patients. Okay, so if at all there is a gastric ectopic tissue, what is it going to happen? It is going to produce HCl, and if because of the HCl, what is going to happen? There is going to be an ulceration, and because of the ulceration there is going to be the bleeding. Are you understand my point? So yeah, that is what you need to understand about the ectopic tissue rest. So if I ask you, what is the most common presentation? Most common presentation. The most common presentation is in the children, it is bleeding. In the adults, it is intestinal obstruction. Okay, you understand my point? In the adults, it is intestinal obstruction. In the children, it is bleeding. The most common presentation in the children is bleeding. So if I ask you about the investigation of choice, if at all you want to diagnose the patients with the Meckel's diverticulum, if at all you are dealing with the children, and if at all there is a bleeding Meckel's diverticulum, what you have to perform is a technetium 99 labeled RBC scan. Okay, technetium 99 labeled per technete RBC scan. This is what you need to understand, because we want to diagnose the bleeding, right? So there's a bleeding, so we want to kind of diagnose it. In the adults, okay, in the adults, what you need to understand? In the adults, the investigation of choice is enteroclysis. Okay, what is it? It is enteroclysis. What do you understand by an enteroclysis? So what you basically do in this, you put in a nasogastric tube, and okay, what is an enteroclysis? Anybody? Okay, so this is basically a dye study. What is an enteroclysis? This is basically a dye study which you are basically performing for the small intestine. Okay, it is a dye study for the small intestine. So what you need to understand over here, you basically kind of put in a nasogastric tube, but you don't kind of keep it only in the stomach. You push it forward and you basically take the end of that into the duodenum. And then what you do, you put in a dye. So when you put in a dye, what is going to happen? The dye is going to delineate that particular area, and ultimately what is going to happen, you will be able to detect the Meckel's diverticulum. Okay, so this is a contrast study which is done in the small intestine. How do you do it? You put in a nasogastric tube, you push it into the duodenum, and then you put in a dye. Okay, I hope you have understood this particular point. Now, what about the management of this, guys? Okay, what about the management? So management is a bit complex. What you need to understand about is that if at all there is an ectopic tissue is present, no doubt you have to kind of excise it, no doubt about it. You have to perform a diverticulectomy. Okay, you have to perform it, or a resection anastomosis. When will you perform a resection anastomosis? When there will be need for performing a resection anastomosis? If the base is involved. If base is involved. So what do I mean by this? So you came across a Meckel's diverticulum, you tried to palpate whether there is any ectopic tissue. If you feel that there is an ectopic tissue, definitely you have to kind of remove it. Then you look at the base. If at all the base is not involved, then you can perform a wedge resection, that's fine. But if at all the base is involved, then you have to cut the intestine at two places. You have to remove the central part of the intestine, and then you have to rejoin this particular intestine. Are you understand my point? So if at all the base is involved, then resection anastomosis. If the base is not involved, then you can perform a wedge resection. Okay, so this is what you need to understand over here. That is the first thing. Second, in your whatever the Sebastian, it has been written. So Sebastian Levenbilly basically tells a bit kind of a different thing. So what you need to understand, if they don't give you ectopic tissue, nothing. If they see that there is an incidentally detected Meckel's diverticulum, and they say that if at all this is having the wide mouth and narrow, or whatever the wide mouth and kind of short length. Okay, so if at all there is a wide mouth and the short length, then what you have to do, you can just leave it like that. You don't have to kind of remove it. Okay, just leave it like that, it's fine. Just have to go ahead with the observation. But if at all there is a narrow mouth and if at all there is a long length, okay, if at all there is a narrow mouth and there is a long length, then what you have to do, you have to perform a resection. Okay, then you have to kind of perform a resection. I hope you are able to understand this particular point, right? Okay, got it. So this is about the management of the patients with the Meckel's diverticulum. Okay, I hope you have understood this point. Now let's move on to the next question. Oh, pretty simple. One of the most simplest questions, I guess, over here. So 60-year-old blah 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 presented with the complaints of the hematuria and whatever the recurrent urinary tract infection. CCT findings have been shown below. Which of the following is a condition indicated by the arrow in this particular given image? Okay, so what is this? Okay, can you please tell me, guys, what is this? What is the answer over here, guys? Come on, fast. I know it's a simple question, but still, what is the answer? Yes, it is definitely a horseshoe kidney. Okay, so let's kind of quickly revise about the horseshoe kidney. It's a very small topic, but an important topic. So let's kind of talk about this. Okay, so horseshoe kidney, shoe kidney. So what is happening in the horseshoe kidney is that the lower pole of the kidneys are fused with each other. Okay, first of all, what is the kind of incidence of this or prevalence of this particular horseshoe kidney? What is the prevalence? It is 1 in 250 people. Okay, so what you need to understand, 1 in 250 people are going to have a horseshoe kidney. That's what you need to understand. And what is happening in the horseshoe kidney? In the horseshoe kidney, the lower poles of the kidney are fused. So if I talk about the embryology of the kidney, does it kind of develop inside the abdomen? No. So what you need to understand is the kidneys are basically developing inside the renal pelvis. Okay, so kidneys are developing in the renal pelvis and then they come to lie inside the abdomen. So they basically starts their development in the pelvis and then they ascend up to lie into the retroperitoneum. Okay, retroperitoneum. You understand my point? So they start their development inside the pelvis. Now, in the patients of the horseshoe kidney, nothing is going to be different. Here also, the kidneys started their development inside the pelvis only. But now, when they were coming up, their ascent was restricted by something. So what is the structure which is going to restrict the ascent of the patients of the horseshoe kidney? Okay, so here what you need to understand, in the patients of the horseshoe kidney, the ascent of the kidney is stopped or restricted, whatever you want to call it. Stopped by what? So anybody guys, anybody? It is stopped by inferior mesenteric artery. Please try to understand, it is basically stopped by the inferior mesenteric artery. Okay, I hope you have understood this particular point. The ascent of the kidney is stopped by the inferior mesenteric artery. So what is the origin of this particular inferior mesenteric artery? It is arising at the L2 level. Okay, so the important question which they ask you is that the isthmus of the kidney, is at what level? So please try to understand, the isthmus of the kidney is at L3, L4 level. Okay, L2, L3 or L3, L4 level. Okay, so that's what you need to understand over here. So it is basically a level below about that. Okay, so it is basically at the L3, L4 level. Okay, I hope you have understood this particular point. Now, okay, that's fine. What about the presentation? What about the presentation of the patients with the horseshoe kidney? So what you need to understand is that the most common presentation of the patients with the horseshoe kidney is asymptomatic. Most common is asymptomatic. They are not going to have any symptoms. Okay, so they are asymptomatic. Most of these particular patients are asymptomatic. It doesn't mean that they can never ever have symptoms. So they can have urinary tract infection, they can have stones, and if at all they kind of develop these things, then you kind of manage this. Okay, but most common presentation is an asymptomatic. I hope you have understood this particular point, guys. Okay, now what about the horseshoe kidney? Is it at an increased risk of something? So please try to understand, the horseshoe kidney is having increased risk of Wilms tumor. Okay, there is an increased risk of Wilms tumor as compared to that of the general population. The risk of the Wilms tumor is kind of elevated over here. Okay, but what about the renal cell carcinoma? Please try to understand, renal cell carcinoma, the risk is same as normal population. So if I ask you, which is the most common renal tumor in horseshoe kidney? Can you please help me with this? Horseshoe kidney. Can you please get me the answer, guys? So what is the most common renal tumor in the patients with a horseshoe kidney? What is the most common renal tumor in the patients with the horseshoe kidney? If you are trying to say that the answer is Wilms tumor, you're wrong. The answer over here is renal cell carcinoma. Okay, are you understanding my point? The answer over here is a renal cell carcinoma. Okay, so please try to understand that the risk of the Wilms tumor is high. That's fine, but as compared to the general population, the risk of the Wilms tumor is high, but still overall the most common tumor is still renal cell carcinoma. You understand my point? In the general population also, the incidence of the renal cell carcinoma is much more than the Wilms tumor, right? So please try to understand. They sometimes very rarely play with the words. Most common tumor is renal cell carcinoma. The risk of renal cell carcinoma is the same as that of a general population, but the risk of Wilms tumor is the one which is kind of elevated in the patients with the horseshoe kidney. It is not that high yield, but yes, they had asked this once. What you definitely need to remember is this: 1 in 250 people, that's fine. The ascent is basically prevented by inferior mesenteric artery. You cannot afford to forget this. Systemus is at the level of L3, L4, and yeah, in presentation most common is the asymptomatic. But at the same time, if you can remember these as well, that is going to be much beneficial. Okay, so I hope you have understood this particular point, guys. Yeah, got it. Now let's move on to the next question. So the next question which you have is: a 25-year-old male patient presented with the 2 centimeter nodule, thyroidectomy was done, and the histopathological blah 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 kind of picture has been shown to you. What is it? It is a clear cell. Is there a clear cell carcinoma in the thyroid, chota doctor? Are you kidding me? It is a papillary cell carcinoma, guys. Papillary thyroid carcinoma. Clear cell is in the kidney. Here it is a papillary carcinoma of thyroid. Okay, chota doctor, I hope you have understood this point. Okay, now let's talk about the papillary carcinoma of thyroid in a bit more detail. Okay, so let's talk about the papillary carcinoma of thyroid. So papillary carcinoma of the thyroid. So what you need to understand is that this is the one which is the most common, and this is the one which is having the best prognosis. Okay, now I'll tell you the risk factors of the papillary carcinoma of thyroid, but in the meanwhile, can you tell me what is the genetic mutation? Okay, so yeah, please put in the comment box what is the gene which is muted in the patients with the papillary carcinoma of thyroid. Till that, I'll tell you the risk factors. So the most important risk factor is a radiation exposure to the neck in the childhood. Okay, you understand my point? So radiation exposure to the neck in the childhood. So that is the most important risk factor in the patients with the papillary carcinoma of thyroid. Along with that, what you need to understand is a long-standing thyroglossal cyst. Okay, so these are the risk factors for the development of a papillary carcinoma of thyroid. Okay, now if I talk to you about the presentation. So what is going to be the presentation of the patients with the papillary carcinoma of thyroid? So the presentation of the patients with the papillary carcinoma of thyroid is going to be a lateral aberrant thyroid nodule. So what is this lateral aberrant thyroid nodule? So what you need to understand by lateral, what they mean is that it is not a midline kind of a swelling. You understand my point? So they say that it is not a midline, it is lateral to the midline. That is what they say. So there is a thyroid nodule that is basically present lateral to the midline. Okay, so lateral aberrant thyroid nodule. Now, if at all there is a nodule of a thyroid in the papillary carcinoma of thyroid, is it going to move with the deglutination? Yes, it moves with deglutination. Okay, it moves with the deglutination. Okay, now another important thing what you need to understand over here is there's something which is called as an occult thyroid malignancy with lymph node metastasis. Okay, so occult thyroid malignancy with the lymph node metastasis. What do you understand by an occult? Occult means hidden. Okay, what does this mean? This basically means hidden thyroid malignancy with a lymph nodal metastasis. I understand. Occult means hidden, right? So you perform an occult like stool for occult blood. Occult means hidden. It is not kind of evident. You understand my point? So here the whole point is that in the patients with the papillary carcinoma of thyroid, there is an early lymphatic metastasis. Okay, there is an early lymphatic metastasis, and that is why there is a chance that when you examine this particular patient, you might not even be able to palpate the nodule in the thyroid. Thyroid will be absolutely normal, but there will be lymph node metastasis in the neck. Okay, I hope you have understood. And yeah, many of you kind of gave this particular answer correct. The genetic mutation associated with the papillary carcinoma of thyroid is BRAF gene mutation. Okay, now in these particular patients, if at all you end up performing an FNAC, so what are you going to find in these particular patients? So please try to understand, you are going to find an orphan NEI nuclei, okay, and you might find psammoma bodies. Along with that, you may also find pseudo grooving. Okay, you might also find a pseudo grooving. Are you understand my point? So on the FNAC, you can have an orphan NEI nuclei, psammoma bodies, or a pseudo grooving. So what is this orphan NEI nuclei? I hope you're able to appreciate that there was a cartoon character, and in this the eyes had only the sclera. So what you need to understand over here also, the nucleus looks kind of an empty. So that is what is called as an orphan NEI nuclei. Then what is the pseudo grooving? Pseudo grooving basically means that the cell membrane is invaginating on itself. So when you kind of take a cross section, it looks like a groove. So this is what is called as a pseudo grooving. Okay, so that is what is called as a pseudo grooving. Okay, so please try to understand this is how you're going to diagnose these particular patients. And finally, about the management. So how you're going to manage these particular patients? Total thyroidectomy, total thyroidectomy plus minus modified radical neck dissection, MRND. Okay, so total thyroidectomy plus minus modified radical neck dissection. I hope you are able to understand this particular point. Okay, now lastly, what you need to understand is that what is a tumor marker? If I ask you what is a tumor marker for the patients with the papillary carcinoma of thyroid. Okay, so what is a tumor marker? Please try to understand. It is thyroglobulin. Okay, what is it? It is thyroglobulin. So what you need to appreciate out of this is that thyroglobulin is not used to diagnose it, but if at all, let's say there is some residual disease. Okay, so after, let's say you have done a thyroidectomy, and if at all, even after doing a thyroidectomy, the thyroglobulin levels are high, then you suspect that, you know what, maybe there is some residual disease or there's some metastasis in this particular patient. Okay, I hope you're able to understand this point. Now, last thing what you need to understand, post thyroidectomy, what you need to appreciate is that the radioactive iodine can be used for various purposes. So it can be used to detect any residual disease, okay, or metastasis. And radioactive iodine can also be a therapeutic benefit. Okay, so this is how you can kind of use the radioactive iodine post thyroidectomy. Okay, I hope I have make some sense to you guys over here, right? Okay, so I'll quickly revise it because this is a very simple topic but a very, very important topic. So what is the papillary carcinoma of thyroid? So kind of look at me. I'm pretty sure that you have read this so many times. Papillary carcinoma of thyroid is the most common thyroid malignancy. Okay, I'll show the screen as well, so if at all you can follow it side by side. So papillary carcinoma of thyroid is the most common thyroid malignancy, and this is the one which is having the best prognosis. What are the risk factors? So a radiation exposure to the neck during the childhood, or let's say there is a long-standing thyroglossal cyst, that is what is a risk factor for the development of a papillary carcinoma of thyroid. It can be associated with the BRAF gene mutation. And what you need to understand how it's present, it can present with a lateral apparent thyroid nodule, or it can present with a what you call as a occult thyroid malignancy with a lymph nodal metastasis. So early lymphatic metastasis is a key in these particular patients of a papillary carcinoma of thyroid. On the FNAC, what you will find, you'll find an orphan NEI nuclei, psammoma bodies, and the pseudo grooving, which is going to help you in diagnosing the patients with the papillary carcinoma of thyroid. And the treatment, it is total thyroidectomy plus modified radical neck dissection and plus minus what again. And what about the tumor marker? It is a thyroglobulin, and the radioactive iodine is something which you can use in the post-operative period in order to detect any residual disease or the recurrence, and at the same time to kind of completely ablate if at all there is any residual disease which is present inside the body. Okay, so this is all about the papillary carcinoma of thyroid which you need to understand. Now let's move on to the next question. Okay, so what is a child pook class of a patient who has a serum bilirubin of 2.5 and serum albumin of 3 and the INR of 2 along with the mild ascites and no encephalopathy. So what is this? We are going to talk about the child pook class for a liver failure. Okay, so what is this? This is what is a child pook's classification for the liver failure. Okay, so let's kind of talk about this child pook class, child pook classification. Okay, so what are the components of this child pook classification? Now there are various different stupid mnemonics for these. I will not recommend you to kind of follow any particular kind of mnemonic. Just try to apply logic and you will get the answer. So what is the function of the liver? Function of the liver is to kind of prevent the ascites and to prevent the encephalopathy, right? So otherwise, if it is a liver fails, what happens? There is an ascites which is happening, and there is an what do you call the hip so uremic encephalopathy can happen. Okay, so what you need to understand is that either it will be encephalopathy. Okay, then what do we have? So encephalopathy is there. Then what else? Ascites. Then what is the role of the liver? Like the proteins, if at all they are kind of produced and if at all they are more, that is what is going to be good, right? So we have to look for the albumin. Okay, what else? Bilirubin, obviously. Okay, so if at all you are dealing with the liver, bilirubin may be high. Okay, and lastly what you need to understand over here is about the PT and INR. Okay, so let's talk about the encephalopathy. So obviously this is what is like 1, 2 and 3. Okay, so what is this encephalopathy? What you need to understand over here, there is no, and if at all there is mild, and there is severe. What about the ascites? Again, it is no, it is mild, and it is severe. Okay, I hope you have understood this particular point. So mild, kind of no, mild to moderate, and the severe. Encephalopathy and the ascites. Okay, obviously nothing major to be kind of talked about over here. What about the albumin, guys? What about the albumin? So what about the albumin? Albumin, more the better, right? Okay, I hope you're able to understand. Albumin is more the better. So if at all it is more than 3.5, okay, if at all it is more than 3.5, that is good. But if at all it is kind of less than 3.5, so what you say, it's like 2.8 to 3.5, then you give it a score of 2. And if at all it is less than 2.7, then you give it a score of 3. Okay, so this is about the albumin. What about the bilirubin? In the bilirubin, it is less than 2, 2 to 3 and more than 3. Here it is less than 2, 2 to 3 and more than 3. Okay, then what do we have? A PT with INR. So what you need to understand, prothrombin time is basically less than 4, 4 to 6, more than 6. What about the INR? Less than 1.7, 1.7 to 2.3 and more than 2.3. Okay, so please try to understand, there's nothing to be memorized over here. I hope you have understood this point. This is what is a child pook's grading. Okay, so now let me just solve that particular question for you guys. Okay, so now let me just solve that particular question. What is the question? That there is a child pook, blah blah blah, serum bilirubin of 2.5. So if at all the serum bilirubin is of 2.5, what is it? It is 2, like the score is 2, that's fine. Then serum albumin is 3, so albumin 3 is again like 2. Then what do we have? INR is again 2. Okay, so what is INR? INR is again 2, that's fine. Then mild ascites and no encephalopathy. Okay, so mild ascites and no encephalopathy. You understand my point? So if you add these particular things, what is going to happen? You are going to get the score of 9. So based on these scoring systems, what you have? You have a child pook score. And the child pook score, what you need to understand over here is that it is divided into A, B and C. What is A? A basically means that the child pook score of 5 to 6. B basically means that from 7 to 9. And C basically is from more than 9, more than 10 or equal to 10, something like that. Okay, are you understand my point? So this is what is the child pook scoring system, which is basically there to look for the liver function, whether the liver is functioning in a decent manner or not. Very, 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 very important. You have to kind of learn it by heart. It is not that easy, like difficult. If you sit with this for some period of time, you will definitely be able to kind of diagnose the patients with these particular stuff. Okay, so child pook's grading, this is very, very important. So here, what is the answer? Here the score, if you calculate, it comes out to be 9, and this is child pook class B. Okay, so till 9 it is B, and 10 to 15 is basically like class 3. Okay, I hope you are able to understand this particular point. Okay, type C. Okay, now true about the uncinate process of the pancreas affects which of the following? Tumor, sorry, not true. Tumor along the uncinate process of the pancreas affects which of the following? So this is again a very important thing. Okay, so whenever we plan a particular Whipple's surgery, we always have to look for this particular structure. Okay, so can you please help me with this? What is the answer over here? Yeah, guys, please tell me what is the answer. Whatever you feel like, supreme mesenteric artery, portal vein, common hepatic artery, inferior mesenteric artery, whatever you feel like. Superior mesenteric artery, okay. Anybody else? Yes, the answer is superior mesenteric artery. Okay, so what you need to understand is you have to look at this particular image. Okay, so what you need to understand, the uncinate process is very in close relation with the kind of a superior mesenteric artery. So whenever you have a patient of a Whipple's disease, okay, whenever you have a patient of a Whipple's disease, what you need to understand or what you need to appreciate is that, okay, so let's talk about the patients of a Whipple's disease. Okay, so I hope you have understood this particular point. The tumor, it should be along the superior mesenteric artery. So now let's talk about the kind of a Whipple's. Okay, so whenever you are trying to perform a patient for a pancreatic adenocarcinoma, so what you need to understand is that, okay, so what you need to understand that the pancreatic tumors can fall into the three categories. What are these particular three categories? Completely resectable, or what it can happen, it is completely non-resectable, and then you have a midline. You understand my point? So what about the completely resectable? Okay, so yeah, so pancreatic adenocarcinoma, when you will say that, you know, it is completely resectable. So okay, so what you need to understand is that we have the superior mesenteric vessel, superior mesenteric vein, superior mesenteric artery, which is basically going very close to the uncinate process and everything. Okay, now let's assume that this is what is a superior mesenteric artery, or let's say this is a superior mesenteric vein. So if at all the tumor is there, we have to kind of evaluate whether the tumor is completely encircling this particular artery or not. Okay, so I'll just kind of do this. Okay, so what you need to understand, let's say for this is the artery, this is the vein, whatever, you have to see whether the tumor is completely encircling this particular artery or not. In other words, the kind of the encasement of this particular artery is less than 180 degrees or more than 180 degrees. That is what you have to kind of see in these particular patients. Okay, so if at all the encasement by this particular tumor is less than 180 degrees, so if at all, what you need to understand is that if at all there is a superior mesenteric vein which is encasement is less than 180 degrees. Okay, so if at all the encasement is less than 180 degree and you are dealing with a superior mesenteric vein, yes, you can go and resect it, not a problem. What about the completely non-resectable? If at all you are dealing with the superior mesenteric artery and if at all the encasement is more than 180 degrees Celsius, okay, well, more than 180 degrees, so then it is completely non-resectable. Are you understand my point? So here there is a superior mesenteric artery, here there is a superior mesenteric vein. Okay, now what about the midline? So obviously, if at all there is a superior mesenteric vein, okay, which is superior mesenteric vein which is having the encasement of more than 180 degrees. Okay, that is one thing. What else? So there is superior mesenteric artery with an encasement of less than 180 degrees. Okay, superior mesenteric artery encasement less than 180 degrees, or there is superior mesenteric vein encasement of less than 180 degrees. Okay, superior mesenteric vein encasement less than 180 degrees with a tumor thrombus. You understand my point? So this is very important. Whenever you are dealing with the patients with a pancreatic adenocarcinoma, you can either have the lesions which are completely resectable, like midline or a borderline. Okay, so it's not midline, it is borderline. You understand my point? So midline is not the correct word over here, it should be borderline resectable. Okay, borderline resectable, and then completely non-resectable. Are you understand my point? So these are the things which you really need to remember. Okay, you have to check for the patency along this superior mesenteric artery and the vein. Okay, right. Now we are at around 11:53, guys. We will continue till around 1. Okay, we will continue till around 1. What we'll do is we'll take a very short, let's say around 5 minutes break. We'll meet back at 12. Okay, so we'll meet back at 12, and we have around 8 questions to kind of go through. We will complete those particular questions, and we'll meet back in, let's say, 8 minutes. Okay, 7 to 8 minutes we'll kind of meet back again. Okay, 7 to 8 minutes we'll meet back. So hi guys, welcome back, and yeah, let's start. So what we have is that there's a patient who is blah 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 having halitosis, and patient is having swelling in the lateral aspect of the neck. Which of the following or the pressing, where it basically gives the regurgitating sound. Barium swallow has been kind of shown to you. What is the diagnosis? So yes, most of you guys have already told. VPR, why would you say that it's a laryngocele? Why would you say it's a laryngocele? It's not a laryngocele. Okay, laryngocele will not have halitosis, right? Will not have halitosis. Why will the patients have halitosis in the laryngocele? The answer over here is definitely pharyngeal pouch. And why would in the laryngocele this like this is a Zenker's diverticulum, right? So simple Zenker's diverticulum. Okay, so what is this? This is a Zenker's diverticulum. Okay, so let's talk about the Zenker's diverticulum. Okay, so let's talk about the Zenker's diverticulum. What you need to understand about the Zenker's diverticulum, is it like a true diverticulum or a false diverticulum? Okay, so Zenker's diverticulum is a false diverticulum. Okay, so what you need to understand, why? What is the reason why this particular thing is happening? Okay, so this is happening because there is a miscoordination between the thyropharyngeus and cricopharyngeus muscle. Okay, so what do we have? We have a thyropharyngeus muscle, and then what we have a cricopharyngeus muscle. Okay, and then what we have a potential triangular defect between this. What is this called as? This is what is called as a Killian's triangle. Okay, so what is this? Above one is your thyropharyngeus muscle, which is basically part of your inferior constrictor. Okay, so please try to understand this. Okay, sometimes the students get confused that it's a part of a superior constrictor. No, it's a part of your inferior constrictor muscle. Then what we have a cricopharyngeus muscle. Okay, so if at all, see, when the food is basically entering into the esophagus and everything, what you need to understand, if at all the thyropharyngeus contracts, the cricopharyngeus muscle should relax. Okay, but when the thyropharyngeus is contracting, if at all the cricopharyngeus muscle fails to relax, what is going to happen? There's going to be an increase in the intraluminal pressure. Okay, what is going to happen? There's going to be an increase in the intraluminal pressure, and if at all there is an increase in the intraluminal pressure, what is going to happen? There's going to be a development of a Zenker's diverticulum. So because of this, what is going to happen? Frankly, the mucosa is going to pouch. Okay, so mucosa pops out, and what we have is a development of a Zenker's diverticulum. Okay, so if at all there is a development of a Zenker's diverticulum, what is going to happen? The clinical features, whatever the food the patient eats, it might go into that particular diverticulum, and it can kind of be there for a prolonged period of time, and there can be halitosis and the bad odor and all those particular stuff. Patients might also give you the history of regurgitating the food which was eaten a day prior. If at all they kind of give this primitive history, definitely it is kind of Zenker's diverticulum. Then halitosis. Dysphagia will be there? Yes, dysphagia is there, but this particular dysphagia is a progressive or a non-progressive dysphagia? It is a non-progressive dysphagia. You understand my point? So what you basically get is a non-progressive dysphagia. Very, very important. Okay, so regurgitating the food, halitosis, non-progressive dysphagia, all these particular things are there. What about the diagnosis? How are you going to diagnose these particular patients? So the diagnosis is basically based on the barium swallow. So what you need to understand is that when there is an increase in the intraluminal pressure, the mucosa, it starts to pop out, right? So what you need to understand, it starts posteriorly in the midline, but it ultimately comes to lie on the left side. You understand my point? It's going to start posteriorly in the midline, but ultimately it's going to come to lie on the left side. Okay, so this is what you need to know about the Zenker's diverticulum, or whatever, the pharyngeal pouch, whatever you want to call it. Okay, now diagnosis is based on the barium value, that's fine. What about the management? How you're going to manage these particular patients? It depends on the size. If at all it is less than 2 centimeters, then what you can perform? You can simply perform a cricopharyngomyotomy. Cricopharyngomyotomy. If at all the size of this particular Zenker's diverticulum is basically between 2 to 5 centimeters, then in that particular what do you understand with the cricopharyngomyotomy? You basically cut the cricopharyngeus muscle. So if at all you cut that particular muscle, the strength of that particular muscle is going to go down, and whatever the small diverticulum material is there, that is what is going to kind of come back in. If at all it is more than kind of 5 centimeters, okay, if it is more than 5 centimeters, then you have to perform a diverticulectomy. Okay, what you have to perform is a diverticulectomy. You have to kind of just excise it, that's fine. But if at all it is less, like it is between 2 to 5 centimeters, then what you can perform? You can perform a diverticulopexy. What do you understand by diverticulopexy? You make it anti-gravity. So earlier, let's say if at all there was a diverticulum which was like this, Zenker's diverticulum was like this. Now what you have done is you have kind of made it anti-gravity. Okay, so you have made this particular diverticulum anti-gravity. You understand my point? So you've made the diverticulum anti-gravity. This is what is called as a diverticulopexy. Or what you can perform is you can perform a Dollmann's procedure. Dollmann's procedure. So what is this Dollmann's procedure? This is what is called as a stapled diverticulopexy. Very, very important. Do not forget about this, guys. Okay, so what is a Dollmann's procedure? It is a stapled diverticulopexy. So I'll explain you what is this particular Dollmann's procedure, but by then I want somebody of you to answer in the comment box what is Delorme's procedure. So Delorme's procedure is used for which condition? I want you to answer it in the comment box. Please do that. Okay, so yeah, what is this Dollmann's procedure? Here what you do, you basically come with a stapler, and then what you do, you fire this particular stapler. So when you basically fire this particular stapler, what you need to understand is that, let's say this is a lumen of the esophagus, and let's say this is a lumen of the diverticulum. So that particular lumen can be like the wall between that can be taken down. You understand my point? So this particular wall can be taken down, and now there is no room for the food to get accumulated over here. So the lumen is going to get bigger, that's fine, but the food will not get accumulated over there. Okay, so I can see that none of you have kind of written. So anybody, guys, can you please tell me where do you have a Delorme's procedure? Do not get confused. Okay, first of all, okay, so where do you find this particular Delorme's procedure? Don't get confused with this. This is what is a Dollmann's procedure. Okay, this is what is a Dollmann's procedure. So no, don't want to tell me. Okay, so the answer is rectal prolapse. Okay, in the rectal prolapse, what is the procedure? It is Delorme's. Okay, it is Delorme's procedure. So there's a Delorme's, Altmaier, and Thiersch. These are the perineal approaches. Okay, these are the perineal approaches for what you call as your rectal prolapse. Okay, so the mnemonic for this is DAT, D-A-T. Okay, so in the Hindi we say that, you know, DAT, like it's cold, it is called as DAT. So that is basically Delorme's, Altmaier, and the Thiersch. Please try to understand this point. Very, very important. Okay, so this is what is a perineal approach. So once they had asked you which of the following is not a perineal approach, the answer was some Rapstein was there, that's fine. But what are the perineal approaches? Delorme's, Altmaier, and the Thiersch. Okay, so I hope you have understood this particular point in a good detail. Okay, now on esophageal manometry, and abdominal spastic contractions of the esophagus of more than 450 mm of whatever mercury with second centimeter were in the body is suggestive of what? So is it like a type 1 achalasia cardia, type 2, or type 3 achalasia cardia? Can you please help me with this? What is this particular type of an achalasia cardia? Okay, so just tell me the answer. By that, I'll kind of tell you about the achalasia. So what is an achalasia? Achalasia cardia is a condition where there is an inability of the lower esophageal sphincter to relax. Okay, so why, what is the reason? Why? The reason is absence of the ganglion cells. Ganglion cells. Now this particular thing was can be present either since birth, absence of the ganglion cells birth, this is what is called as a primary eclasia cardia, or it can be acquired. Okay, so acquired is basically called as a secondary eclasia cardia. Secondary eclasia cardia. Okay, so I'll tell you about this, like what is the cause of the secondary eclasia cardia, but till that, can you please put in the comment box what is the pseudo eclasia? All these things are very, very important, guys. This all things have been asked to you. Okay, so what is a pseudo eclasia? So there's like a primary eclasia cardia, or there's a secondary eclasia cardia, and there is a pseudo eclasia cardia. So can you please help me? What about the kind of a secondary eclasia cardia? Okay, so first you can put in the comment box about the pseudo eclasia. Till then, I'll explain you what is this kind of a secondary eclasia cardia. Secondary eclasia cardia is when the ganglion cells are destroyed. Destroyed by what? So they are destroyed by Chagas disease, trypanosomiasis. Trypanosomiasis, Chagas disease. You understand my point, right? So that is what is the secondary eclasia cardia. Did you tell me about the pseudo eclasia cardia? Short keys ring. No. Come on, guys. It is a repeat question. So, okay. So it is lower or GE junction malignancies. Okay, not the lower. It is a GE junction malignancies. Guys, this has been asked to you. Please try to understand this particular point. Okay, so what you need to understand, GE junction malignancies are the ones which lead to pseudo eclasia cardia. Okay, pseudo eclasia cardia is basically found in the GE junction malignancies. Okay, I hope you have understood this particular point, guys. Yeah, everybody understood this particular point, right? Now, what about the diagnosis? What is an investigation of? Okay, first of all, what is the clinical presentation of the patients with an eclasia cardia? So there is a dysphagia. There's a dysphagia, and can you please tell me about any characteristics of this particular dysphagia? Okay, first of all, it is progressive. Okay, it is a progressive. What else? It is more, or it is early. Okay, it is early to the liquids than solids. Okay, so the dysphagia, if at all there is a more dysphagia to the liquids as compared to the solids, what you're probably dealing with is a eclasia cardia, and this is a progressive dysphagia. So over a period of time, everything will have a dysphagia, like the liquids, solids, everything. But to begin with, it is more to your liquids as compared to that of the solids. Okay, I hope you have understood this particular point. So you have done, these are the clinical features. Okay, now what about the diagnosis? What is an investigation of choice? So can you please help me put the investigation of choice? Investigation of choice to diagnose these particular patients is manometry. And manometry, not just any simple manometry, high resolution manometry. High resolution manometry. Okay, I hope you're able to understand high resolution manometry. Okay, now we will talk about this particular thing in detail. Finally, what about the, okay, let's kind of talk about that first. Okay, so what you need to understand is that, okay, I'll just read this particular paragraph for you guys, because this is absolutely important for you to understand what are the things in the type 1, type 2, type 3. Broadly, I will tell you. In the type 1 and the type 2, what you need to understand is that in all the three, in order for us to label any patients with a eclasia cardia, there are two parameters which we broadly consider. One is called as a integrated relaxation pressure, IRP, integrated relaxation pressure, and then DCI, that is distal contractile integral. Okay, so what you need to understand over here is that the integrated relaxation pressure is going to be greater than 15 in every kind of a type 1, type 2, type 3. It is going to be have an increased pressure. The relaxation pressure is going to be increased, and because of that, the relaxation is not going to happen. Okay, are you understanding my point? So in all these three, what is going to happen? The IRP, integrated relaxation pressure, is going to be greater than 15 liters of mercury. Okay, but The difference comes in the DCI. So DCI is distal contractile integral. That is going to be less than 450 in the type 1, less than 450 in the type 2, but more than 450 in the type 3. Okay, so this is what is called as a DCI. Okay, so okay, don't worry, I'll put it in the tabular form. Don't worry, I'll put it in the tabular form. Just give me a minute. Okay, so I'll just read it through. Okay, so that's going to be kind of a bit more helpful. So manometry is the gold standard. Okay, so that's fine. Manometry is the gold standard. I just told you to diagnose the patients with the dysphagia, achalasia, cardia, blah blah blah. Achalasia, so this is important. Okay, please try to understand. Achalasia is defined by the median IRP, integrated relaxation pressure, greater than 15 millimeters of mercury. Okay, it means that it doesn't matter whether it is a type 1 or type 2 or type 3. So there are three types of achalasia: type 1, type 2, type 3. In all the three types of achalasia, the integrated relaxation pressure is always going to be more than 15 millimeters of mercury. That is a prerequisite to label any patient as a achalasia cardia. Okay, IRP is going to be greater than 15 millimeters of mercury. So this, because of this, what is going to happen? There's going to be a failure of the lower esophageal sphincter to relax with the deglutination. Okay, now, and the absence of the normal peristalsis. So all these particular things are there, but the takeaway is integrated relaxation pressure is basically greater than 15 millimeters of mercury in all the three. Okay, additional manometric findings associated with the achalasia include esophageal body pressurization. This is what we are going to talk about. From incomplete air evacuation, simultaneous minor contractions without evidence of a progressive peristalsis, and low amplitude waveforms indicating the lack of muscle tone. Okay, so all these particular things you might find in the high resolution manometry, but that is irrelevant. That is not going to be asked in your MCQs. So we all know what is a classification system for what do you call as hyper and the motility disorders. What is the name of that? I hope you are answering that it is a Chicago classification. Okay, so Chicago classification is the one which is basically trying to kind of categorize and define the definitions of your hypermotility and the hypermotility disorder. Okay, now we talk about the three types. So we have a type 1, type 2, type 3. In the type 1, as we just talked to you about, IRP is going to be greater than 15. That is going to be given for all the three, but there is 100% failed peristalsis. It means that not even a single time the effective peristalsis is being generated in these particular patients. Okay, now with the minimum esophageal pressurization. So even the esophageal pressurization is very low. In other words, the pressure inside the esophagus which is being developed, that is also very, very low. Okay, I hope I'm making some sense to you guys. Yeah, I hope I'm making some sense to you guys, right? Okay, now in the type 2 achalasia cardia, what is going to happen? What is going to happen to the IRP? That's going to be kind of greater than 15. That's fine. So the median IRP is greater than 15 and 100% phase peristalsis and pan esophageal pressurization with at least 20% of the swallows. So the peristalsis is ineffective. That's fine. But in 20% of the swallows, what is there? There is a pan esophageal pressurization which is kind of generated. Now this is something which is new. So in the type 1, no pan esophageal, like no pressurization inside the esophagus. In the type 1, no pressurization. In the type 2, for the 20% of the time, there was a pan esophageal kind of pressurization during the swallow, 20% of the swallows. Okay, I hope you're able to understand. Now what about the type 3? In the type 3, again the same thing, right? There the median IRP is greater than 15. That's all fine, but there is no normal peristalsis. That's all fine, but the spastic contractions of the esophagus, distal contractile integral of more than 450 millimeters mercury gram second centimeter. Okay, with at least 20% of the swallows. Okay, I hope you are able to understand this particular point. Okay, so I'll just simplify things for you. What do we have? We have achalasia cardias of type 1, 2 and 3. And what are the two things which we have to look for? IRP, integrated relaxation pressure. Okay, IRP, and what else? We have to look for DCI, distal contractile integral. Okay, so we have to look for DCI, that is distal contractile integral. So what you need to understand over here, that IRP in all these three is what is going to be it? It is going to be more than 15. Are you understand my point? So here it is always going to be more than 15. Okay, but the thing is with this DCI, in the type 1 it is less than 450 with no pressurization inside the esophagus. In type 2 it is again less than 450, but there is 20% of the swallows are associated with what you call as uh, pan-esophageal kind of contractions, or rather pressurization. Okay, so it is associated with pressurization. And what about the type 3? Here the DCI is more than 450, so there is a spastic contractions. Is there any effective peristalsis which is being generated? No, not really. So there's no effective kind of peristalsis, but here there's a spastic contraction. So here the answer was this, more than 450, and that is why the answer is type 3. And in the type 3 is the one where the kind of a cardiomyotomy is going to be maximum effective. I hope you are able to understand these particular stuff. Very, very important. So for exam, even if you remember this particular table, you are going to be good enough. Okay. So spastic contraction is more than 450 DCI. That is what is the type 3. And then like some pressurization inside the esophagus is going to be in the type 2. In the type 1, there is no pressurization. Okay. So there is absolutely no pressure which is generated in the esophagus. Okay. Are you able to understand this particular point? Okay, so no pressure generated inside the esophagus. That is what is a type 1 atresia cardia. Okay, yes or no, guys, or it is becoming a bit too toxic towards this time of the kind of hour. Okay, this is an important thing. Okay, so I hope you have understood this particular point. Okay, so this is Chicago classification, and this is what is a high resolution manometry. You can just kind of go through these particular stuff, right? Okay, now I won't kind of take a lot of time of yours. I will just wrap it up in, let's say, 15-20 minutes or so, but yeah, let's kind of do that. Okay, right. So patient presents with a peritonitis, and during the surgery the diverticular perforation is seen with the fecal peritonitis. Okay, so there's a fecal peritonitis. What is the Hinchey's classification? Okay, so what is the Hinchey's classification in these particular patients? Can you please help me with this? What is the Hinchey's classification? The Hinchey's classification in these patients is type 3. Shoulder doctor? No, it is type 4. What is this? It is type 4. Please try to understand. No issues, no issues. It's okay. It is type 4. Okay, so let's talk about the diverticulosis and the diverticulitis. Okay, so diverticulosis. So what you need to understand over here, what is the cause or the risk factor? The risk factor for the development of this particular diverticulosis is chronic constipation. Okay, chronic constipation is one of the kind of risk factors. Okay, so what is going to happen? There's going to be an increase in the intraluminal pressure. Okay, there's going to be increase in the intraluminal pressure. Okay, now what you need to understand is, just look at this, just look at this. So what is this above? This is what is your mesenteric border. So what is this? This is what is your mesenteric border. Okay, now just imagine this. Okay, just imagine this. This is, let's say, a lumen of the intestine, right? And let's say this is a mesenteric border. So from the mesentery, the blood vessels are coming and they are going to supply this particular intestine. So what is going to happen? The blood vessels are going to go around this particular kind of a thing, and blood vessels will enter into this particular wall in order to supply the deeper layers. Are you understanding my point? So these are the places of your potential deficit. Okay, so potential weakness. Here the weakness can happen. Are you understand my point? So I hope you understood this particular point, guys, that the blood vessels are coming from this particular mesenteric border. They are traveling on the wall of this particular intestine, and they are entering inside to supply the internal wall of this particular intestine, right? So these are the places where there is a potentially kind of deficient area. So when there is an increase in the intraluminal pressure, what is going to happen? The mucosa is going to pop out from this particular area, and that is what is referred to as your diverticulosis. Okay, so whenever there is an increase in the intraluminal pressure, what is going to happen? The mucosa is popping out. Okay, is popping out, or it pops out at the site of entry of blood vessels. At the site of entry of the blood vessels, what happens? The mucosa is basically pops out. So when the mucosa pops out, that is what is referred to as your diverticulosis. Okay, presence of the diverticula is called as a diverticulosis. Okay, so if I ask you that what is the most common site, okay, what is the most common site of diverticulosis? What is the most common site for the diverticulosis? In the colon, obviously. What is the answer? Diverticulosis in colon. What is the answer, guys? Answer is sigmoid. Okay, obviously it is the sigmoid colon. Sigmoid colon. Okay, so this is what is called as a diverticulosis. Now, if at all there is a patient who are having a diverticulosis, it can get complicated. Complicated into what? Diverticulitis. Okay, it can get confined into diverticulitis. So what is this diverticulitis? If at all, let's say the diverticulum get kind of ruptured, or if at all there's an infection in this particular diverticulum, that is what is called as a diverticulitis. Okay, I hope you are able to understand this particular point. Okay, now if I ask you, what is an investigation of choice? What is an investigation of choice for the diverticulosis? Anybody? Can you please put it in the comment box? What is an investigation of choice for the diverticulosis? The investigation of choice for the diverticulosis is barium enema. Okay, what is it? It is a barium enema. And over here, what you're going to diagnose is, we are going to have a characteristic sawtooth appearance. Okay, sawtooth appearance. Are you understand my point? So you have a characteristic sawtooth appearance on the barium enema. Okay, characteristic sawtooth appearance. So this is what is an image of this. I hope you're able to appreciate. So this is what is a sawtooth appearance, which you basically get in the patients with the diverticulosis. Okay, I hope you have understood this particular point. Not a very clear image, but I hope you have understood this. Okay, now what about the diverticulitis? What is an investigation of choice for the diverticulitis? Is it the same, the barium enema? Yes or no? Okay, so for the diverticulitis, what is the investigation of choice? It is CECT. Please understand, it is a contrast enhanced CT scan. So because if at all the diverticulitis has already happened, you cannot perform a barium enema because it was going to increase the inflammation and infection and all those particular stuff. So over here, the investigation of choice is a contrast enhanced CT scan. Okay, I hope you have understood this particular point, guys. Yeah, got it. Now, lastly, what you need to understand is that there is something which is called the Hinch's classification. Okay, what do you have? You have a Hinch's classification for diverticulitis. Okay, what we have a Hinch's classification. This is basically for diverticulitis. Okay, so we have an Hinch's classification for the diverticulitis. So what are included in this particular Hinch's classification? So this is 1, 2, 3 and 4. So what is 1? 1 is basically a pericolic abscess. Okay, it is a pericolic abscess. Pericolic abscess means just around the diverticulum. Just around the diverticulum, if there is an abscess, that is what is a pericolic abscess. In the type 2, what is happening? There is a pelvic abscess. Okay, there is a pelvic abscess. It's a pelvic abscess. Then what do we have? In the type 3, what do we have? In the type 3, what we have is a purulent peritonitis. Okay, purulent peritonitis. And in the type 4, what is there? There is a feculent peritonitis. Okay, what is there? There is a feculent peritonitis. Okay, I hope you are able to understand this particular point. So this is what is called as a Hinch's classification. Hinch's classification. This is what is diverticulitis. Hinch's classification for diverticulitis. Very important. So over here, I think it has been asked a feculent peritonitis. No? So feculent peritonitis is kind of Hinch's type 4. Okay, I hope you have understood this particular point. Got it? Okay, so that is about the diverticulosis and the diverticulitis. This I'll cover tomorrow, because this will be like, not tomorrow, in the next session on the 8th, when I'll cover this particular question over there. And similarly, the sutures, many times the students have asked me to cover the sutures in detail. So because of the lack of time, I had kind of planned it to cover today, but what I'll do, I'll cover this particular stuff tomorrow, or like on the next session. So today is whatever 5th, on the 8th I'm going to cover. Okay, on the 8th I'm going to cover these particular stuff. Okay, now this is important. A 32-year-old female undergoes an emergency laparotomy for a perforation peritonitis. What is the surest sign of the wound dehiscence? Okay, what is the surest sign of the wound dehiscence? Yeah, what is the surest sign of the wound dehiscence, guys? Can you please help me with this? What is the surest sign of the wound dehiscence? Copious serosanguinous discharge, rebound tenderness, hemorrhage, or the hypertension. What is the answer? Yes, it is copious serosanguinous discharge. Okay, so whenever you perform a laparotomy, so what you need to understand is that you close the layers of the abdomen in a sequential manner. So what you do is you kind of close the inner sheath, then you close the muscle, then you close the outer sheath, then you close the subcutaneous tissue, and then you close the skin and everything. You understand my point? So all the layers of the abdomen are closed. So when, if at all, okay, if at all there is a breach, or let's say the defect in the sheath of abdomen after the surgery, like in the kind of recovery period, this is what is referred to as your wound dehiscence. Are you understanding my point? So this is what is referred to as your wound dehiscence or burst abdomen. Okay, wound dehiscence or burst abdomen. Okay, so this is what is referred to as your wound dehiscence or the burst abdomen. I hope you're able to understand this particular point. This is what is called as a wound dehiscence or the burst abdomen. Okay. Yeah. Okay. Right. Now what you need to understand over here, what is the cause of this? Okay. So if I just ask you, what is the cause? What is the cause of this? So cause can be many things. So it can be either a local factor. What are the local factors? So let's say if at all there is ischemia. Let's say there is what you call as a foreign body. Okay, so all these particular things can be there. Or what can happen, there is something which is called as okay, so there can be patient related factors. So what are the patient related factors? Patient related factors means that, you know, that means that there is what you call as, let's say the patient is having a chronic cough. Okay, let's say the patient is having COPD. Okay, so that can be there. So because of the chronic cough, what is going to happen? There's an increase in the intra-abdominal pressure, which can kind of lead to the giveaway of this. Or what can happen? It can be the surgeon related factors. Okay, it can be a surgery related factor. So surgery related factors. It means that the kind of the surgeon did not kind of did a good job. Okay, so there is a kind of a suturing problem. Like the suturing was not done kind of in a good manner. You understand my point? So these are the three things which can happen. These are the causes of your burst abdomen. Now the characteristic history which they will ask you is that what is the time of presentation? So please try to understand this particular burst abdomen. It is going to present on post-operative day. What? It is going to present on the post-operative day 5 to 7. Do not forget about this, guys. Very, very important. What is the day at which the burst abdomen usually presents? Post-operative day 5 to 7. And how will you come to know whether the patient is having this particular burst abdomen or not, or something like that? So what you need to understand, the characteristic history which they will give you is that, let's say if at all there is a whatever the surgeon, or let's say the first year resident or something like that, and they were doing the dressing. Of the post laparotomy wound. And what happened was a copious amount. What do you understand by the copious amount of sero or the serous discharge came out. Are you understanding my point? Copious amount. Copious means large amount of the serous discharge basically came out. So this is what is referred to as your Salmon sign. Okay, what is it called as a? It is called as a Salmon sign. What is the Salmon sign? Salmon sign is a condition where there's a large amount of the copious discharge which is basically going to come out on post-operative 5 to 7. These are the two things which you really, really need to understand. So this particular thing is the surest sign. This is the surest sign of the burst abdomen. Are you understanding my point? So the two things which you cannot forget over here is surest sign. What is copious amount of the seropurulent discharge coming out on the post-operative 5 to 7. This is what is a burst abdomen. And yeah, that is, I hope you have understood why this is happening. Now, what about the management? If at all there is a patient with a burst abdomen, how are you going to manage it? The management is re-exploration. Okay, what is the management? It is re-exploration. Okay, so the management of this particular patient is re-exploration. You have to kind of re-explore and you have to kind of take the stitches whatever you want. Okay, I hope you are able to understand this particular point. Okay, everybody understood this? Okay, let's move on to the next question. Okay, so a 37-year-old kind of a patient presented with a road traffic accident and was brought to the emergency room. The pulse rate was 120 per minute and systolic blood pressure was less than 80 millimeters of mercury. The patient's condition deteriorated, blah blah blah. BT was giving and there was a ongoing profuse bleeding from the liver. Name the procedure which has been performed over here. What is it? It is Pringles maneuver. Okay, what is this? This is a Pringles maneuver. Great. What is this Pringles maneuver? What exactly do you do in this particular Pringles maneuver? Okay, so here the whole kind of bottom line of this particular question was that, you know what, there's a patient who is hemodynamically unstable. That is the first thing. Second thing was that there is a patient who is having a profuse bleeding from the liver, and you have to kind of what you will do. So what you will do is you will perform a Pringles maneuver. So what is this Pringles maneuver? Okay, so in the Pringles maneuver, what you're basically doing is, so I'll just kind of cover this with you guys. Okay, just cover this with you. So what you're basically doing in this particular Pringles maneuver is that you are just 1 minute. So what are you doing in this particular Pringles maneuver? What are you doing? So in the Pringles maneuver, what you're doing is that there is a ligament between the liver and the duodenum. Okay, so you have liver, you have a duodenum. So there is a ligament between this. So can we call it as a hepatico-duodenal ligament? Will you allow me to call this? Yep. Can we call that, right? So yes, we can definitely call this as a hepatico-duodenal ligament. Now, if I ask you, what is the content of this particular hepatico-duodenal ligament? What is present inside this? So over here, what we have is a hepatic artery, portal vein, and bile duct. So this is what is the content of this hepatico-duodenal ligament. Are you understanding my point? Right? Everybody understood this point? Now, if I talk about the liver, okay, so let's say if at all you have a liver, what are the blood supply to this particular liver? So what you need to understand is that hepatic artery is kind of bringing the blood to the liver. Portal vein is also kind of bringing the blood to the liver, and the vein is being drained by the hepatic vein. So these are the three vessels which are in kind of relation with this particular liver. Okay, I hope you're able to understand this particular point. So okay, so this is what is the hepatico-duodenal ligament. Now in the Pringles maneuver, what you're doing in the Pringles maneuver, what you're doing, you compress the hepatico-duodenal ligament. What you do, you compress the hepatico-duodenal ligament. So if at all you are compressing this particular hepatico-duodenal ligament, what is ultimately happening? Ultimately, you are basically occluding. Occluding what all? So you are occluding hepatic artery, portal vein, and bile duct. Okay, are you understanding my point? This is what is a Pringles maneuver. Now, what is the use of this in the liver trauma? So let's say if at all there is a patient who is having a liver trauma. Okay, so let's say there is a patient who is having a liver trauma and the patient is having the bleeding. The patient is suffering from bleeding. Now, if at all you come and you perform the Pringles maneuver, okay, so you came and you opened the abdomen, and then what you did, you performed the Pringles maneuver. So if at all you perform Pringles maneuver, what you need to understand over here, after this, you check for the bleeding. If at all this particular bleeding, it stops. If at all this particular bleeding stops, what does it signify? That the source of the bleeding was, the source of the bleeding was the hepatic artery or the portal vein. Yes or no? Obviously बात है ना. If at all you compress this particular hepatic-arterial ligament and if at all the bleeding has stopped, it means that the source of the bleeding, it was coming basically from the hepatic artery or the portal. But if at all you kind of perform this particular maneuver and if the bleeding continues, okay, if at all the bleeding continues, what does it signify? It signifies that the source of the bleeding is hepatic vein. Okay, so source of the bleeding is a hepatic vein. Are you understand my point? So this is an importance of a Pringles maneuver in the patients with the liver trauma. Okay, I hope you have understood this particular point. So this particular kind of maneuver is a Pringles maneuver. Why are you performing it? Because you want to kind of control the bleeding, and because the source of the bleeding, if at all that is a hepatic artery or the portal vein, then the bleeding is going to stop if when you perform this particular maneuver. Now, what is the Scatterbrash maneuver and the Mattox maneuver? These are the maneuvers if at all you want to reach to the retroperitoneum. Retroperitoneum. Okay, so let's say if at all there is an injury in the aorta or let's say in the kidney or something like that, so you have to kind of reach to the retroperitoneum, right? So how are you going to kind of reach it? So in the Mattox maneuver, what you do is you put an incision on this white line of Tolt. Okay, white line of Tolt. What is this? This is basically an avascular plane. So you put an incision on this particular avascular plane, and then what you need to understand is that you rotate the intestines medially. Are you understanding my point? So when you kind of do it on the left side, that is what is called as a Mattox maneuver. Okay, so when you perform this particular maneuver, I hope you're able to appreciate. Now you're able to reach to this particular kidney and the aorta and everything, right? Because when you enter into the abdomen, all you're basically seeing is this particular small intestine. But when you perform this particular Mattox maneuver, now you are able to kind of gain access to the kidney and the aorta and other stuff and everything. Okay, so this is what is called as the Mattox maneuver. So what is in Mattox maneuver? This is what is a left. Okay, so this is what is a left medial rotation of the bowel. Okay, so this is the left medial rotation of the bowel. This is what is the Mattox maneuver. What about the Scatterbrash maneuver? This is the right medial rotation. Okay, so what is this? This is what is a Scatterbrash maneuver. So this is what is your right medial rotation. What is this? This is what is a right medial rotation of the intestine. Okay, so the way I asked the students to kind of remember it is by the class representative, CR. Okay, so it's very simple, nothing major about this. We all know what is a CR, class representative. So class representative means that the Scatterbrash is the right side medial rotation. Mattox maneuver becomes the opposite of it. That is what is a left side medial rotation. Okay, so if at all you are kind of having some difficulty in kind of remembering what is right, what is left, you can follow this class representative, CR. It means that Scatterbrash is the right side medial rotation and Mattox is the left side medial rotation. Okay, I hope you have understood this particular point. So these are the maneuvers which you have to kind of perform. Okay, now the next question which we have is this. Okay, so what is this? Most common mediastinal tumor is what? Okay, what is the most common mediastinal tumor? Is it like the neurogenic tumor, thymoma, lymphoma, or the bronchogenic cyst? Okay, so what is the most common mediastinal tumor over here, guys? The answer over here is, anybody? Yep, anybody guys? B. Yes, thymoma, guys. Okay, so this basically constitutes around 23% of all the mediastinal tumors. Okay, it constitutes to 23% of all the mediastinal tumors. Okay, so thymoma. Okay, so thymoma is associated with what? Thymoma is associated with myasthenia gravis. Myasthenia gravis. So in these particular patients, you have to kind of resect this. Okay, you have to kind of remove this particular thymoma. This is going to help in kind of recovery of these particular patients of the myasthenia gravis. Okay, I hope you are able to understand this particular. Yes, okay. Now, if I ask you which is the most common tumor of the posterior mediastinum, then what is going to be the answer? Neurogenic tumors, guys. Okay, so neurogenic tumors are the most common in the posterior mediastinum. Okay, in the posterior mediastinum, it is the what you call as here this. Okay, I hope you're able to understand. Okay, got it. Okay, guys, so that was pretty much about the session which I wish to kind of cover today. I hope you gained something out of it, guys. Okay, now I'll just talk to you for a couple of minutes and then I will kind of take a break. So just stay with me for a couple of minutes. Okay, so what you need to understand, guys, okay, so obviously these particular things I'm just trying to help you revise stuff and everything. So what you need to do is, no matter what you're preparing for, let's say the NEET PG or FMG or something like that, if you're preparing for the NEET PG session, then what you need to understand is that, yeah, you have to kind of be on your toes because now the exams are very, very near and you have to kind of just revise most of the things. So by the 15th or 16th or maybe let's say 18th max, your revision, proper revision should get over, and in the last 4 to 5 days you have to kind of read things like whatever the nitty-bitty things or whatever the classification systems or whatever you kind of tend to forget, you have to kind of revise in the last couple of days or something like that. Again, I will say, many people will say, people will keep on giving you advices. What resonates with you is something what you have to kind of take away with you. Okay, that is the first point. Second point, which I definitely want you to understand, is that you have to kind of let go of your fear, because if you are backed down by your fear, if you're backed down by the anxiety, if you're kind of constantly thinking that, you know what, whether I will secure this particular rank or not, whether I will get this particular seat or not, whether I will get this particular branch or not, it's already my second attempt or third attempt or my first attempt or XYZ. You understand my point? If at all these kind of thoughts keep on kind of moving in your brain, that is not going to help you at all. Okay, that is counterproductive. Some amount of anxiety is still okay, but a lot of anxiety is going to be a lot of counterproductive. So don't do that, and just at the back, what's going to happen? You're not going to get selected. What's the big deal in that? Anyways, if you are into this particular zone of hyper anxiety and everything, anyways, you're not going to get selected. You understand my point? So just let go of that particular fear, be fearless, kind of revise the best you can. And sometimes what happens, the things become so painful that we want to just be done with it. We are like, yeah, just exam leke khatam karo bhai, bahut ho gaya abhi. Okay, so don't be into that particular zone. You have decent amount of time, 15-20 days you still have. Use it to your fullest, use it in a proper manner, and don't waste your time. Okay, you are not robots. I understand that you will not be able to read for 20 years for the next 20 days or something like that. I understand that. But whatever the time zone you are trying to read, just read. Okay, so don't be like, you know, you will not do it voluntarily, but involuntarily you might end up into, let's say, the scrolling kind of mania and hyper thinking and thinking about worst possible kind of places and all those particular things. Don't go into that. The best way to avoid it is self introspection. Towards the end of the day, talk to yourself and try to be a better version of yourself every day. So these are the things. Go back to your support systems, your parents, your friends, your brother, sister, whatever is your safe haven. Just go back to them. Just take some amount of the strength and efforts, like warmth and the comfort from them, and just get back to the studies and give your 100% in the next 20 days. That is very, very important, because if you don't revise in these 20 days, I'm pretty sure that at least 5 to 10 questions you are going to miss in the last kind of an exam. Okay, that is the first thing. When you come to the exam, you have to be focused. I mean that. What do I mean by that? So what do you mean by, so let's say if at all you have 300 questions, right? So what you need to understand, you don't have to be backed down upon. For example, first 5 questions came and you were not able to kind of answer them. It was very difficult questions or something like that. When you're on the 6th question, you don't have to think about the first 5 questions or something like that, because if you give your 100% to the every question, that is the only way you will be able to give your 100% to this particular exam, and ultimately you will reduce the number of silly mistakes. You will never ever be able to make it zero, never ever. Okay, but if at all you give your 100%, like 100% means obviously you want to give your 100%. How do you kind of give that? When you're on the question, just think about that. Don't go kind of here there. We saw one particular question today, right? SMS syndrome. It was a knee-jerk answer. Like many people kind of made it wrong. Why? Because what you need to understand is, in the exam also you feel that, you know, let's go ahead, because there are many questions which I have left. I want the time at the last so that I can go back and I can review that. It's okay. You gave enough time to it. Now give your adequate amount of time what is needed to it. I'm not trying to say that, you know, be very slow in solving or anything like that, but whatever the due diligent time is needed for that particular question, please do give that. That is very, very important. Okay, so by doing this, you will end up giving 100% of the question paper, and yeah, the silly mistakes will be reduced. They will never ever go to zero. It's might sound very silly. I mean, obviously it sounds so logical, right? But when you are in the exam, you might not follow this. Okay, so just train yourself to kind of follow this in one particular manner. Okay, so I don't want to bombard with you with any particular advice and all this particular stuff, because already there are too much of information which is in and around you. So just be yourself, just stay calm, just get back to yourself. Don't waste your time. Be true to yourself, do self introspection, yeah, just enjoy, just try to revise the maximum you can, and when you go and the last day, just mark whatever you can. Okay, and the similar advice basically holds true for FMG as well, but they have, let's say, 2 weeks more. That's fine, but yeah, similar kind of thing. So it really doesn't matter. Somebody also said that, you know what, the questions are also very similar, the NEET PG and FMG. Yes, actually. So in the FMG, the only thing is they have to kind of reach to the mark of the 50% pass and fail, but in the NEET PG, there's a relative marking. You understand my point? So you have to kind of perform better than the others. As far as the preparation is concerned, as far as the paper is concerned, there's not a much difference between the FMG and the NEET PG and something like that. But the only difference is in the FMG, they just have to kind of clear the 50%. But in the NEET PG, you have to perform better as compared to your peers. So that is a basic difference. The concepts are the same, the paper is the same, the questions are very similar. Okay, so that's pretty much it, guys. I will just wrap it up for now and see you on 8th. So today we had a session. On 8th also we'll have a session from, let's say, around 8 o'clock. Might kind of shift it to 7, just stay tuned. But yeah, at this point it is kind of scheduled at 8 p.m. Yeah, so I hope it kind of you like this particular session, something like that. See you around. Dr. Pawan signing off. Have a great day. Happy studying. Bye bye.